World Congress of Dermatology to Riyadh would be a powerful symbol of how far we have come and how much more we can achieve together. It would create unmatched opportunities for global collaboration, groundbreaking research exchange, and the advancement of dermatology in our region. Let us stand united behind Riyadh 2031, demonstrate to the world what our community is capable of, and let us set the tone for the future. Let us be bold in our ambitions, generous in our collaborations, and relentless in our pursuit of excellence. Thank you again to all the organizers, the speakers, the participants, and every individual who made this first edition possible. I really wish you an inspiring conference filled with meaningful dialogue, new ideas, and lasting partnerships. Thank you again, and I look forward to joining you in person at the future ADAM gatherings and hopefully welcoming the world to Riyadh in 2031.
Assalamu alaikum wa rahmatullahi wa barakatuh. Distinguished guests, esteemed colleagues, it is my absolute pleasure and honor to welcome you to ADAM Annual Conference, a gathering that will be a cornerstone for advancing dermatology, elevating clinical practice, and shaping the future of our field. Today, we come together not only to share knowledge, but to spark new ideas, build collaborations, and reaffirm our commitments to excellence in patient care. ADAM Academy was founded on a simple yet powerful belief: education transforms outcome. And the Academy activities, including this conference, will stand as a testament to that mission. I would like to express my sincere gratitude to our speakers, partners, and the organizing teams whose hard work has made this event possible, and to each one of you attending today. Thank you for investing your time, your energy, and your expertise in moving our field forward. I would also like to extend deep appreciation to the founder and president of ADAM Academy, Dr. Ahmed Al-Isa. His vision, determination, and belief in the power of continuous learning are the foundation upon which this academy stands. And to my friend and colleague, Dr. Adan Al-Isa, the head of scientific committee, her meticulous standards, thoughtful planning, and unwavering commitment to academic excellence are reflected in every detail in this agenda. Thank you again, and welcome all to ADAM Annual Conference.
Good morning, ladies and gentlemen. It's my great honor to welcome you all to the opening of this exceptional scientific program. As the head of the scientific committee, I'm proud to present a dynamic and enriched program thoughtfully created to bring the best of dermatology and aesthetics to the forefront. Our agenda includes a wide range of lectures covering both clinical and aesthetics, addressing real-world challenges and innovations. You will hear from renowned national and international speakers, each bringing unique expertise and insight. We are also excited to offer interactive workshops designed to enhance your practical skills and deepen your understanding of cutting-edge techniques. I encourage you not to miss our unique sessions, including the future of drug discovery, emotional intelligence, the business and ethics in dermatology, and فن الإقناع في بيئة العمل. I would like to take this opportunity to thank the advisory committee and the scientific committee for their dedication, collaboration, and hard work in shaping this program. I would also not forget our partners, pharma and industry, for being part of this success. Thank you for being part of this journey. Let's learn, connect, and elevate our practice together. And now allow me to introduce the first session and our chairpersons, Dr. Saad Al-Talhab, Dr. Ahmed Al-Isa, and Dr. Fatim Bukhari. Please welcome to the stage.
صباح الخير على الجميع. Good morning everyone. So it's our pleasure to start the scientific activity with the session of laser science and beyond, the future of energy-based therapies. And we'll start with Dr. Ali Al-Ajmi with a lecture about From Concept to Clinic, the Science of Laser in Dermatologic Procedures. Dr. Ali, go ahead.
Assalamu alaikum. Good morning, everyone. I would like to congratulate the scientific committee, the head of this conference, for the successful meeting even before starting. Thank you, Dr. Ahmed Al-Isa, Dr. Arwa Al-Harqi, and Dr. Adan Al-Isa. So I will be talking about the theoretical part, but in a practical way, and I'm going to share some cases from Kuwait. Okay, so I was told it's a 15-minute, and it's going to end suddenly, and my lecture is almost 20 minutes, so buckle up. I'm going to go very fast. I'm so sorry. So this is my outline. I will be talking about the safety of lasers, and then I'm going to share my favorite tool that I use in my laser clinic every day, and then some cases from my practice in Kuwait. Okay? So before I start the lecture, I want to share one of my favorite quotes by Imam al-Shafi'i, who's actually studied here in Al-Madinah, the greatest university and the greatest school in Al-Haram al-Madani more than 1,000 years ago. He said, "My opinion is right, but probably could be wrong. And the opinion of others is wrong, but could be right." I love this quote because of two reasons. First reason, I like how the mentality of open-minded mentality, we have it more than 1,000 years ago. And the second reason is because we face this every single day in dermatology. Diagnosing is really dynamic because the rash is very dynamic and evolving. What appears non-specific and atypical at a certain point of time, it might evolve to a textbook presentation after a few days or weeks. So dermatology, we have to understand that dermatology is really difficult. Sometimes you think you're right, but it's okay. You could be wrong. Okay, we have to be have this open-minded for accepting, being wrong. And the second reason, in dermatology, we have only 9 primary morphological lesions. Okay, and Out of those 9, according to the European Academy of Dermatology, we have more than 3,000 skin diseases. That's why dermatology is really tough, and we need to accept that we might get hard cases and we might miss the diagnosis. Nobody is immune for missing the diagnosis, okay? So 3 messages from this slide. Nobody is immune for missing the diagnosis, okay? Be kind to yourself and your colleagues and understand the limitation of our specialty. Okay, so how to play it safe with lasers? The most important thing here is do not copy laser settings from others, not even from the papers or journals. We need to tailor the settings based on 2 things: pathology characteristics, okay, and the patient characteristics. Pathology characteristics, you're talking about what is the chromophore? You have to ask yourself, what is your chromophore? And then how big is the chromophore? Because the size of the chromophore, based on the size, you're gonna tailor the pulse duration. Big chromophores, like blood vessels or hair, you need long pulse duration in the millisecond domain. Smaller chromophores, like tattoo, you need short pulse duration, okay? And then where is and how deep is your target? Also, this is important. Patient characteristics, where is the lesion? Where is the location of the lesion? Is it in the neck? Is it on the face? In the back? The skin thickness is different, even in the face. Thickness of the cheek different than the forehead and the eyelid, okay? Also, be careful. Sometimes the same laser from the same company with the same wavelength and parameters, you can have different output, okay? And this is related to calibration and the maintenance. Okay, so you have this situation or scenario a lot. The laser rep from a laser company, we love them, we respect them a lot. But sometimes they will tell you this is the right setting for the Fitzpatrick skin type, okay? Fitzpatrick scale is really good, we use it a lot, but it can be really unpredictable with lasers because it was not made for lasers, okay? It was made for phototherapy with a standardized dose. We know the minimal erythematous dose of the UVA and UVB, but what is the minimal erythematous dose of laser? Let's say in Diag, long pulse versus short pulse, Q-switch or Pico. It's impossible to know the minimal erythematous dose of the laser. That's why Fitzpatrick, don't depend on Fitzpatrick a lot, okay? Many lasers in the market. You will see the companies promoting 5-in-1, 10-in-1. Same laser can treat tattoo and hair removal at the same time. Different pulse duration domain, but the physics, the foundation is fixed and it's one and we know it. I think sometimes too much confidence can be an indication or red flag of lack of knowledge. And this is not just me. This is actually described by Dunning-Kruger theory, which is a Nobel Prize psychology research, showing that if you know nothing, the confidence will be more than 100, almost 100. Okay? With more knowledge and experience, the confidence will go down. And then with more experience and research, you're going to have you will reach this level of confidence, which is a healthy level. Okay, you're not going to go 100%. This is the red flag. You have to have this mentality of being open to new ideas and new approaches. Okay. So I found this. To me, it's really a scary video on Instagram. Promoting a device, saying it's the best in the world. Too much confidence, right? I like the energy, and then he started to shoot the laser in the middle of the convention center. You know, people walking around, no goggles, nothing. You know, too much confidence. Definitely, there is a lack of knowledge here. Okay, so instead of copying settings, you need to follow the endpoints. And what are the therapeutic endpoints? This is a landmark study by Rox Anderson group, talking about all the therapeutic endpoint that you need to look and to achieve during using all types of lasers. For vascular lasers, your endpoint is the purpura. And also if there is a telangiectasia, disappearing of the vessel, this is one of the endpoints. For laser hair removal, you have to see the perifollicular erythema and edema, sometimes urticaria. If you didn't see that, most probably you're not going to have good results. For fractional lasers, you have to see this white dots, which is a coagulated epidermis. Okay, and for pigmented lesions, you need to see this white frosting, not too white, okay, just a moderate white. So those are the good points. What are the bad endpoints that if you had during the procedure, you need to stop? Many bad endpoints. You have Nikolsky sign, burns, cryiasis, and many other, etc. Okay, so this is a burn, a Nikolsky sign after using non-ablative fraction laser. Definitely here you need to stop. You're either doing too much high settings or too much passes. Here, this is a burn after using Alex for port wine stain. Again, here also, this is the metallic gray blanch. That means there's a necrosis and you have to stop. Alex and Nd:YAG long pulse can be used for resistant and thick port wine stain because it's too deep and PDL cannot reach it. But why we have this risk? Why there's a burning and scarring more than PDL and KTP? This is related to the absorption curve of hemoglobin. We have two peaks. We have the high peak, KTP and PDL, where just 5 joule, 10 joule, that's enough to destroy the hemoglobin, because if you see the absorption coefficient is almost 1,000, okay, here. So very, very little energy will destroy, will give you the good endpoint and you'll have good results. But if you see the low peaks here for the Alex and Nd:YAG, it's 100 times weaker. Look how. So here, selective photothermolysis theory is not very well respected because absorption is weak. You need to increase the energy. If you look at the literature for Nd:YAG and Alex, the average is like 100 joule. PDL is like 5 joule is the average. Here is 100 joule. You need to compensate for the weakness of absorption of hemoglobin. And this will narrow your safety window, and that's why you have scars. This is atrophic scar after treating of veins on the forehead with Nd:YAG. Okay, so done with the endpoint. The last part of safety, you need to know the basic science, but in a very practical way. You don't have to go deep. We're not, engineers, but we know the skin-laser interaction better than the engineers. Okay, so selective photothermolysis, basically you need to match your parameters, your settings with your chromophore to destroy your target and to spare the surrounding. That's it. Matching the chromophore with the setting. This is selective photothermolysis. So if you match your, so you have the chromophores, and then you need to match it with your wavelength, okay? This is the first thing. And then you need to match the chromophore diameter with the pulse duration, okay? Bigger target like hair follicle or blood vessels, you need to increase the pulse duration to heat it up. It will take time. Smaller target like tattoo, you need to have shorter pulse duration because it's very small. It can heat up quickly and it will lose the heat very quickly also. You don't want to have the heat to dissipate to the surroundings, okay? And then very important term in laser is the thermal relaxation time, okay? This is a fixed number. This is from God. Every chromophore has a fixed thermal relaxation time. Hair follicle, usually longer, within a millisecond. We play with the pulse duration, okay? So, big target, they have longer thermal relaxation time. That's why you need to use longer pulse duration. It should be equal or less than thermal relaxation time to avoid having complication and dissipation of the heat to the surroundings, okay? I'll try to go faster. I have just 5 minutes. So pulse duration is like in the microwave. You play with this, with the time of heat. If it's small, you have to do it shorter. If it's big, you have to heat longer. Okay. What happens if you choose the wrong pulse duration? So try to remove hair follicle, hair with a pico laser. Nothing gonna happen. But try to remove tattoo with a long pulse duration laser. You're gonna burn the skin. Okay. So what's my favorite tool? This is really, I can't work honestly in my laser clinic without this. This is a cross-polarized filter. It will help you see the surface and the subsurface clear without any reflection or glares. Okay, as you can see, the blood vessels are very clear. You can target them with the lasers. Here again, not just blood vessel, even the pigmentation. And here you see the end point clearly. You don't have, sometimes we remove the goggle to see the end point, and then we put it, this is dangerous. So with this filter, the cross-polarized filter, you don't have to do this removing the goggle, okay? Not just for accuracy, also to diagnose. This is, if you see, it's non-specific lentigo. But with the cross-polarized light, you see it has multiple colors. This is lentigo maligna melanoma. Also, this is impossible to see this pigmented lesion inside the tattoo. This is melanoma in situ. If you want to read more about it, it's in the JDD journal. There's a paper about it. So, a few cases. I have 4 minutes and I have 5 cases, so we'll go very quickly. Atrophic scar and hypertrophic with some vascular component, okay, and hypo or white scar, hypopigmentation. This is the hardest scar to be treated. Always, it's hard to challenge, and it's very challenging to treat hypopigmented scar. He had a motorcycle accident. He's 16 years old. So this is after 4 sessions. I did PDL because there was a vascular component, and then I did CO2 fractional. For this patient, I did high density because I want to stimulate some collagen, and I want to stimulate some pigmentation. Okay, usually density, we don't go high with the density because more density, more complications. But here I used it, and then I used only 5-FU because of the hypopigmentation, because of the atrophy. Kinacort, it can aggravate that, but it's not going to happen with 5-FU. This is according to the literature. So this is before and after 4 sessions. So here in this study, they compared 5-FU with after fractional versus triamcinolone after fractional, and they found out with 5-FU, you don't see, you have the same efficacy. It's as effective as cortisone, the 5-FU, but without the atrophy, without the telangiectasia, without the hypopigmentation. This is the second case, port wine stain. She's 7 years old, never been treated, started school, and kids start to bully her. So I did 2 sessions and very good results. Usually with port wine stain, it takes longer. The key here, you need to do purpuric setting, and you need to increase the spot size, okay, for better penetration. Don't do 7 or 10, do 12 or even more, or 15 millimeter. And according to the study, if you increase the spot size 15 millimeter, it can cut the sessions up to the half, okay, versus 12 millimeter. Case number 3, 80 years old with multiple comorbidity, dialysis, chronic ulcer, painful for more than a year, not responding to wound care antibiotics. I did 1 session of fractional CO2, superficial and deep, and this is after 2 weeks, this is after 4 weeks, and then after 8 weeks, I saw really good result. The rationale here, the wound here is stuck in the chronic environment. With the laser, you shift to the acute environment. You eliminate the biofilms, and this will facilitate healing. Okay, many cases, many case reports and studies about using CO2 laser, erbium YAG, fraction lasers to treat the ulcers. This is alopecia areata. She's 16 years old on Olumiant for 2 years. Improved except this patch that's not responding to Kinacort injection or minoxidil. I did fractional CO2 1 session. This is after 8 weeks. There's good response, and then I did another session. So as you can see here, it's improving. And then I did another session here within 4 months, cleared. And this is I was inspired by this paper. They use fractional CO2 laser with minoxidil. I have only 40 seconds. So this is the last case, systemic sclerosis, having microstomia, and she cannot go to the dentist. It's very painful to open the mouth. I did fractional CO2, and then I did hyaluronidase topically, laser-assisted drug delivery, and improved after 2 sessions, almost half centimeter horizontally and vertically. There are many papers, injection hyaluronidase, but it's very, very painful. Okay, and there's studies about using CO2. I combined CO2 fractional with topical hyaluronidase. Before concluding my talk, I would like to invite you all to Kuwait Derma in 12, 13, 14 of February 2026. In February, the weather in Kuwait is amazing, okay, and it's during the Hala Febrayer festival. So please join us in this conference, and all the best. We wish them the best of luck, our brothers and sisters in Saudi for the World Congress. And by that, I conclude my talk. Thank you so much.
Thank you, Dr. Ali, and safe trip He's leaving actually after 1 hour, right? And I would welcome Dr. Muhammad Rashid to the stage. He will present lectures about lasers in the treatment of difficult wounds and scars.
السلام عليكم. شكرا على اللي عمله أحمد على العزومة. أشكرك كثير كثير كثير. Now I will talk about lasers and practical patient, difficult patient refused by all. You will see that I present some cases in different congress. Here I will not talk about acne scars. For example, most doctors love this. Easy patients. I will talk about difficult patients oriented or refused by doctor. With scars, just read and then write. Before doing anything, شوف, read the scar and then act. First patient, this one. I will not ask you about laser. I do laser. I did fractional laser. Which one? Ablative or non-ablative? I did ablative, but I combine. What I combine? You can, when you see that the scar is red and depressive. When the scar is red and depressive, you have to combine these two techniques. Fluence mean to be deep. Time mean to be hot. Hot, every red scar, you need more time. Every depressive scar, you need more fluence. So here I combine the two techniques, the two parameters. It's red and deep. So I combine the two, fractional ablative and longer time. After 7 sessions, the patient told me, I want more. قلت له الحمد لله كله تمام. He told me, I want more. So I combine other techniques. And then I did vascular also, and you can see the result after 11 sessions, around 1 year of treatment. This is the first case. I have 7 cases. I want to be quick because I want to share with you all the cases. Rhinophyma with diabetes, hypertension. I did erbium-YAG continuous with surgical handpiece, and on 1 session, all these patients, I use only topical anesthesia, crema, anesthesia with crema. And then a few weeks after, and around 1 month after, 1 session with surgical handpiece erbium-YAG, 1 session. Another case, localized rhinophyma, 1 session, same parameters, 1 session, 1 month after. And then, difficult case. This girl, 14 years old, عملوا حادث مرور في الطريق والأسفلت لصق في الوجه، كان وجهها يخبط في الطريق. I proposed it in IMCAS 2022. All the doctors told me, do Q-switch or PICO. Yes, of course, but not at the beginning. ليش؟ الأسفلت لما يسخن يدوب. لما راح يدوب, you will have more burns. So I did ablative surgical laser with erbium-YAG. Why erbium-YAG? Erbium-YAG is colder than the CO2. So I did surgical ablative action, layer after layer. And when you see the pigment, the target were here, deeper. So here I did the PICO. I did ablative action, and then I add the pico because it was so deeper. And then after 2 years, you see the deformation here. I don't know if, yes, perfect. Here, you can see I cut this with continuous handpiece, no surgery. The girl refused the surgery, so I cut it with the erbium YAG. I cut. So the deformation became better. And then I start here to use fractional CO2. Ablative but cold. Why cold? I use 0.3 millisecond. More than 1 millisecond, you are hot. Less than 1 millisecond, you are not hot. Why I use 0.3 millisecond? Because of the phototype. The PIH, you got it when you use more time. The PIH, you have it when you use time, longer time. Don't worry about what's, worry about time. لما تأخذ غلاية تأخذها 5 دقائق هنا وساعة هنا اللي تحرق تاع الساعة ما بتاع ال5 دقائق. So the time is very important. Use less time to have less burn. And then after 2 years, you can see the result. This girl, 21 years old, with a congenital nevus of the hemiphase. The MRI, you can see the lymphatic malformation here. She was very fearful and in deep depression. I did laser. I did a test. Don't after to do a test. ما تخاف تعمل test. Refused by any جراح ما يعملها الجراح. ما بتقدر تعملها. تسكن بفرنسا. ولا واحد قبلها. I did laser. I did test. But which laser? Q-switch, pico, continuous laser, fractional laser. I did ablative test with erbium YAG. خديت هذا المكان with topical anesthesia, and you can see the result 1 month after. وتشوف هنا the smile return. لأنه في دهنها من كم سنة ما في حل. ما في حل. Just topical anesthesia. You can see the result. هنا we can add vascular laser, fractional laser, hair removal, pigmented laser. So خديت وعملت كل شيء وما رجعت لي مازال ما شفتها البنت. هذه عملتها من حوالي 3 أشهر حوالي. I did ablative erbium YAG with spot size 4 millimeter. I was ablative. She need more than 3 or 4 sessions. And this one, I told you that's difficult cases that no one wants in his clinic. هذا الشاب 22 سنة جاني من المستشفى عشان fungal infection. I saw that he was tearing and enough sialuria. ليش؟ في رأيكم ليش؟ الشعر كان يدخل في العين ويدخل له في الفم. شو نعمله؟ عملت هير ريموفر. لس ما ولا يدمع ولس sialuria. And I think the last one that I have presented in this ERDV in Paris. هذا شاب مقيم أيضا بفرنسا عمل عملية جراحية من حوالي 8 أشهر ولا 9 أشهر على هذا الكارسينوما، ورجع له في حوالي 8-9 أشهر. He refused surgery. ولا مرة أعمل surgery. So I did laser, continuous laser, with handpiece, surgical handpiece. Only CO2, only CO2. I did only CO2 with surgical handpiece. Few days, few weeks, and you can see the result 3 months after. 1 year after, I got this scar. It's not good. Not good for the scar. And another lesion here. Why? I got this relapse. Why? Usually you know it, Dr. Ahmed. I did only CO2. I did a mistake. Why? I didn't do vascular laser before the session. كان يلزمني أعمل vascular before and directly after surgical CO2. So I did it. But 3 years after, the relapse of CO2 was 3 years after. With surgery, حوالي 9 أشهر, 9 months. So I did NDYAG, 100 millijoules and 40 milliseconds. Why? Why 40 milliseconds? I'm working with, not with photothermolysis. I'm working with photocoagulation. I coagulate the vessels of the BCC. And then I did surgical treatment with the CO2. I present in this EADV that there is many paper that the vascular should be associated, combined with the CO2. Because this vascular laser destroy the vessels of this BCC. There is publication about BCC melanoma. I did some cases about Kaposi disease also. So this one was the last one. I respect the time, perfect. And I did fractional also on the same session, and every 2 weeks I did fractional, ablative fractional 0.5 millisecond. Why? I don't need hot, I need ablative action. And 3 months after you got the result, final result. شكرا. شكرا.
Thank you. Excellent cases. Next speaker, my close friend Shadi Mahmoud from Egypt, and he will talk about fractional laser clinical application. Shadi.
Assalamu alaikum. It's a great pleasure for me to join this amazing Adam, a nice organization. Thank you for inviting me, Dr. Ahmed Al-Isa, Dr. Al-Harsi, Dr. Dana Al-Isa. My topic today will be fractional surgical application of CO2 laser in dermatological practice. I will share with you some tips I have. My objective, explain how to optimize settings of CO2 laser according to indication, identify unconventional use of fractional CO2 laser and surgical hand, and explore more techniques regarding surgical hand of CO2 laser. So what about CO2 laser? It acts at 10,600 nanometer, which is the ablative laser device, because of affinity of water. It shows higher affinity to water compared to other wavelengths like 1550, 1540, and this make differentiate between ablative and non-ablative devices, the affinity of water. because affinity of water can generate more thermal affection on the tissues. How to optimize? Starting with pulse energy, because there is correlation between pulse energy and depth. When you're increasing pulse energy, we will go deeper, and this is something we need in some cases of dermal pathology, something like scarring tissue up to subcutaneous tissue in post-acne scars, stretch mark, or laxity. You have to go deeper, so you have to increase pulse energy. When it comes to pulse duration, it's a cooking time. It's something correlated with diffusion of heat. So in microsecond range regarding CO2 laser, and you can govern ablative and coagulation according to pulse duration as mentioned by Dr. Muhammad. When you're increasing pulse duration more than 1 millisecond, would go to more coagulation associated with ablation. When you decrease duration less than 1 millisecond or 1,000 microsecond, would be pure ablation with little thermal coagulation around microthermal zones. Regarding density, please take care with excessive density, because when you're doing excessive density, something like 15% or 20%, you lose the islands of health tissue around each microthermal zones. Islands of health tissue will guarantee for you re-epithelialization and healing time. So in density less than 10%, you can guarantee faster healing, and we guarantee islands of good health tissue around each microthermal zone. So take care, especially when you're dealing with darker skin type with excessive density, something like 15 or 20%. Regarding stacking, overlapping, or depth level, this all names similar to in different devices we have in market. So please don't doing stacking to doubling or tripling your energy or your duration, because it's something will be aggressive. Please take a stacking option for dividing. Please, I do prefer to use little power, doubling with stack 2, better than megawatt, like 20 watt in single stack. To stack 2 or stack 3 to divide your high energy into sub-pulses, and also duration to sub-pulses in duration to induce some cool down in between sub-pulses and make more safe for your patient, especially when you deal also with darker skin type. Regarding spot size or micro beam size, it's sometimes standard for each device. I do prefer to use a channel size less than 300 micrometer diameter, because it will heal quickly. When you have microthermal zone very small, it will heal quickly, and you ensure your depths to go deeper more than a large diameter of microbeam size, something like 600 micrometer or 1,200 micrometer will be sometimes show slow healing during re-epithelialization. So let's go to indications. We have some standard indication regarding scarring tissue. Sometimes we're dealing with atrophic or hypertrophic scars. In such a case, I do prefer use long pulse duration when you deal with atrophic scar, because in such a case, I want to induce remodeling of collagen. When you deal with hypertrophic scar, I do prefer to use short duration, less than 1 millisecond, to induce more ablation, more than coagulation effect, because sometimes when you deal with hypertrophic scar and keloid, excessive thermal diffusion can induce some keloidal tendency and some instability in some scarring tissue. In such cases, we have atrophic scars, atrophic, soft, lax, sometimes post-acne scars, especially rolling. In such a case, yes, I doing high fluence to go deeper and long duration to induce remodeling of collagen. Another case, post-traumatic scars. In such a case, we have sclerotic or hypertrophic scars and shows pigmentation. I do prefer here to use short duration. Please reduce thermal affection of CO2 laser to avoid any aggravation of this pigmentation or aggravation of thickening of this scar. As well as post-burn scar, because most common in post-burn scar we have hypertrophic scars, especially in this old one. And in such case, I do prefer high fluence to go deeper in second skin, and also short duration to avoid excessive thermal affection, especially when you deal with delicate area or this area shows burn, lose everything could make re-epithelialization, something like hair follicles or sebaceous gland sometimes when you deal with in face. And in the first photo, we have pigmented post-burn scars. I'm doing here just ablation using short duration with less power, because in such a case, I don't do penetration. I don't need any penetration to deep dermis. I just induce cool peel using low power and short duration. When it comes to rejuvenation, sometimes we have cold rejuvenation technique or hot rejuvenation. It depends on indication. Because when you deal with laxity, wrinkles, photo-edge skin, I do prefer to use hot rejuvenation using long pulse duration and high energy to go deeper and to induce more collagen remodeling. Some cases we have just fine lines. Some patients needing to use some glowing effect. In such case, yes, we can do cold rejuvenation using short duration with low energy, but as well as we can induce high density to cover more surface area, especially when you're dealing with face. This is the difference between cold rejuvenation and hot rejuvenation. It's a matter of duration, because short duration will allow occurs before significant heat diffusion. But in long pulse duration will allow more thermal diffusion to induce more coagulation as well as ablation effect. And in here, histopathology, you can see here the rim of coagulation in long pulse duration more than rim of coagulation in the first photo. So cold rejuvenation, yes, we can use very low power, ultra short pulse duration in high density mode to cover more surface area, and no scaring here from high density, because here I used low energy and low pulse duration. And some cases, as you see here, skin type 4, we can use this technique, induce some rejuvenation and the glowing effect, as you see in these cases. Even the same idea I can use for pseudoacanthosis nigricans, as this publication for my colleagues from Zagazig University in Egypt. They used high power, high density, with using short pulse duration to avoid any excessive thermal damage, to just induce cool peel for hyperkeratotic lesions. Also, we can use as a concept of transepidermal elimination. What about transepidermal elimination? It's something to induce microthermal zone deep way into dermis to eliminate some material from dermis, to be sloughed away from the skin. And this is something we need in some cases like macular amyloidosis. And this is my publication. 3 years ago, we published this one to compare the fractional CO2 laser alone and the fractional CO2 laser combined with topical DEMSO to eliminate amyloid protein inside dermis by concept of transepidermal elimination. Some before and after cases from my publication, and this is my publication from my colleague Cairo University, Professor Samia Ismat. As you see here, even with macular amyloidosis and papular amyloidosis, we can use, according to papular or macular, we can use high power and short pulse duration, of course, to eliminate some of amyloid protein. And they evaluated that pruritus could be improved after this technique, meaning that we eliminated some of amyloid protein inside dermis. And the same technique we can use in to decrease shadowing effect after tattoo treatment using Key-switch or picosecond laser, because sometimes we have shadowing effect due to some of tattoo ink deep lying. So in the same technique, we can improve the shadowing effect by combining Key-switch or picosecond with fractional CO2 laser, using high power also to go deeper and short duration to avoid, I don't need here excessive thermal diffusion, and of course high density to eliminate the most of tattoo ink inside dermis. And this photo by me mixing fractional CO2 laser and Key-switch in the same time of session. The on contrary of delivery, yes, we can use fractional resurfacing using assisted epidermal delivery to deliver some materials to go deeper inside dermis to enhance the effect. Like in hypertrophic scar, we can use fractional CO2 laser in low fluence to avoid any excessive thermal diffusion to the keloidal tissue, followed by topical steroid to disrupt the stratum corneum to enhance delivery of any materials you want to go deeper into dermis. The same idea here in atrophic scars. I used here growth factors after fractional C2 laser. You can use growth factors, exosomes, whatever indication. Regarding post-acne erythema, in such a case, I used laser-assisted drug delivery using CO2 laser in low fluence, low duration, followed by topical 5% tranexamic acid, because tranexamic acid can reduce angiogenesis associated with post-acne erythema, especially persistent post-acne erythema. Even with melasma, please low fluence, low duration, low density, just to enhance delivery, your material you wanted to be delivered, something like growth factors to help to bright the melasma lesions. Even with alopecia areata, I think it's mentioned by Dr. Ali. Yes, I can use this my publication, fractional C2 laser followed by topical steroid. Even fractional C2 laser alone can induce Wnt pathway stimulation to enhance hair growth in alopecia areata. With a nail or onychomycosis, the same idea. I can use trans-nail delivery using topical antifungal to enhance delivery or to induce damage to modified stratum corneum to enhance delivery topical antifungal, something like tioconazole. And I published 2 papers about this matter. As you see here, this is my results after 6 sessions or after 6 months regarding fingernail and after 9 months after toenail onychomycosis. When it comes to surgical hand of CO2 laser, it's something like magical tool in your hand. Yes, we can use it regarding different techniques, vaporization or painting technique, excision, coagulation, and even pinpoint technique. Some examples for that, this is for vaporization. Yes, we can induce ablation for seborrheic keratosis, for compound nevi, for xanthelasma, layer by layer, using gauze with gauze to eliminate the carbonized tissue, and after that doing a second layer and third layer to endpoint we targeted. Regarding granulophyma, yes, we can use paint technique to ablate the excessive tissues in one session. Regarding earlobe keloid, it's something difficult to be treated with intravenous steroid alone or cryotherapy. So in such a case, I do prefer to excise and followed by topical intravenous steroid up to 6 months. Every month I'm doing topical intravenous steroid to avoid any recurrence could be occurred after removal. Regarding biogenic granuloma, something shows some vascularity, so I do prefer to doing defocus technique, make a space around 10 to 15 centimeter spacing to induce defocus technique. Defocus technique induce coagulation, just coagulation to coagulate all blood vessels you see here. After that, you can induce ablation without any bleeding tendency. This is my technique in biogenic granuloma. Regarding syringoma, because syringoma has dermal tumor, so it's deep, so it should be reach up to this point by using pinpoint technique. Make a hole inside papule and make 3 or 4 seconds to ensure you reach it up to all dermal tumor to induce shrinkage effect and reduce the syringoma as you see here. The same technique I can do for hydrocystoma till water release. This is my endpoint. The same technique I can use for papular acne scar. It's a dermal fibrosis, periappendigeal fibrosis, by the same technique to induce coagulation to shrink this fibrosis. As you see here, this is my result. And also for most toughest scar I have, which is whitish scarring tissue, it's something very difficult to be treated. So in such case, I'm doing pinpoint technique to reduce this fibrous tissue and to induce some inflammation, could improve the color of whitish, as you see here, and I published it 10 years ago. So to wrap up, fractional C2 laser effectively treats versatile of aesthetic and dermatological indication. As you see here, standard or unconventional. Adjustable path solution is very important to be safe and to reduce risk of PIH. Maximize clinical outcome with surgical hand of C2 laser, as you see here, focused or defocus technique, painting, and pinpoint technique for syringomas and papular post-acne scars. So, thank you.
Thank you, Dr. Shadi, as usual. Very nice presentation. Now it's my pleasure to introduce my friend, Dr. Thamer Al-Mibki. He will talk about the role of fractional PICO technology in aesthetics.
Assalamu alaikum wa rahmatullahi wa barakatuh. I've been told to be close to the microphone. I think it's wise not to do. I am very glad to be here in Al-Madinah Al-Munawwara. It's been a while not visiting this great place. And I would like to thank the organizing committee for having me here and to choose this city of Kingdom of Saudi Arabia. And I have heard that the next Adam will be in Riyadh, for which I encourage my colleagues to change their opinion and to make it happen again here in Al-Madinah. So, having said all about laser, now it's time for Pico laser. Pico is like, it's an amazing laser. Every patient is coming asking to do Pico for multiple indications, either whether successful or not. It's used for pigmentation, it's used for tattoo removal, and now it might be even helpful, as research shows, for rejuvenation. So picosecond laser differs actually fundamentally from nanosecond laser by the pulse duration and also by the mechanism by which the picosecond pulses interact with the tissue and chromophores. Picosecond laser lasts for 1 trillionth of second, while nanosecond laser lasts for only 1 billionth of second, which makes actually the picosecond laser 1,000 times faster than the nanosecond lasers. This high energy that is delivered within an ultra-short time gives a higher peak power, up to 10 times more than that of the nanosecond laser. This will cause tissue to react in an acousto or mechanical effect, not a thermal effect, and this is an important difference between pico laser and nano laser. So lowering the pulse duration has dual effect on intensifying the laser's mechanical shock wave while maintaining minimizing heat diffusion into surrounding tissue, and this comes important in practice. We see less inflammation, less downtime when we use pico laser as compared to the conventional fractional laser or nanosecond laser. This graph shows the difference in the optical absorption characteristics of different pico lasers of different wavelengths, 532, 755, and 1064. Across two different and important chromophores of the skin, melanin and hemoglobin. As you could see that the 532 nanometer picosecond laser has higher affinity for melanin. It absorbs melanin, best absorption of melanin and hemoglobin as compared to the others. And this might carry a higher risk for darkly pigmented individuals, even though it is good for superficial pigmented lesions and superficial vascular structures. However, it might cause depigmentation and hypopigmentation in darker skin tone. 755 nanometer has a balance between good penetration and good affinity to melanin, while 1064 has lowest absorption of melanin, but it actually penetrates deeper, makes it more safe or safest option for darker skin individuals. Clinical use of three different wavelengths in 2 different skin tones shows that the vascular component is at least with 755 nanometer, while 1064 and 532 might tend to develop PTKI and hemorrhage and vascular post-treatment, vascular remedy after post-treatment of the therapy. So it's well known pico is used for elimination of pigment, fragmentation of tattoo, fragmentation of epidermal pigment, but can we use fractional pico as a pico laser as a fractional mode of getting the rejuvenation of skin or not? Before we go into the mechanism of action of pico laser, we need to go to the physical or understand the physical concept of plasma. The physical concept of ionized plasma is important because unlike solid, liquid, and gases, which are the conventional matters, plasma is composed of ionized particles, where high energy in the atoms or high atomed energy will lead to separation of electrons from their nuclei. This will result in a dynamic cloud of ionized particles, and this is how Pico laser uses hyper acoustic shock rather than heat. And this is important when we deal with Pico laser as a fractional wave. Histological evaluation 10 minutes after applying Pico fractional laser into the skin, you can see micro cavitations and micro alteration in the epidermis accompanied by mild inflammatory infiltrate in the dermis. This inflammation will lead to, or transient inflammatory response will lead to stimulation of the collagen remodeling cascade, and will lead, after using the long-term histological evaluation, to increased collagen synthesis and elastin synthesis. So without inducing a collateral damage, because the Pico technology is based on inducing photoacoustic reaction rather than mainly heat reaction. This will eliminate the long downtime, erythema, and even the crust that you see because of the conventional fractional laser affecting the superficial dermis. So using this histopathology shows that the fractional Pico laser can induce new collagenesis and new elastogenesis. This will lead to the use of possibly fractional Pico laser in the area of rejuvenation of skin and improving skin quality. So there are many uses of the fractional handpiece of the Pico laser. We can use it for epidermal pigmentation, dermal pigmentation, skin toning, acne scars, skin rejuvenation, glowing, cosmetic, normal, and normal tattoos, as if known. Can we use 755 nanometer Pico laser in darkly skin types? Yes, we can do, and we can see that when the graph I showed before. Here is a case of Fitzpatrick type 5 with post-inflammatory hyperpigmentation in the forehead. As you could see, the use of both fractional plus the flat handpiece can induce good improvement. However, be careful from defocusing. Defocusing of laser can give depigmentation in that case. Another case of use of laser combined by azotretinoin can give also good results, but be careful with hyperpigmented individuals. You have to have larger spot size, lower fluence. Improvement of body pigmentation is something an expert hand can happen. Improvement of acne scars along with the fractionated conventional laser, we can combine fractional Pico laser, and it can give good results with low downtime. Improvement of pigmentation, actually, surprisingly, it could be an indication with fractional Pico laser. Try it, be careful, it is safe, and you can combine topical also tranexamic acid on top after. Another case of melasma, which is a devastating problem, fractional Pico laser can be used, and it is good to give it a try because I found it safe with minimal side effects and no downtime. Removal of tattoos is a well-known indication. Combining both fractional Pico plus the flat mode Pico is helpful. Melasma in men may be a good idea because nothing works for men when they have melasma. Melasma, also nevus of aorta, can be something done. combining in laser is the key. There are a number of many publications regarding the use of pico laser in the area of dermatology and cosmetics. And, and pico laser, to be honest, is something that is promising. However, we don't need to overestimate the uses. We need to be safe, especially in darker skin type, but I can reassure it's something that we could try in the future. Thank you very much.
Thank you. This is a very interesting session for me, which is laser, but because of the time and we have the prayer and we cannot exceed, we will not allow any question for this session exceptionally. And we can ask Dr. Umar al-Sheikh, Khalid al-Naimi, وأخوي محمد فطاني to come over here to have the next session.
نبدأ يا دكتور محمد. فين في موجود جفري عبد الهادي جفري. بسم الله والصلاة والسلام على رسول الله. أنا سعيد اليوم أنا وزملائي جميعا بالمشاركة في اللقاء العلمي السنوي الأول المقام من قبل أكاديمية آدم. أشكر زميلي الدكتور أحمد العيسى رئيس الأكاديمية، وأشكر زميلتنا الدكتورة رؤى الحارثي والدكتورة دانا العيسى على كل الجهود اللي قاموا بها حتى في ترتيب هذا المؤتمر واللقاء في المؤتمر. المتحدث الأول زميلنا الدكتور جفري عبد الهادي. سيتحدث عن موضوع مهم. he is one of the most active colleagues, dermatologists, and he talks about the management of atopic eczema and different other inflammatory diseases. He will talk today about setting the standards in atopic dermatitis management. تفضل.
Mark is working. Okay, perfect. Yes, it's working now. Good morning, everyone. Jum'ah Mubarakah. So today I will be, guys, talking with you about atopic dermatitis, and I'm going to give you some update from the new studies regarding dupilumab in patients with atopic dermatitis. So setting standards in atopic dermatitis treatment. I don't have any conflict of interest to disclose. And the agenda, I wanted to explore with you guys the burden of atopic dermatitis beyond signs and symptoms that we see in the clinic, and define atopic dermatitis patients' need, and finally discuss the dupilumab benefits for patients with atopic dermatitis. So the atopic dermatitis is not only a skin disease. The symptoms can be itch. They also, other than that, they can have sleep disturbance that can affect their quality of life. work productivity. In the clinic, if I have a patient with atopic dermatitis, I always ask about sleep. Why? Because if they don't sleep well, then they're not going to function well in general. They will be itchy and have an anxiety and depression from not sleeping very well. And you know, the guidelines for atopic dermatitis have changed significantly over the past years. And back in the days, we used just to look at the body surface area involvement, but now we look at other aspects. For example, if we have very small area of atopic dermatitis, but it's in a sensitive area such as the hands or the face, then we consider this to have an impact on the patient's quality of life, and that can be in the category of severe. So it's not only by the body surface area involvement. So we talked about the other problems that patients with atopic dermatitis face other than just the skin disease, the psychosocial impacts on the disease, the work, absenteeism and presenteeism, and also the mental health problems and disorders that are associated with atopic dermatitis. In the clinic, I always tell my residents if we get a lot of AD patients, they're usually nervous, they don't want to wait, they're itching all the time, so that makes them very, sometimes difficult patients to deal with compared to other diseases in dermatology. So now we also understand that inflammatory cytokines that are associated with atopic dermatitis can also increase the cardiovascular risk. This is very important. It's similar to psoriasis. Probably most chronic inflammatory diseases have increased in the inflammatory cytokines that can increase the risk of cardiovascular disease. So it's important to see if the treatment that we're giving can actually reduce this risk, which is a big risk for mortality. Also, the mental health, we know that Th2, the atopic march, the asthma, allergic rhinitis, and also food allergies. Patients with atopic dermatitis have reduced antimicrobial peptides, so at increased risk to get bacterial infection, and also superimposed viral infection that give them more frequent visit to the hospitals and increase the cost to the, the country health cost. So our AD patients, what do they need from the treatment? Of course, they want something that lasts for long term, but the problem is a lot of patients with AD, they think that the eczema is just temporary, give me treatment, I can control it, and then bye. But we have to discuss with them now that we know and understand more about AD, especially the associated internal morbidities and comorbidities, such as the cardiovascular ones, that it's a chronic inflammatory disease. And it does have some flares. So our goal is to control the disease and keep the patient in remission for the longer period that we can. So we discussed about this. So we want, the patient probably want the improvement in quality of life. They want improvement in sleep. Sometimes as physicians, we just look at the body surface area involvement, EASI-75, and look at the severity scores, and we neglect the patient's reported outcomes, but I think it's really important. And if you have a time in the clinic, I really suggest stressing on the patient's sleep health, because this is very important. When I have patients in adolescent, young children, I always ask the parents about their school performance. If they don't sleep well, they're going to the school tired, they're not gonna focus in classes. If they're itchy all the time in the classes, that also can impact their productivity in school, and later on can, have a big impact on their career. You will see this slide a lot, I think, in many conferences, because now dupilumab has been approved for urticaria, probably for bullous pemphigoid, it's in Saudi Arabia, it's already been there in the US, other than atopic dermatitis, prurigo nodularis, so a lot of approved indications for dupi, and we understand that if we control the IL-4, we'll probably reduce the other cytokines, 31 that is responsible for itch, in addition to IL-4 and 13 that are Th2 inflammatory cytokines. And here we can see that dupilumab can significantly reduce the IL-4 and the protic cytokines, which is 31 in patients with AD. Also, AT here provided an improvement as early as 2 weeks. When we compare the clinical trials of asthma, clinical trials of eczema with psoriasis, usually we give patients with AD longer period of time, so we give them 16 weeks to see the outcome compared to 12 weeks in patients with psoriasis. But we can see at least a little bit of improvement as of week 2. Oops, sorry. Okay, and then we have to understand that also these cytokines are important in the skin barrier. Why is that important? For two reasons. The first one is, if the patient have impaired skin barrier, someone is moving the slides, not me. If they have impaired skin barriers, they will have increased risk to get antimicrobial, they will have increased risk to get bacterial and also viral infections. Not only that, there are certain allergy studies where they found that if the patient has broken skin barrier, allergens can get in from the creams, especially for children. So, you know, a lot of creams, moisturizer ones, have nuts and have almond oils. So if it gets through the skin to the bloodstream and antibodies formed against them, probably these kids will have food allergies. And this theory actually was also confirmed by studies where they found that giving Dupi to children can actually reduce the atopic march, including food allergies. So we can see here the impaired skin barrier that increased water permeability also from the skin makes the skin more dehydrated, but also increased risk of bacterial and also viral infections, which we call it impetiginized eczema or eczema herpeticum. And here also we can show that the things can get into the skin if the skin barrier is broken, and that can increase the patient's risk of getting food allergies. This is also a sustainability study that showed the skin clearance that we typically look at from week 16. And here at 5 years, it's also EASY 75 is 65%. Also, the reduction in the flares, of the atopic dermatitis is associated with Dupi. Vascular permeability, we know that increase in the plasma proteins, including fibrinogen, fibronectin. So fibronectin is associated with staph aureus. And of course, we know the important role of staph in patients with AD. The colonization can increase inflammatory cytokines, also increase 31, makes the patient itch. And typically, we give the patient sometimes doxycycline in the clinic, or we tell them about the household bleach bath to reduce the colonization of the staph. But also we see that with dupilumab, we can reduce these plasma proteins, including fibronectin that gets attached to the staph aureus and increase its survival. So it can impact the inflammatory cytokines in patients with AD. So we see that there is an approved reduction in all protein cytokines in patients with, on dupilumab patients with AD. Here are some pictures for before and after for eczema improvement on dupilumab. From baseline and then week 16. I always tell the patients to combine it with skincare measures, so moisturizer, avoid triggers. We can give topical steroids as well. It increases the EASY and the improvement in the patients. If the patients are thick and associated with prurigo nodularis, think about it similarly to the prurigo nodularis clinical trials, where you're supposed to see improvement in around 24 weeks. So give it more time. These lesions are thick and require more time to see noticeable improvement. Okay, now let's go over a couple of long-term studies and also what we call minimal disease activity. It's our treatment goal now in patients with atopic dermatitis that we can see here in a 5 years study from the clinical trials, but also was observed in a real-world evidence from this Italian cohort that we are trying to achieve these markers, the severity markers, the reduction in the DILC, the numeric itch results, the minimal disease activity, the EASY, sleep of the patient, really important. So we look at it all as a minimal disease activity. Not only improvement in the BCA on the skin. And here we also can see EASY 90 and EASY 100, those patients who achieved these results over 4 years, maintained and sustained the same efficacy. Here, the majority of patients treated with Dupi also were having itch-free and no sleep disturbance, and this is very important. Now we're going back to the quality of life improvement in patients with AD. Also, the improvement in AD symptoms sustained over 5 years here from the clinical trial. This is before and after for a senior patient. Of course, if you have someone old, first onset severe eczema, you have to biopsy these patients. especially if they don't have a previous history of any atopic disease before you place them on Dupi, but you can see the improvement in this patient. Okay, we talked about comorbidities. Here we talked about the earlier on we talked about the improvement in the skin barrier can actually reduce the atopic march. And we know that it starts with atopic dermatitis, and then patient can develop asthma, food allergies, allergic rhinitis. But here you can see there is a reduced incidence in the atopic march, so that confirms that probably introducing children early on to Dupi or improving the skin barrier early on can reduce the incidence of developing food allergies in children with atopic dermatitis. And also here we look at the other comorbidities, nano-comorbidities associated in peds. So the GI infections, UTI, mood disorders, ADHD as well, sleep disturbance and anxiety. And I told you about the importance of controlling sleep in these kids because you want them to focus in school and also be productive as well. Here we can see that the comorbidities, the cardiovascular with Dupi compared with other traditional oral medications that we use, such as methotrexate and cyclosporin, and also JAK inhibitors. Probably Dupi and JAK inhibitors were associated the most with reducing the incidence of cardiovascular risk in patients with AD. And you know, AD is safe and very well tolerable, and the side effects that was observed in one of the clinical trials was injection site reaction, and in a few other clinical trials was conjunctivitis that we don't see that much honestly in the clinic. It's mostly dryness, especially in those with background of conjunctivitis and have a severe atopic dermatitis. We typically give them artificial tears, moisturizer, but if it is severe enough, we can send them to ophthalmology to prescribe for them cyclosporin eye drops. But very few number of patients actually discontinued Dupi due to the conjunctivitis. I don't really consider it a big risk. We also did a network meta-analysis that were published in JAD, and we found that conjunctivitis is associated with all treatment options for atopic dermatitis. Dupi, Tiltra, even with JAK inhibitors, obadacitinib, conjunctivitis, it's something to do with AD that we don't see with Dupi when it's used for prurigo nodularis and other indications, such as urticaria as well. This was my presentation. Thank you so much.
I'd like to ask my friend, Professor Abrar Qureshi from United States to come to the stage. He's going to speak about the cases from the multidisciplinary dermatology, rheumatology, and clinics. Dr. Abrar is a professor of epidemiology at School of Public Health and chair at the Department of Dermatology, 1 Albert Medical School at Brown University. He's also the dermatologist-in-chief at Brown University Health Hospital. Please, Dr. Abrar.
Assalamu alaikum, everyone. Really a pleasure to be here. What a beautiful day, beautiful people, a lot of barakah in a place and the people. I want to thank Dr. Ahmed Alisa, Dr. Al-Harithi, and Dr. Dana Alisa for just an incredible show. In the US, we joke that it takes 2 or 3 years to build a conference, and you can see this team has built a conference just within the first year, so alhamdulillah. So hold on to your seats. It's between me and Dr. Muhammad Tawara, between you and coffee break. So we're going to give you a rapid tour. If you have attention deficit disorder, you'll fit right into this talk. I'm going to run through in the next few minutes a number of cases we've seen in the last maybe 15 years or so in our combined clinic. It's a very exciting thing to work with rheumatology. This is our team. You know, this is a picture taken on a certain day. We have a number of people in clinic with us. There are rheumatology fellows, there are dermatology residents, we have pharmacists, we have medical students. It's a wild time, but we learn a lot together. And today I'm just going to run through cases that we've seen over the last few years where we have made mistakes or we've learned lessons. So Tom Fitzpatrick, who trained us at Mass General, used to say that his experience is a collection of his mistakes. So today I'm going to tell you all about our mistakes. Here we go. So basically, we had a referral center since 2003. It's one place with 2 specialists. So every patient sees dermatology and rheumatology together. and we have access to all the therapies out there. The best part is we now have a pharmacist. The hospital gives us a pharmacist in clinic, and it's absolutely wonderful. You know, we can tell the patient about the therapy. As soon as we're done with the therapy, the pharmacist comes in and counsels the patient. It really takes a lot of pressure off of the physicians. And our residents and fellows, dermatology residents, rheumatology fellows, have long-lasting relationships together. So these are the cases we see typically in our combined clinic. You can see it's a variety of disorders. Majority of them are psoriasis and psoriatic arthritis, but we see almost everything that requires systemic therapy. And majority of referrals are coming from dermatologists to our clinic. So a lot of trust, they send us patients, we see them, we send them right back. You know, a quarter of them are primary care physicians, and a quarter are coming from rheumatologists. All right, so here's case number one, right? I'm going to run through these cases very fast with you. This is one of our first epiphanies. Patient comes into clinic, has severe psoriasis, has severe psoriatic arthritis, but it's very interesting. If you look at the nail changes in the thumb right there and that third digit, those nail changes are much worse than the other nails. The nails are very deformed. It turns out that those digits have deformities related to psoriatic arthritis, mutilations, where those joints are completely destroyed. You can see that finger's short. And so it turns out that nail disease and psoriatic arthritis are linked. So if you see a patient with psoriasis who has nail changes, please think about asking them about morning stiffness and considering treating them with systemic therapy. And then that led to a whole series of work with us. We had rheumatology in clinic. They had ultrasound available. We learned about the anatomy of the nail. This is basically the cross-section, but you know, this is actually ultrasound in clinic. You can see the nail fold, nail bed, nail matrix, and the nail plate. And it led to a whole series of research we've done and published on looking at nail matrix inflammation in psoriatic arthritis. Other cases, this is a patient I'll never forget. Patient comes in, she's on a JAK inhibitor for severe psoriasis. She has vitiligo. And you know, she comes in and says, I have pain in this finger. And she went to urgent care. Urgent care said, you know, we can't tell what it is. It turns out she has actually a brewing infection. And if you look at her carefully, she has a tender distal nose. She's carrying Staph aureus in her nose. So she's positive on Staph aureus nasal swab. She's got an infection in a subungual area right there. So we used electrocautery to drill the holes, cultured the pus. This Staph aureus and this Staph aureus were the same strain. We gave her oral antibiotics. Actually, we had to eventually give her rifampin, 300 milligrams twice a day to clear the nasal carriage. You can also use mupirocin ointment twice a day to clear the nasal carriage, but she was able to go back on her JAK inhibitor, responded to therapy, and did very well. But again, something to watch out for. Never forget this case, you know, severe psoriasis was doing very, very well on an anti-TNF agent and methotrexate. Suddenly comes in, he's flaring again. So when we think about psoriasis flares, you think about infection. We looked in the buttock area, we looked in the groin area, we looked in the throat. It turns out his oropharynx was fine, but he had horrible teeth. And here was the lesson learned. I had taken care of this man for probably 2 years. He's a car salesman. I'd never looked at his teeth. So now when I see a patient with severe psoriasis, I say, open your mouth, let me look at your teeth. He had horrible dentition. We had to stop therapy. His TNF therapy and methotrexate. We stopped his therapy. We got Panorex x-rays of his entire jaw. He didn't have any abscesses, but we figured there was so much bad inflammation. We got him to surgery. Under anesthesia, they pulled his teeth. He went back on the same therapy 3 months later, and his psoriasis cleared. So I invite you, please take a look at your patients who have severe inflammatory skin disease. Look in their mouth. If you see bad dentition, it's much better to pull these teeth than to continue leaving them there. And he cleared on the same therapy. So this is a schematic for how we're using, in patients with psoriasis and psoriatic arthritis and Crohn's disease, how we're treating patients with all the biologics we have available. We're so excited. We have so many mechanisms of action. The TNF agents work across the board. If you remember, the IL-17s cannot be used in inflammatory bowel disease. And of course, you have the IL-23s right there. The JAK inhibitors are really an exciting advent to therapy. We'll talk about that in a little bit. All right, moving on. Patient with pustular psoriasis, generalized pustular psoriasis, right? We have methotrexate. We have Dapsone. Like all of us use these therapies all the time. This patient was actually going through a aortic valve replacement, open heart. She needed to be, chest needed to be opened up. So we had to stop her methotrexate, stop the immune suppression, and we actually cleared her on Dapsone. She did very, very well on Dapsone. You can see beautiful lakes of pus, the pustules merging collectively. And she did very, very well on dapsone. We got her through surgery. And now she's on a drug called spezolimab, which is an anti-IL-36. It's a brand new anti-neutrophil drug. I'll tell you about that in a second. But we have some brand new therapies now we can treat pustular psoriasis with and clear them completely. It's a patient with pyoderma gangrenosum, moving to neutrophilic disorders. We're using a fair amount of oral cyclosporin, micronized cyclosporin for these disorders. It's a patient I treated when I was a junior faculty at the Brigham many years ago with IV cyclosporin. Over the course of a couple of weeks, you can see a patient came in, got IV cyclosporin for pyoderma gangrenosum and Crohn's disease. And within days, cleared on IV cyclosporin, but we're also now using Cytoxan, cyclophosphamide for these patients as well. It's a patient with cutaneous Crohn's, looks like pyoderma gangrenosum. How do you know it's cutaneous Crohn's? Here's the giveaway. You can see the ulcers occurring in the skin fold right there, and that is a suggestion for cutaneous Crohn's. Now, when this occurs, they clear beautifully on oral steroids, but long-term, they really need anti-TNF therapy, and they need to be watched very, very carefully. Otherwise, if you stop the steroids without secondary therapy, they flare and they'll come right back. It's a patient actually who failed all therapy. He actually was getting repeat surgeries from plastic surgery for a nose procedure. It turns out he has pyoderma gangrenosum. So he lost almost the entire nose structure. And he showed up in our clinic with an infection and what looked like PG. We did a biopsy of the edge. It was classic pyoderma gangrenosum. We treated him with IV antibiotics, cleared the infection. He failed TNF therapy, so we gave him cyclophosphamide, oral, 50 milligrams twice a day. That's him within literally 3 months, and that was him most recently, almost cleared completely. We got him a nasal prosthesis, had some reconstructive surgery, has done very well. Look at this ulcer on his arm. This is his arm, pre and then post cyclophosphamide. So yes, we have new therapies like spezolimab, Spevigo, IL-36, but sometimes we go back to our old therapies from years back and we can use them. Now, interestingly enough, cyclophosphamide IV can cause hemorrhagic cystitis, but orally, very safe in someone his age, and he's cleared quite well. This almost looks like, we sutured the wound closed, but this is all oral Cytoxan, 50 milligrams twice a day, and did very, very well. So how do we treat pyoderma gangrenosum? This is some of our schematics. Certainly steroids work very, very well. Dapsone we use a little bit, doesn't have much efficacy. We like cyclosporin, but Cytoxan is even better. TNF therapy works well. But our new kid on the block is Spevigo, spezolimab, anti-IL-36, available in both intravenous and subcutaneous form. All right, some other fun stuff. So working with rheumatologists, well, guess what? They have ultrasound in clinic, right? And so we see someone with hidradenitis suppurativa, we look at their skin, we see scarring, inflammation, oozing, pus coming out, they're very uncomfortable, a lot of pain. And what we see is really the top of the iceberg, what's visible. If you put an ultrasound probe on, good between sort of 12 to 16, 18 megahertz ultrasound, you can see a lot more inflammation in the same patient. You see the sinus tract, an abscess right there, and a lot of inflammation on power Doppler. So we're learning rapidly in our clinic that ultrasound is telling us a lot more about HS than we knew before. In fact, there's a recent study that suggests that patients who have Hurley stage 1 disease, when you do ultrasound, they really have Hurley 2 or Hurley 3 because we're not able to see what's going on in the skin. So here's an example. This is a patient we saw who had severe HS. This is the grayscale ultrasound right there. You can see cavities. You can see a sort of abscess that's connecting. On power Doppler, you see a lot of inflammation on the edge of the lesion where the advancing sinus tract is. We treated her with a drug called bimekizumab, Bimzelx, which is an anti-IL-17. And literally within 8 weeks, you can see that the skin still looks the same, less pain, less oozing, the sinus tract's organizing, and the inflammatory patterns changing on power Doppler. In a year following this patient, you can see skin looks a little bit better, less edema. You can't really tell, except palpation is less painful. The scars are well organized, and there's no power Doppler signal. So we're learning a lot more about what's beneath the skin rather than just looking at the skin. And as we use ultrasound, we're becoming better and better at this. All right, I'm going to switch gears on you. We're going to go to collagen vascular disease. So dermatomyositis. This is a paper we published about 3 cases of malignancy we missed in clinic. So what's the clinical pearl? If you see someone with dermatomyositis of the skin, if they're not responding to hydroxychloroquine or they get a rash, they're not responding to methotrexate, you give them a JAK inhibitor, they don't respond, please look for malignancy. The first case is a gentleman who had retrotonsillar cancer. We scanned his chest abdomen, pelvis, missed the cancer. It was in his neck. So, you know, luckily we got surgery, got radiation, survived. He's still alive today, doing very, very well. This is a crazy case. This woman had an enlarged left breast. The breast CT, breast MRI, ultrasound, all normal. The problem was she had an angiocentric T-cell lymphoma blocking the lymphatics on that left axilla, causing the enlargement of the breast. She had a bone marrow transplant, her dermatomyositis cleared, and she's alive and well, you know, almost 8 years later. And this young woman had breast cancer, but when we were treating her, we couldn't find it. During the course of therapy, she developed a lump, had surgery, and got chemo, and her disease cleared. So just FYI, if the patient doesn't respond to therapy, please pay attention to cancer. Pediatric dermatomyositis, this lesson learned, this child came to us. Question was, you know, does he have eczema or acne, something else going on? He was called a floppy child, didn't want to go running around at recess, didn't want to do anything else, and we treated methotrexate, he cleared completely. Darker skin type with some dermatomyositis right there. I'm going to wrap up just in a couple minutes. And then just want to end with a couple of slides. So again, ultrasound available in clinic. When we see calcinosis cutis, we can use ultrasound to see how they're doing. And we're treating these patients now with intralesional sodium thiosulfate. So they respond very well to systemic therapy, but intralesional sodium thiosulfate works pretty well. And you can see here, that's normal adipose tissue, and that's where the calcinosis is. You can see the calcium does not let the ultrasound shadow go through, and then you see inflammation right there. And these patients respond quite well to therapy, systemic therapy. Thank you so much for your attention.
Thank you, Dr. Abrar, for this great presentation. It's my pleasure now to call Dr. Mohammed Dawara. Dr. Mohammed is a consultant dermatologist and the director of dermatology unit of the Eye Specialty Hospital, Amman, Jordan. He will talk today about pharmacological advance in dermatology, a year in review. Please, Dr. Mohammed.
Well, thank you very much. صباح الخير جميعا، جمعة مباركة. وحقيقة يعني تشرفنا بهالدعوة الكريمة، فالشكر الموصول لكل يعني آدم أكاديمي ممثلة بالدكتور أحمد، دكتورة رؤى والدكتورة دانا. So let's start a year in review in dermatology. What about the recent pharmacological advances? 2025, it's not just what it was a year ago. So we have many breakthroughs in dermatology. We are moving from generalized approach to deeply personalized medical care. That means we are moving from guessworking to precision medicine. Let's actually deep dive and let's talk about many breakthroughs that will reshaping dermatology practice. We have several genuine game-changing treatments that have been approved over the last year. And with many expanded indications of already available drugs have been approved during the last year. There is a new hope to the patients living with the rare and particularly with the genodermatosis and often neglected skin diseases. And then so let's move for the first with the alopecia. And as we know, we have the already approved drugs in alopecia, and we know minoxidil and even finasteride. But what about the androgenic alopecia? Do we have a new molecule for this? So, first of all, the clascoterone, it is in the phase 3 trial right now, currently, and we hope to have the in the first Q1 in 2026, we have the data about clascoterone in androgenetic alopecia. But the new molecule that has been actually even overwhelming, even in the social media, it is the PP405. It is acting as a topical serum or topical treatment to reversing alopecia by reawakening the dormant stem cells. It is actually overwhelmed in the social media, even in Arabic social media. So what about this PP405? It is currently in the phase 2A. It is an innovative topical drug. It's right now, as the recent data being approved, at least 1/3 of patients, they have actually using this molecule experience more than 20% increase in the hair density after 8 weeks. But on the cellular level, it's actually, we can see the early results as of 1 week. This molecule actually has been studied by researchers in the UCLA. In the UCI, they studied another molecule, which is the SCOOP3, which is acting also in the hair follicle stem cells, reawakening of these stem cells. Another researchers in the UCI, they are talking about, why is this? Why hairy moles are hairy? And then during this year, they identified there's a molecule, we call it the osteopontin. This is the molecule behind the hair in the hairy moles. And this is a new target. It might be for research in androgenetic alopecia. Moving to alopecia areata. Alopecia areata, we know the first publications like 15 years ago, they're talking about new hope for the hopeless, and these are the era of JAK inhibitors. And currently, we have 3 molecules, we have 3 anti-JAK or JAK inhibitors being approved for alopecia areata. So what's next? Do we have more of the same? Do we have opadacitinib? It might be upcoming in the near future. But what's something new? Something new, it is the RNA interference, or what we call the siRNA. And when we are looking back to the 2006 about Nobel Prize by the Fair and Milos, and when they discovered the siRNA, which is the small interfering RNAs, these are what we call the silencing genes behind this. And actually the first trial, it has been approved right now, and it was the first intradermal injection in a human being. It was in March 2025. So it might be this is the clearance for the first genetic medicine program in trichology. But in 2025, we know we have actually 3 researchers. They get the Nobel Prize in Physiology and in Medicine. That's behind actually their work behind identifying the immune system security guards, which is the Treg. And a scientist actually from MIT, Brigham Women, I know Dr. Abrari was there, so Brigham Women, MIT, Harvard, they are right now currently working in a new molecule, which is, or a new technology about the treatment of alopecia areata. They are talking about the immune regulating microneedle patch that it will deliver a combination of 2 immune molecules, the cytokine interleukin-2 and CCL22. By that, they are boosting the Treg cells. Moving to the Netherton syndrome. Netherton syndrome, we know it's an autosomal recessive disorder characterized by SPINK5 gene mutation that it will lead to the serine protease inhibitor deficiency or the lectin deficiency and upregulation in the kallikrein molecules. That it will lead to the actually barrier dysfunction and intractable pruritus and the scaly dermatitis. Right now, we have an FDA and EMA, actually, they have been approved like a designation for orphan drug for a topical lotion that containing broad-spectrum serine protease inhibitor. So this might be in the future, this is a new hope for the Netherton syndrome. And because it is, and we know there is an immunologically, and there's a chronic inflammation in Netherton syndrome. So many molecules that have been tried, like the secukinumab and the dupilumab, and there is a good trials about these. What about the IgE or omalizumab? It has failed. What about the JAK inhibitors? I have this patient with actually Netherton syndrome associated with alopecia areata. Then I decided to try the baricitinib, which has been approved. And we can see after 8 weeks, we can achieve an excellent sustained response regarding the chronic inflammation. And after that, we know there's a trichorexis invaginata, here structural abnormality, but we can achieve a good, excellent response. What about the recessive dystrophic epidermolysis bullosa? It is not just a skin disease. This is really a very devastating disease for the family, even for the medical health. So we know the collagen is 7, and we know the mutation, it is in the collagen 7A1 gene mutation. So over the last 2 years, we have 3 distinct FDA approval for this disease. The first one, it was topical gene therapy, which is Vyjuvek. It was 2 years ago. The other one is botanical. And the third one, which came this year, it is autologous cell sheet gene therapy, what we call the Zivaskin. And what about the Zivaskin? It is actually the first FDA-approved autologous cell-based gene therapy. And this is a one-time surgical treatment. So we're making the sheets and then transform it to the already chronic wound. And this is significant wound healing. And there's a long-lasting, it may take about up to 8 years, the results. And this is actually the Zivaskin procedure. But how it cost? It cost actually the single treatment cost might be $3 million. What about the neurofibromatosis? Do we have any hope for neurofibromatosis? For example, when we have plexiform neuromas, definitely it is surgical treatment. But what about inoperable neurofibromas or neurofibroma-associated plexiform neuromas? Definitely we have a medical therapy. So we have 2 approved drugs right now for the neurofibromatosis plexiform neuromas. They are working in the MAQ1, 1 or 2, and they are the mirdatinib and the silumetinib. And these are new treatments. They are for symptomatic and inoperable plexiform neuromas, and they have been approved from the age of 1 year in pediatric age group and in adults. What about molluscum contagiosum? Do we have treatments for this, and do we have any approved antiviral treatments for this one? We know it's highly contagious, and sometimes we are facing these cases in immune-compromised patients. 2 years ago, we have this, like what they call the Betelgeuse, which is the cantharidin or the Ycanth, but it should be applied by healthcare professional in office. Recently this year, there is what we call the berdazimir, which is a fine 10% gel. It should be applied at home by the patient himself. It is an adult and children more than 6 months, and it has antiviral activity. The activity, it is via topical nitric oxide releasing gel. What about dupilumab? Dupilumab, it has been new expandable treatments and indications this year. It is for the bullous pemphigoid and for the chronic spontaneous urticaria. And when we talk about the CSU, this is adopted from the Canadian guidelines protocols for the CSU. So you can see it is the first steroid-sparing treatment. It is the dupilumab. So we can use it in the severe form, we can refractory form, or when we have these patients with afraid from steroid long use. What about the CSU? We know dupilumab, it has been approved this year, but to be honest, disappointing efficacy in the omalizumab refractory patient group with a delayed onset of action. So what's next from the CSU? Just 2 months ago, we have a new molecule. It's the first in class. It has been approved, which is targeting the BTK, proton tyrosine kinase inhibitor, which is the remibrutinib, which is the Rapsido. It has been approved 2 months ago, which is an oral therapy. It is controlled very fast within 2 weeks. A safety profile, no lab check, no lab monitoring, and it is taking twice per day. What about prurigo nodularis? This is one of my cases. We know we have DUPI and the nemolizumab, anti-interleukin 31 receptor inhibitor. But if we have alopecia areata with prurigo nodularis, I think our first choice here is JAK inhibitor. So by JAK inhibitors, we can talk about these two. Delgocitinib, for the time constraint, I will be a little bit fast. So delgocitinib has been approved for the chronic hand dermatitis also in July this year. Ruxolitinib, we are using it for atopic dermatitis. We are using it for vitiligo. Right now, it has been approved from the age of 2 years. So it will give us an ample, actually, duration, age-wise to use it in vitiligo and in atopic dermatitis. What about roflumilast? Roflumilast, it is the only drug that has been actually taking 6 indications over the last 6 years, over the last, 3 years. 2 formulations, 3 concentrations, and 3 indications. And recently we have it in the very low dose, which is the 0.05% atopic dermatitis. So lastly, the gozulcumab right now, it is the first anti-interleukin 23 that has been approved in pediatric age group, which is from the age of 6 years. But the dose is the same as in adults, but in spite, we have 40 kilograms of body weight. And lastly, this is how we are going, if we have psoriatic patients. So do we have something we can take it orally and we can affecting a targeted therapy? I think yes. This is what we call about oral peptides. And when we are talking about oral peptides, there is at least 80 peptides being approved in medicine right now. One of them, it's upcoming. I think we may face it might be in the Q1 next year. This is the icotrokinra, which is actually icotrokinra. It blocks the interleukin 23 from binding to its receptor. And when we're talking about this molecule, it is first in a class oral peptide that it will act against the interleukin 23 receptor. It's a once daily pill. And we know the ICONIC project. They have many studies regarding the ICONIC, and they compare it actually to the ustekinumab. They compare it even to the deucravacitinib and to placebo, and it's been superior. So by that, I think 2025, it is a field in full bloom. So we are waiting many molecules in the new horizon. So by that, I think wish Saudi Arabia for the best for the World Congress of Dermatology next time, and thank you very much.
Thank you, Dr. Mohammed, for this great presentation. I think you have time just only for one question. Yes, Dr. Omar, please.
Dr. Abdul Hadi Jifri. So, comment, question. Would you, yeah, Habib. Dr. Abdul Hadi, would you agree? Where is Dr. Abdul Hadi? Jeffrey. He's not here. يعني I would like to say my comment concerning atopic eczema, the management of atopic eczema. We shouldn't focus on one modality of treatment. For example, biologic therapy. It helps. It is magic, but it will relapse again. And I didn't note any study saying after decreasing the dose or even stopping the dose, it will relapse. So it is not the solution. And that should lead us to look for other options, therapeutic options. For example, the role of microbiome in the intestine and the hemostasis, يسمونها التوازن. It's very important in the management. They call it gut-skin axis. It could affect this microbiome and the balance of these toward the beneficial bacteria, it will affect the immune system, and it will affect the improvement of atopic dermatitis. And there are a lot of studies. And I do believe, in the long run, it's maybe curative if you have a good balance for this bacteria. As I said, it's good. The other option, we should focus on the skin repair, barrier repair, because it's now they think it is the most important factor in having eczema, in addition to genetic factors. But we have to think of repairing this barrier. For example, ceramides and other things. I don't mind, we can have therapy, biologic therapy, JAK inhibitors for severe cases. If the psychology of the patient is affected, he has depression, you can help him. But in the long run, I think I do believe we have to add this therapeutic approach. Dr. Abdelhadi is here? Not yet.
Okay, thank you, Dr. Omar, for this comments. It's my pleasure now to call the next chairman for next sessions, Dr. Hani Shibeli, and Dr. Nujud Ajroush, and Dr. Azhar Ahmed. Please go.
Assalamu alaikum wa rahmatullah. Good morning, everybody. This is Azhar Abbas Ahmed, Derma Consultant at King Faisal Specialist Hospital and Research Center, Al Madinah Al Munawwara. Pleasure seeing all of you today. And as a Medina citizen, I would love to invite you all to enjoy all the Medina scenes for these days. I would like to welcome our co-chairperson, Dr. Nujud Al-Ajroush and Dr. Hani Shibeli. So, I will have the honor to introduce the first talk, which will be about the new art of rejuvenation and restoration that will be presented by Dr. Ali Al-Amri. Dr. Ali Al-Amri, he is a consultant dermatology, fellowship trained in dermatological surgery and laser medicine from Germany. So welcome to the stage, Dr. Ali.
Thank you so much. Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you, Dr. Azhar, for the nice introduction. Thank you for all that you are coming today. In the beginning of my presentation, I would like to thank all of the scientific committee. It's actually an amazing conference. Thank you, Dr. Ahmed Al-Isa. Thank you, Dr. Ru'a Al-Harthi and Dr. Dana Al-Isa. Thank you so much for the well preparation and coordination since long time. The previous injectable master class, I informed that we are looking to have like those conferences that will organize and scientific and looking to find the new modalities. Like the previous lecture, it's amazing lecture that update a lot of things that we needed in our clinic. Now we shift to the cosmetic issue and biostimulation and biostructure. So let me to start my presentation. Most of our face rejuvenation and remodeling for any cosmetic issues, all the time we are looking for those triangles. And actually, I hope this is the pointer. Actually, we know it since long time, but nowadays, it's not only the optimal one that we have to make it in triangle, opposite in opposite side, vertical or in verticals, because we have now a lot of generations and also ethnics. So for example, if we are looking for those patients coming from Asia, we have most of them with rounded face. So this shape, it will not be the optimal one for them. And for example, if we have some patient from Russia, it will be also different. But at least we have the idea in our mind. Now we have to analyze all the time our patient depend on her face. I don't like to have all of my patients in my clinic with triangle. We have different shapes, and so the face analysis all the time is very important for the evaluation. So the aging process, before we thought it's only in the skin, but with time we know that we have pigmentation changes, we have also reabsorption of the bone, we have also wrinkles, we have also loss of fat and elastin and collagen. So now the idea is changed. Before we are using only topical peeling or tretinoin, and with the time, now we are trying to build all layers, bone, we have to, for example, the calcium, we have to activate collagen and elastin, and with the time we find also that we have to change the, or treat the pigmentation and forward also the wrinkles by peeling, laser devices, microneedling radiofrequency, and as well the Botox toxins. So, with those ideas, we did a lot of the dissections of the cadavers, and through those dissections, we find that we have different modalities for the face remodeling, and we are starting all the time from the bone, and we are going up, and we find also it's only the we have different layers that we have to target. So the bone, it's the most difficult one. So we have to take care of the nutrition of the patient, and also we can use the KAHA to stimulate the periosteum area. And after that, we have to look for the fat beds. The fat beds, we have different actually layers of the fat beds. We have the superficial and the deep. So we have to target the deep layer. And with the advanced injectable master classes, we can educate our colleagues how deep and which level that we have to target. So this is what's happened if we did dissection. So sometimes you can imagine it, but we have also different variation. In this slide, I would like to show you that we have to decide which layer that we have to target it. For example, in the skin here, we're targeting the pigmentation and also micro wrinkles. And here we have, in these two layers, we have to target to volumize or stimulate the fat tissue, or just substitute the volume loss with hyaluronic acid, for example, or KAHA. In this mass, we have to stimulate the collagen with, in both two layers, with, for example, hybrid filler or the BLLA. And in this layer, we have to use also calcium hydroxyapatite. So sometimes in the outer layer, we can use also different mechanism with devices or peeling. Now, I will go with this important slide. I think I had it in many of my lectures. So we have different type of ligament. We have pseudo ligament and we have a real ligament. Pseudo ligament is actually making like deviation or sometimes depression in the face. So this ligament, it's not important to keep it. So sometimes we need to subside it. But we have a real ligament. The real ligament is coming in the orange color. This is very important ligament that can we target it with the hybrid filler or calcium filler, or sometimes with the normal hyaluronic acid filler, that we can lift the face. So this is also for the fat beds. This slide is very important for me and also for all colleagues and the beginners especially, but even if we have long experience all the time, sometimes we have to take care of those zones. So the important areas all the time, I imagine it for my patient, 2 point here, 1 point here, and 1 point here, 1 point here, and 1 point here. It's not important to know the name of the vessels, but important that to avoid those dangerous zones. Good. So now we have two different theory that we have biostimulation and biostructure. Before, we have only biostimulation. So in this lecture, we can differentiate between the biostimulation and biostructure. The biostimulation, it's to improve the quality, health, and appearance of the skin and superficial tissue. We have different types, the old generation and the new generation, like BRB, growth factors, peptides, amino acid, and also hyaluronic acid. So we have way to stimulate the cells to build up or make the skin healthy. We have direct stimulation and indirect stimulation. Direct stimulation is physiological process like cell turnover and fiber synthesis. This is what is called biostimulation. It means that we wake up the cells. We ask the cells to work more. Indirect, through activating the tissue repair mechanism, it means that we remodule the tissue or rebuild the tissue. This is what is called biostructuring. Biostructuring, it's recognize and reshape the tissue, increase the extracellular matrix. At what time that we need the biostructure? If we find the cells, or with aging, the cells is not functioning very well, so we have to stimulate the physiological activity. Good. So we increase in biostructure all the time extracellular matrix. So with those processes, we can build again the tissue and the shape. What will happen? Tumor growth factor beta and tumor necrosis factor alpha, which activate the fibroblast and collagen type 1. What's the difference between both of them? This is a very important slide. Biostimulation improve the physiological cell process, keep tissue balance, prevent aging progress, and quick result and short term. So if we inject the patient, we can see the result through 2 weeks to 1 month. But the biostructure, it's a corrective action, extracellular matrix production, and will do the tissue remodeling like what we use in this biostructure, BLLA and CAHA. Good. Now in this lecture, I'm talking about the new modalities, which is the hybrid filler and what I have in my experience, the Sphera, and also another mixture which is Restora. And what we find in Restora and in the Restora that it has different mixture, and I will explain that in other workshop 2 days. Restora, we have a lot of different activation for or direct volume. We have indirect volume, we have firmness, we have reshape, we have elasticity and rejuvenation. We have all in the same level. But for example, in CAHA, we find the reshape, it's little bit less than indirect volume. So if I would like to make more volume, I will use CAHA. But if I'd like to have all in the same level, so I will use the rejuvenation way with the all combination. Hyaluronic acid, CAHA, PLLA, and succinate. So all together. So this slide can differentiate between all different type of the collagen stimulator or the volumizing material, so you can compare. If your patient need to have more volume, you can choose hyaluronic acid, for example. If you'd like to make like elasticity less than or more elasticity, so skin booster. But with PLLA, for example, the elasticity improvement, it will be low. So this diagram, it will help us how can we choose the better treatment or material for our patient. So according to what I told you before, the Sphera, it's the first hybrid filler that we have it in the market. It's not cause any calcification or ossification, has low risk of migration or foreign body reaction. All the time, please don't inject the KAHA, because in the last conference that I was in, I find some colleagues that they mentioned that we can use the KAHA in the temporal area, and also some of them they mentioned under eyes. Please, it's I don't prefer to use it because it's dangerous area, and also the result it will be not in the proper way. Good. Let me to go forward. So the filling, rejuvenation, and tightening, this is all the time with the hybrid filler. So we'll stimulate the collagen, elastin, and angiogenesis. This dilution, I will explain it for you in the workshop. If we have, sometimes with the KAHA, sometimes we have some nodules. So the management of the nodules, all the time we have to inject a hyaluronidase or normal saline. So we have to differentiate between the nodules and the granuloma. But the granuloma, we have to add like 5-FU or cortisone, and after that, if not, we can excite it. This is the result of the Sphera patient that I have. You can see some volume and lifting at the same time, this before and after, and you can see also the nasolabial fold, how is it the result. Also this patient, you can see the improvement in the skin quality and also the lifting and the remodeling of the face. Here, as you see, also the same in the nasolabial fold and the cheeks. From the other side from here, and also there is improvement as well here in the wrinkles as well. So we activate both elastin and collagen, and also we do some lifting, because I target also the real ligament here around the orbital cavity. We can use it also for jawline and for the neck. And the Restore that I told you, the different combination for biostructuring and biostimulation all in one. We have polylactic acid, calcium KAHA, we have polynucleotide, collagen fragment, we have hyaluronic acid, amino acid, and niacinamide, all in one. So we build biostructure and biostimulation in the same way. My method, I will explain it also in my workshop. So contraindication as well, lips, under eyes, and also temporal area. I don't prefer to use it, but in some cases, if we have deep breast and deep breast, we can use it. I still have half a minute, so this is the result of the Restore, but the result for Restore, it will take time, so we have to wait like 6 weeks to 2 months. This is another case, and this is another case, so I think I catch my time, right? Thank you so much.
Thank you, Dr. Ali, and I think we'll leave the questions for the end of the session. I'm really honored to present our next speaker, Dr. Mohammed Turkumani, who's a dermatology consultant in Derma Clinic Riyadh. Dr. Mohammed Turkumani, we are always excited and looking forward for your talks. Today, he will be talking to us about facial morphology, perfecting the art with fillers and toxins. The floor is yours.
Thank you very much, Dr. Najoud. Assalamu alaikum wa rahmatullah. Good morning. Okay, in my presentation, I'm going to talk how to improve the face shape with injection of botulinum toxin and filler. I have nothing to declare. We know that there are many shapes are attractive, and there are many factors play a role when we say this is an attractive face or not. We have to check for the ethnicity, age, gender, culture, and what are the fashion nowadays, what is the trend nowadays. In general, we are focusing in three factors: symmetry, balance, and the facial morphology. So let's talk about the symmetry. Let me tell you that what is the truth about the face symmetry. Complete symmetry is not present in nature. No one having symmetrical face. And asymmetry in nature is natural. This study published to show you this is the middle, the center, this is the face, and the blue one, which is the right, both have, and the left, look at my face. This is my face, this is the center of my face, and the other side is my two right halves, and this is my two left halves. So no one having symmetrical face at all. No, it's very common to see asymmetry. You can see it in the brow, we can see it in the smiling chin, and look, this is a hemifacial macrosomia. Look at the right side of the face is bigger than the left side, and even the brow shape, brow position is completely different. And we know that the balance also, we know these rules, the vertical fifth face and the horizontal third faces. And this is one of the main rules when we talk about the beauty of the face. So there are some rules in our face, like the Ricketts line, that if you draw a line passing from the tip of the nose to the chin, that the upper lip is 4 millimeters behind and the lower lip is almost 2 millimeters behind. And how about the facial morphology? Now, in women, in general, there are 7 types of face shape. We have the oval, round, square, triangle, inverted triangle, rectangle, and the oblong face. So always the face shape determined by 3 factors: the space between the forehead, cheekbones, and the jaw widths. Usually the Asian people having wider face, the Caucasian having shorter and slimmer face, and this is a round face which is no angles at all. The forehead, cheekbone, and jawlines all are in almost the same width. This is the oval, that the length is longer than the width of the face. And this is square. Unfortunately, this type of face, it was in fashion years ago. And you've seen that the lengths and widths are almost the same. It's more giving more masculine face than feminine face. Triangle, which is narrow at the temples and a little bit wide in the jawline. And this is inverted triangle, and this is, I think this is the most attractive shape of the face, like the heart. When the temples is fully filled and the cheekbone is fully filled and the patient having pointed and circular chin. And this is rectangle, which is similar to the square face, but a little bit longer. And oblong. Oblong means rectangles without angles. So contouring the lower face, we know that always the chin and jawline are 2 important factors in formation of the beauty of the face. Usually men having strong chin, the woman having youthful chin, and let me show you about the chin itself. In male, the chin is flat, broad, and wide. In women, it's usually rounded, circular, and pointed. And the border or the outlines of the female chin it's the intercandle space. In male, the corner of the mouth. So in male, having always wide chin, in woman, more pointed chin. And also, again, the chin position is important. Now, if you draw a line passing from the subnasal area, the chin usually 2 millimeters behind this line. So we have in the chin, we have two positions, which is retracted or protracted. We call it protraction or retraction. Now, if you have a patient with retrognathia, so this is giving the convex shape of the face and short neck length. So what is the main area to inject with the dermal filler to improve this face shape? Definitely, we have to inject the jawline, we have to inject the lower lip and chin. In prognosticism, or those people having too much projection of the chin, this is giving concave face. So here, we have to inject the anterior cheek, nose, and upper lip. So what the ideal jaw? The ideal jaw is there are three factors playing a role in shape of the ideal jaw. The gonial angles, which is the space between the gonian from gonion, the ramus lengths, and bigonial weights. And we know that in women, this angle, we call it gonial angle, is more obtuse. In male, is less obtuse, more acute. And this is determine the shape of the face. And the ramus length. Ramus length in male is longer to give more osculant face, and usual in female between the tragus to the gonion between 4.5 to 6.5 millimeter. And bigonial weights also. Look at the bigonial weights. Now, in male, my zygomatic and bigonal distance are the same. In women, the zygomatic should be wider than the gonial to give more hard shape. And let's talk now about the botulinum toxin for improving the facial contouring. This is the bilateral mastication or bimastication muscle hypertrophy. We've seen that temporalis muscles and masseter muscles are enlarged. And look at these two males there. It gives what we call it hourglass appearance, which is hill, valley, hill. Okay? So how can we improve the shape of the face in those people having bimastication muscle hypertrophy? Just we inject temporalis muscle. These are the size of injection. Do not inject below the horizontal line because it will increase the temporal depression. So these are the sites of injection. You can inject it in 3 sites or 5 sites. And look at this, my patient before and after. Definitely it's improving the shape of the face. And when we inject the masseter muscle, it's important just to inject away from rhizorius muscle, and the best area to inject it is the V area, which is lower middle area of the masseter muscle. And look at this patient having wide mastication muscle is hypertrophic, and this is after the injection of the toxin. Her face becomes more slimmer in the lower part, and it gives more feminine shape. So the treatment strategy according to facial shape, this is a round face. This is, we can inject the toxin and we inject all the filler. This is a patient after the injection. The square face, the blue dots is the area injected botulinum toxin, and the pink one, we injected the filler. And this is the shape after we improving with the combination therapy of dermal filler and botulinum toxin. This is inverted triangle face, and this is a patient after, definitely give better improvement. And the oblong face, we have to widen the face on the center, and this is a patient after the injection. So how about the male? Male, they like to have straight jawline, wide jawline, and to give, this is a patient before, and this is after the injection of the dermal filler. So the facial morphology, I'm always saying, when we use botulinum toxin and dermal filler, it's not the matter just to fill. We have to know why, when, where, and how to fill. Thank you very much.
Yes, thank you, Dr. Turkamani, for this lectures. Now we'll proceed for the next speaker, Dr. Erjan Sihandidi. It is the aesthetics, plastic and reconstructive surgeon. He will speak about the new era in natural beauty, advanced technique in full face rejuvenation.
نعم والله نعم. ليلة القبض على فاطمة. كيف حالك؟
الحمد لله. عايزة
لا أنا وليت
Dear moderators, dear presidents, dear colleagues, I brought the warmest regards from Istanbul, Turkey. I'm an aesthetic plastic surgeon. I was in the university like 10 years ago and I moved to private practice. So I will be talking about my journey from HA fillers to KAHA. The last 4 years I have changed my approach to facial rejuvenation. So if we look at the statistics, we have a big number of patients coming for fillers. Like everyone else, I was using the HA, and if you look at the numbers, it's coming bigger and bigger each year. And for the KAHA, the numbers were low before 2019, and even though we have the pandemic in 2020, the numbers are going high because the biostimulation is now the new era in facial rejuvenation. So when I talk about dermal fillers, I think we should just carefully approach the patients because we have more 50 or 60 plus patients coming to our clinics. And if we have too much skin excess and if we go with the HA filler, then we will have a problem. Probably you have the same thing. I'm an aesthetic plastic surgeon, so if the patient needs a facelift, I'm doing the facelift. But if the patient wants something non-surgical, we should be careful about putting and overfilling the patient with HA fillers. So the seniors, 60 plus patients, are more coming to our private practices asking for solutions for facial rejuvenation. And I just want to point out the pillow face phenomenon. This term is used to describe the puffy, overfilled look that can happen when too much dermal filler is injected into the face. We see puffiness, we see loss of facial contours, we see unnatural smoothness, we see lack of expression, which is a huge problem, I think, and we see a disproportion. And the reason could be overfilling, incorrect placement of the filler, filler migration, and type of fillers. So we should be careful about the recurrent HA fillers. And when we look at the face, we are always talking about the soft tissue changes. We are talking about the increased vertical eyelid length. We are talking about the periorbital hollowing, prominent nasolabial fold, tear trough deformity. So this is always about soft tissue. But what happens to the bone underneath? This is one of our mentors, Brian Mendelsohn from Sydney, Australia, aesthetic plastic surgeon. And I think this is a great article to read about. If I ask you which facial bone gets the most bony resorption on the face, is it zygoma, is it orbita, is it maxilla, or is it mandible? Let me ask you, which bone? Is there any answers from the audience? Which facial bone gets the most resorption? The answer is maxilla, not the zygoma, not the mandible. So this ascending wing of the maxilla gets the most resorption. When we get old, we think of the nose getting longer, but actually it's not getting longer. We are losing the bone underneath. So we should always focus also on the deep tissues, doing supraperiosteal fillers. This is another nice article about periosteal stem cells. When we are going deep on the bone, we are touching the periosteum and we are scratching it. And in in the back response, the periosteal cells produces fibrosis and calcification or ossification there. So when the patient comes to you 1 year later, you feel that you need to do a little bit less. This is the reason. The reason is the periosteal stem cells. Okay, if we look at the fillers, for me there are two important criteria for filler selection. Of course, the first one is patient safety, and the second one is everyone is going for private practice, so cost efficiency. If we have two functions in one composite action, then that would be my choice. As professionals, I don't want to go about the general definitions. And how do we see the wrinkle formation? We lose the collagen, we see elastin destroyal, and the decrease in hyaluronic acid. So we need to put it back. And instead of HA, what we can do do something else. So if you look at the classification dermal fillers, we classify the PLLA, CAHA, and PCL as semi-permanent. Why? Because the immune system just absorbs it, attacks it, absorbs it, and instead of the molecule, it triggers collagen, and we see collagen deposition in time. So I will be talking about my journey with CAHA, and I also used every molecule you see on this table, and the last 4 years, I'm a CAHA lover. So CAHA is non-toxic, physiologically inert. It has a big potential in anti-aging properties. It stimulates new collagen and elastin formation, and it gives a natural appearance. My patients are always after a natural look. Your patients choose you because of the referral from the other patients. So I'm always after a natural appearance. And CAHA does this through a non-inflammatory process. For example, I used PLLA before. PLLA triggers the collagen deposition through an inflammatory process. So the first 3 or 4 days, your patient sees a puffy appearance. And I wasn't happy, my patients wasn't happy. So after 1 year, I'm after the biostimulation, but I didn't like it. It wasn't good in my hands, and my patients were unhappy. So I moved to CAHA, and I'm very happy with it. And if you look at the approval time, it has been in the sector since 2004. FDA approved it in 2006, with lidocaine in 2009, and in hand regeneration since 2015. There are lots of articles for the safety and tolerability of CAHA, and this is a very nice article. It proves that it really triggers collagen production. One of my colleague, a plastic surgeon, before doing a tummy tuck, you know what we do in tummy tuck? We are taking the skin out of the body during the operation. 1 month before the operation, he put CAHA and saline into the skin that he will take off during the operation. And then at the operation, he sent it to histopathology. And staining with picrocereus red and looking at it under polarized microscopy, the new collagen fibers looks green and yellow. The mature, the old one, looks red. So the control group treated with saline, you see the red ones. This is human skin. And the yellow and the green ones is the newly produced type 3 collagen. So it really works. It increases the elastin and collagen production. And I have been giving lots of lectures and trainings, and my colleagues, doctors, are asking me what happens. We have Hyun days in HA, but we have anything. So this is probably we will see it in the coming years, intralesional sodium thiosulfate or topical sodium metabisulfite. It has been approved for intravenous injection to get rid of the complications for the chemotherapeutic agent cisplatin. So probably in the coming years, we will see it. There are lots of expert consensus guidelines in managing the complications for CAHA. You will need, again, Hyun days. You will do the same things you do if you see a complication with HA. You will do the same thing with CAHA. Because of the capillary permeability increase effects, edema reducing effects, and anti-inflammatory properties, you need again hearing aids for complications of CAHA. And where to use how much, there are again lots of consensus guidelines. When doing it everywhere, we need to pay attention to the anatomy. Blunt cannula is preferred whenever possible. Aspirate before injection. We need low injection pressure. Every hand habit is different, so you need to choose the right filler for your hand. If you just push too much onto the syringe, definitely you will have a problem and complication. So you need a low injection pressure, and we need to give little amount with each pass. This is a fresh cadaver study. Should we choose blunt cannula or needle? Whenever possible, we need to choose blunt cannula because in contrast to the blunt cannula, the sharp needle material is placed in multiple anatomic layers in this fresh cadaver study. So the authors say, do it with cannula whenever possible. So these are before and afters for my patients. The afters are 1 month later. The treatment is with CAHA, and in the afternoon, I will be giving a workshop. If you have time, please come. I will be talking about, I chose, after my journey of 4.5 years with CAHA, I chose which product and how I approach the patient. So you can use in asymmetric doses, you can just treat the facial asymmetries, and you see the lifting, the increase in the skin quality, and the texture. And when a 60-plus patient comes, you can use it freely. 1 syringe, 2 syringes. You are not overfilling the patients. You are staying away from the pillow face phenomena. I think this is the important thing. And the patient, normally, when I used HA fillers only 5 years ago, my patients weren't coming back to me asking for the repeated dosage after 1 year. But with CAHA, with biostimulation, with lifting, with increase in the collagen production, and with improvement in the skin texture, they're coming to ask for the same treatment. So I think this is important. And they see the improve in the skin texture and lifting, and they're coming for the same treatment again. So these are all 1 month later than the facial treatment. And because I'm a plastic surgeon, I have a media room. So my all photographs before and afters are taken with the same machine, with the same LED lighting from the same distance. So I care about these photographs very much because I see lots of bad before and afters, which doesn't really reflect the result. And I think biostimulation and the CAHA treatments are will be the new era. I know that the biostimulators are being used hugely. So this patient had an asymmetry because of a previous trauma, right-sided soft tissue atrophy. I will be showing you how I approach to the patients in the workshop in the afternoon. So I used asymmetric doses for the mid-face, for the cheek and zygoma, but the effect goes for 10 to 12 months. In patients like this, I am asking the patient coming back in a very short period, like 6 months, to do the repeat dosage, again in asymmetric doses. And the patient is always happy. My private practice is in Istanbul, Turkey, and if you ever visit, please be my guest to visit me at the clinic. And if you want, you can reach me anytime, anywhere. Thank you so much for the invitation.
Thank you, Doctor. And now, if we have any questions for any one of our speakers. Can we hand the mic, please?
طيب يا جماعة، دحين صلاة الجمعة حتكون إن شاء الله في مسجد القبلتين، في باصات حتكون موجودة in front of the convention center. So there will be buses taking you to القبلتين mosque there إن شاء الله. And I think the break time until 1:15. So thank you all. 1:15 ها، لا حد يتأخر. حياكم الله.
Good afternoon, everyone. Thank you so much for joining the afternoon session on Friday. It's my great pleasure to welcome the next speaker, Dr. Omar Foda, to speak with us about the adding regeneration to shaping. And this also session includes a live demo. Dr. Omar Foda is a Canadian board-certified academic plastic surgeon at King Saud University in Riyadh and private aesthetic practice. He also has a master's degree in health management from McGill, and we're so glad to have him here with us today.
Good afternoon. Thank you for the invitation, and I hope this will be an amazing conference. My name is Omar Foda. I'm a plastic surgeon from Riyadh, and I would like to be adding a little bit of a different angle to the presentations with the surgeon's perspective about how could we add a rather newer methodology of anti-aging regeneration to shaping. I have no conflict of interest with any of the products. So it's very important to understand that aging comes along the different layers of the face. Primarily, we as plastic surgeons, we were concerned with the deeper layer and the skin. So we were working on two layers, the musculoaponeurotic layer, which we know as mass or platysma or frontalis, and the skin. And many of the treatments were based on tightening these two layers. A lot of the treatments in dermatology were based on improving the surface of the skin and adding volume to the upper fatty layer of the face, that being the malar fat pad and the other fat pads in the skin. And we were getting good results, I think, but we were missing that aging is a phenomena where a lot of it has to do with the laxity of the ligaments and the thinning out of the skin. So if you want to talk about the evolution of aesthetic medicine and surgery, so we have the surgical solution. Surgical lifting primarily addresses the skin layer and the deeper muscle layer. The volume filling, we do it with fat, we do it in the clinic with fillers, you guys do it with fillers, different layers, different thicknesses, we'll be talking about them. But again, we're addressing one layer of the face, we're addressing only the fat pads, and we're trying to work around it by injecting deeply over the muscle to give the appearance of the fat pad. Different discussions about the dynamic and the static fat pads and where should the fat go, and if we inject, does it move with dynamic movement? Now, in the last, I would say, 10 years, we moved to biostimulation, where we understood that a big part of aging is the changes that happens in the collagen. Many biostimulators are around, available, PLA-based, calcium-based, polynucleotide, and etc. And now we're into an integrative regeneration process where we are addressing or hoping to address all the signs of aging in one procedure, whether being surgical or non-surgical. So the previous expectations of patients were different than the current expectations. Patients now are expecting more natural looking results. Patients are expecting more appearance of young looking without being filled. And I think that's very important to understand, because the longevity of our results has to be explained properly to patients. So I started pulling out some of the earlier results that I had, and this is a patient in her late 60s. She initially presented to me requesting a blepharoplasty, an upper and lower blepharoplasty. And although, as you can see in her one-year post-op pictures, I mean, she has a significant improvement in the skin of the upper lid. I believe she has significant improvement in the bagginess or the fat pads of the lower lid. I routinely use on Fitzpatrick 1 and 2 some sort of a fractionated erbium or CO2, which was the case for her, so we improved the surface of the skin. However, I think we missed improving the quality of the skin. And that's what I think we are in now. The fine wrinkles, the pores, how thin her skin is, this is something that we now discuss with patients routinely, that it was not the case when I did this case around 10 years ago. So let's define what do we mean by biostimulation and true tissue regeneration. we are talking about resulting in a natural structural layered support where we are addressing volume alone. After that, we're addressing the dynamic movement and how we can improve the dynamic movement. And we're addressing the skin quality, whether that being adding hydration to the skin or thickening the collagen layer of the skin. There are many biostimulatory agents available on the market. I would say the 4 families of agents are the calcium-based, so I'm sure everybody here is familiar with those. They improve both collagen type 1 and type 3. They are injected for volume without dilution. They're diluted 1:1 or 1:2 or 1:5, depending how you want to use them. Second family would be PLLAs. PLLAs are usually in a powder form. They come and we dilute them. PLLAs, they induce a foreign body reaction, and they actually are significantly a tissue remodeling agent because they actually improve the thickness of the upper layers of the skin. Polynucleotides, whether it's PN or PDRNs, are one of the newer agents that we have. PDRNs are used for wound healing. PDRNs are used in combination with calcium. PNs are also, it's a bigger family of PDRNs, are used a lot for tissue regeneration. And many of the newer formulations of HA have a lot of free HAs in them, and they are working more as a hydrating agent. So we have the thinner material. I like to explain many of them as the vermicelli or the thin pasta, so we can inject them very superficially under the skin, and we're really getting hydration effect rather than volumizing effect of the classic fillers when we started doing fillers around 15 or 20 years ago. We have discussed a lot, and a lot has been published about the cellular response to biostimulators. Do they really work? And how do they work? And I think this is well studied in histology. The effect on fibroblasts and the effect in collagen type 1 and type 3, especially with calcium-based, or type 3 with PLLAs. I think we have to understand that different types of collagen give different outcomes in the body. So collagen type 1 will give more structural support. Collagen type 3, which is around 10 to 15% of our collagen, gives more elasticity. And I believe we need both for a younger, fresher look. So what happens? Beyond volume loss, we want to talk about bone resorption. We want to talk about ligamentous laxity. We want to talk about fat descent and atrophy. We want to talk about dermal degradation. And if we don't think about all the layers of the face, we're going to lose the proper outcome in patients. And other than that, we're talking about it in layers. So this applies to surgery when I do a facelift and I'm doing different layers of fat. So in our world, we'll call it structural fat and microfat and nanofat, depending what we want to do with it. And in the non-surgical world would be different types of fillers with different thicknesses, with different G primes. And the idea is to use a higher G prime for structural support, being a volume-based filler deep on the bone. The same way we are using structural fat grafting deep on the bone for volumization. And then in a separate layer, we'll use something that is thinner. In the surgery world would be microfat during a facelift. And would be something that has a moderate elasticity, moderate G prime, to be used in areas where we need a combination of volume and elasticity. And something much thinner for the outer layer of the skin, that being what we call the thinnest type of fat or nanofat. And in the non-surgical world would be many of the thin lines that we're going to use, and we're going to explain some of them today, that have a lot of free HAs. They're non-cross-linked, similar to the other HAs. They give hydration without adding volume. So this would be a layered approach. And that would be different than the biostimulatory effect of some other agents. And now we're in an era, we'll be talking about the hybrid fillers as well. So another patient of mine, 1 year post a facelift. What are the changes have I achieved to correct what she needed? She came to me complaining about skin laxity all over the face, deep nasolabial folds, deep marionettes, jowls, lack of definition in the jawline, platysmal bands. I mean, you can see all the changes that she had. She was interested mostly in a face and neck. I discussed the brow lift, I remember, and she wasn't interested. So I believe that this patient had reasonable volume, so she didn't need a lot of volume exchange. She had a lot of changes on her skin, which at that time, one of the only modalities I had was a fractionated erbium, so which we did for her. So I did a deep plane face and neck lift with nanofat grafting and a fractionated erbium. But have I missed some of the areas? I believe nowadays a patient like this will benefit from a pan-facial nanofat grafting, as well as many of the modalities to improve the quality of the skin. And what we're doing differently now is that we are, after the surgery, using the biostimulatory effect of radius or combo fillers on the skin of the neck, which I think is one of the best areas that you can use these type of fillers in, because surgery or lifting addresses laxity, and fat grafting will address volume, but none of these will address the thickness of the skin. Many different types of hybrid fillers. I'm learning this from you guys, so you are aware of this, combining calcium with HAs, combining calcium with PDs, combining calcium with newer material like the NCTFs, and this will give an amazing result on the surface of the skin. So a treatment plan has to be done. I usually spend 45 minutes with any new patient. Kind of in my examination, I'm going to try to explain this today with the live demonstration. Try to understand what the patient wants, try to understand what her expectations are, and kind of tailor-tuck the treatment plan for her needs. This is a patient that I've done an isolated neck lift on because she was not happy with the creeping of the neck. So I did the procedure. She looks much better, but she has such a thin skin that I felt that I'm missing something. And nowadays, a patient like this would be an excellent patient to introduce a biostimulatory agent to it to improve the quality of the skin of the neck. So we'll be talking later on about the dilution of these agents. Should we hyperdilute? What are the effects? What should we be diluting with? Should we be diluting with other agents? So many of the mesotherapy techniques you can dilute with calcium and gives a nice result in the neck. And there's quite a bit of clinical evidence in many of these products. Calcium has one of the best clinical evidence in collagen type 1 and type 3, and with a longevity of 1.5 years to 2 years. PLLAs have a longer longevity, but mostly with a type 3 collagen, and they are structural remodeling rather than regenerative agents. And I mean, I will pass the histological evidence for the purpose of time, but I want to see that it's not only surgery and injectables. You guys are the experts in device space, and if you guys, or some of you guys not doing this yet, I think the combination of many of the high-intensity ultrasounds with a lot of these agents will yield an amazing results. For example, I have in my OR now a radio frequency microneedling device, and I have a microcoring device that I use even in facelifts immediately in the area perioral and periorbitally, because I think a lot of the areas in the forehead, around the eye, around the mouth, will not change with a surgical procedure. And unless I have the capacity of introducing a radio frequency device to tighten that upper layer, and then coming later on and injecting a biostimulatory agent under the skin, I will miss the real bigger picture of the aging process or what the patient goes through. So let's conclude this by saying that I think the future is promising, and I think the more all of us understand the outcomes of these agents, the more all of us understand that to really combat the aging process, we need agents that address each layer of the face, and we need agents that will give us the results that we want in a natural way. At some point, surgery is the solution, but I think early on, many of these agents will delay the need for any surgical intervention. Thank you.
Thank you so much, Dr. Fodder. That was a great session. I think now we will see a live demo on injecting biostimulator. So while we are getting ready for the session, do you guys have any questions to Dr. Foda? Maybe we can take some questions.
Is it working? Shall I?
Anyone? Are you all guys using collagen biostimulator in the clinic, combining them with devices? Yes, I see people knocking their heads. Okay, perfect.
Sure. كيف حالك؟ ايش اخبارك؟ تمام؟ ما في اي مشاكل صحية؟ كله تمام؟ So the part usually, so the purpose of this live injection session is to kind of share our experiences. I come with a different set of eyes, mostly from a surgeon's set of eyes. ممكن you have masks? يعطيك العافية. And I think the most useful part of it is to, and that's what I do when I go to my colleagues' offices, is to share how both of us assess the face. Do we see the same things? And we can have this as an interactive session. If you guys see something that I don't see, or if you guys have any suggestions, we can do it. I'm left-handed, so I'm usually on the left side of the face. I want her to see in the mirror. What do you see? You're a shy person? Don't worry about them. It's only me and you here, and the nurse. Okay. Do you have a cotton tip? Cotton tip. لا مش قلم, cotton tip. في cotton tip عندك? Right, so what she just told me, it's going to be easier for me without a mask. So what she sees, they have her, and I think we want to bring this up so they can see her directly. ممكن نطلع هذا. البس الظهر. So I want people to see you. Come on. Go. Bring the camera up. Come on. Go. Maxim? Maxim. طيب. So go again. So she was just telling me that what she sees is what I saw before previously, that she works in the healthcare field, correct? And that she has long shifts, and she sees a bit of hollowing under the eye, which, if you agree with me, of course, I reviewed her pre-op pictures. I've seen in her pre-op pictures more hollowing in the right eye more than the left eye. Have you seen that? And that's something that we can discuss how we treat that. I mean, there's a surgeon perspective and there's the non-surgical perspective of what's the best way and what's the best type of material we use for this. You were talking about the temples. منطقة الأصداغ إيش كان ضايق فيها? So she was talking about her temples. Her temples, she was not happy with the fact that there's a little bit of hollowing in the temples. Couple of techniques, cannula-based, needle-based to inject the temples. We'll be discussing in a second. What else? إيش كان ضايق? Okay. So the last thing that she wanted to address is the definition of her jawline. And if you can see, perfect, we can see it. In her profile view, she had a little bit of protrusion in the chin and a little bit of lack of definition in the jawline. I don't think she needs any volume per se in the cheek. So the way I assess patients when they present to me for any non-surgical or surgical facial intervention is that I divide the face into thirds. So the thirds being the upper face, the middle face, and the lower face. So first of all, I mean, we can move structures a little bit by injections. Does she need any movement in the upper face? I think her eyebrow is in a perfect position, where it sits perfectly on the orbital rim superiorly. She has a little bit of hollowness in both sides here in the temple, which we can correct with either a gunshot technique, which is a technique described by Arthur Swift from Montreal, all the way down in the bone, and at that point we can use a thicker filler. We can use a volume in case of art fillers, a volume or a universal, or another technique which is less precise in my opinion, but does the job, which is a cannula technique, going from underneath and filling up a little bit of the temporal region with a more thinner type of filler. In Filmet's case, it'd be a universal filler. to give the appearance of fullness in the temple. We have to understand where the temple hollowing comes from. Temple hollowing with age, she's very young, so I'm not talking about her, comes from muscle atrophy. But with a lot of people, they lack the muscle volume in the temple region. And of course, in the lower temple, we have the fat pads. Let's move to the eye area and the mid-face. So in the eyes, normally the orbital retaining ligaments, which is basically the ligament all the way down here, separates the lid, the lower lid from the face. A lot of people they're tired, they have puffiness in the face, and would seek a more unified transition, let's call it, between the eyelid and the face. And one of the easier way of achieving that transition is injecting a little bit of filler, whether superficially with a cannula or deep with a needle. I might do this a bit differently than many dermatologists because a lot of people will do this area with cannulas. And I think cannula does a great job if you're using a type of filler that is not going to cause a Tyndall effect. The issue with using cannulas or using a thicker filler here is that people are prone to overfilling. It's an area that has a lot of lymphatic drainage. And if you overfill in this area, you will have puffiness that is very hard to correct. And I think the worrisome part is that even if you liquefy it, the filler will go away, but the edema will persist because of the scarring that happened because of the filler. And we shouldn't underestimate that it's really the puffiness, the swelling, the edema of the lymphatic that some people are bothered with rather than the old filler that they had. They always come back to clinic saying that the filler didn't go away, but they're really worried about the puffiness that they have. I'm going to move forward down to her mid-face area. She's very young and she doesn't need much work done in her cheeks. She has an excellent cheek volume, excellent positioning. This is an area where in the ideal facelift patient, they will need movement of the descended malar fat pad because that's an area where the nasolabial fold becomes very deep, the marionettes become very deep because of the natural laxity that happens in the ligaments and the descent of the fat pad. Now, a lot of people would seek definition in the lower face, and I think that's what she's looking for. If you can, I don't know if you have, or if you can go her profile view, she would benefit from a little bit of definition. I would say a 0.3 to a 0.5 only of either a thicker material like a volume in the mid-chin or a thinner material like a universal directly on bone in the mid-chin area. She needs only a one-point technique. People as they age, not in her case, might need a bit of filler on the edges to more define and reduce the appearance of the fold. Going to her lateral cheek, she has an excellent contour anteriorly. I think she lacks a little bit of definition in the angle. So she is seeking a mild correction of the angle here. And this is something that we do directly on bone as well. Could be done by a superficial injection. I would rather shy away from it. Volume or universal directly on bone. This is something that we do, and we're going to go through the masseter muscle. But a small injection will add definition to this area in a nice way. So to recap, I think we'll be doing temples on her. We'll be doing the right eye. And we'll be doing a bit of a lower face, for the interest of time, a lower face contouring. So we'll start by the temples. Perfect. Can I have some alcohol? And let me actually give me a pen first, the pencil, sorry. So I'm sure most of you, most of you know this very well, but I'm just going to explain it because I'm doing it. So the gunshot technique is usually 1 centimeter above and 1 centimeter lateral to the lateral orbital rim. So you feel this area, which is basically all the way on the outer crest of the orbit. This is the end of the superior temporal line. When we do a brow lift surgery, usually the incision for a brow lift surgery comes from here, which is hidden behind the hairline. And we have to release this anterior orbital or anterior temporal crest. The anterior temporal crest is easily palpated over here, so I can feel her on temporal crest. And then this is where there is a strong ligamentous attachment. Behind this, there is a temporalis muscle. So there is, in front of it, there is the frontalis muscle. So from here, I'm going to draw her frontalis temporalis. And essentially, we know from anatomy that the temporalis muscle looks like a V or a funnel, and inserts all the way down in the coronoid process of the mandible. So in the temporal fossa, which is bounded anteriorly by this ligament, this is the area we want to add volume for her. So if we are 1 centimeter above and 1 centimeter backwards, we're limiting our injection in the most anterior aspect of the temporal fossa. The idea of this is to make sure that we're avoiding filler migrating all the way posteriorly. You'll see that I'm going to be blocking any migration by my hand, because otherwise we're going to be using a lot of material to inject the entire temporal fossa without a real purpose or without a real need. So an area like this would be injected, we're using a 0.5 cc only of filler. We can use more. The same will apply to the other side. And we're going to make sure that we are directly in bone because we're injecting a bigger material. Timing is clear. We're good for time? So I'm good until 2? 10 minutes? Okay. The same technique will be done through a cannula. Cannula can be injected from above the zygomatic arch or below the zygomatic arch. You basically pass your cannula above the arch and all the way, and you're filling in more of a superficial aspect, superficial area under the skin in the layers. Of course, we have to understand the layered anatomy of the temporal area, because we have the temporoparietal fascia and the 2 layers of the deep temporal fascia. So in an injection that is superficially, we want to make sure that we don't overdo it because it's an area that can receive a lot of fillers. I'll start by explaining everything, then we're going to inject for the interest of time. So let's go downwards all the way to the orbital area. So another area that can be injected by cannula or by needle, this is the area I'm concerned about. It's the area that basically shows like a groove between her lower lid and her cheek. One of the classic ways of doing it is coming from the lateral aspect with a cannula, injecting superficially in a retrograde fashion to really fill the groove. I shy away from this because I've seen my fair share of Tyndall effects happening with many types of filler. So I would inject in the inner tear trough in 2 or 3 locations, aliquots of 0.1 cc only, directly on bone. And I think that's a technique that, if done properly and in a safe way, it's a very safe technique for people who experience that. And you can add 0.3 and maximum 0.5 in other cases for patients who suffer from a little bit of hollowing with an excellent result. متضايقة من الجهتين ولا بس اليمين؟ And then I guess the more straightforward type of injection here is injecting a little bit over the bone. I think we both agree that's the better way of injecting it. On the chin area, we're going to be injecting directly on bone in the midline. This is the area where the mentalis muscle works, and injecting all the way down. Of course, cases like this, the use of toxin, any kind of botulinum toxins, will improve the irregularity that happens with the mentalis muscle, and will give a much smoother contour for the chin area. So another bolus here of 0.5. In older patients, we can go up to 1. And the same will apply for the lateral jawline, where we can have a bolus directly on the angle of the mandible. So let's start the injection, and if you guys have any questions, I can receive them as we go. So let's start by needle. Needle معاه. Okay, so I'm going to do it quickly in 5 minutes. Perfect. It's a lot in half hour, a lecture and an injection. Needle. So I'm going to try to, if you guys have any questions, we can do it while we inject. And I'm going to try to finish it in around 5 minutes or so. The needle اللي معاها لو تكرمتي. So that's A. ايش فتحتي لي؟ لا بس which one was open? A universal ولا universal? So this is an area that we inject with a universal or with a volumizing agent. And I'm just going to go, can I have some alcohol swabs, please? Alcohol swab. Sponge. 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 So I might show one side, and then we'll take the rest in the back. I'll fill it up for her. So I'm feeling the lateral orbiter, 1 centimeter above, 1 centimeter back. I'm directly on bone here. So it's an aliquot of 0.5. Perfect. Let me just come from here. And the idea here is that I'm always feeling the rim, going 1 centimeter above and back, injecting. I'm trying to avoid all the vessels. And with my contralateral hand, I'm blocking any migration of the filler backwards. A little bit of pressure. Of course, an area like this can receive double this amount. And many patients have a bit of asymmetry, but if you can see in the picture or the video, this is a nice contouring effect without adding significant volume for her. So we'll go ahead with the fine line. Alcohol, please. No, needle. Alcohol. Sponge. So there are a couple of techniques of injecting. I'm going to try not to block the camera. I'm going to do it from this side. So this is an area that I understand a lot of people always want to inject with a cannula, but this is a fine line. Of course, the lighting is not the best here, but I'm directly on bone. 0.1. It's enough. Feeling the bone. Any pain? No. Aliquot of 0.1. And then I'm going to add some more alcohol swab. Alcohol swab. Okay.
Yeah, because of the lenses best.
Okay. So I'm directly on bone. Aliquot of 0.1. Directly on bone. So we're familiar with the area because we do a lot of transconj blepharoplasty. And this is exactly where we do fat repositioning when we do a blepharoplasty. So I've used only 0.5, meaning 0.2 on this side. And if you can massage the area like this. I don't know if the lighting is good enough, but a 0.3 and a 0.2 in this area is more than enough. Deep on bone with an agent that doesn't give much volume. Of course, you can always add some more with a cannula on top of that, but I like to inject deep on bone in this area. I will add a little bit for the right eye. Right here, شوي. And I'll continue the rest in the back. Give me a volume. So the last thing I'll do for her for the interest of time, relax a little bit.
1 minute, Dr. Omar.
Yeah. I'm going to be doing this to chin for her. And the chin technique with a bigger or a thicker material will be a 1 injection in the midline of a bolus of around 0.5 cc. So directly on bone under mentalis. Perfect. So for the interest of time, I'll do the rest in the back. But this is a technique of a bolus injection for the temporalis region under eye correction with a thinner material. So I use universal for the temples. I've used fine lines under the eyes, and I've used the volumizing agent to give her a little bit of projection for the chin. Thank you.
Thank you, Dr. Omar.
Sorry, we are a little bit overloaded with the lectures. I'd like to introduce Dr. Salma Al-Barqawi. Dr. Salma Al-Barqawi is a consultant dermatologist and assistant professor at Imam Mohammed bin Saud University in Riyadh, and she will talk about the new paradigm in skin regeneration and collagen stimulation.
Good evening, everyone. I'm sorry, my voice is a little bit shaking off. First of all, I'm really happy to be in Al-Madinah Al-Munawwara. This is the perfect spot where our heritage and Islamic heritage started. So today I will talk about a new concept and something we are facing in our clinic. So I will tell you a story that every one of you see in their clinic. Sorry. Every one of us, we have this patient, like 45 or 50 years old patient who has her makeup on, who's confident, and she came to you and she sit down, and without any word, she will look at the mirror and touch the cheeks or the jawline and tells you that I don't look like myself anymore. So at that point, we all know that the patient is suffering from the aging and the consequences. She look at you saying that I hydrate, I do Botox, I do lifting with filler, but still something is missing. I'm still not me. My face doesn't match my spirit. And as we get older, we are from inside the same people when we were in 20s, but our looks differ. That's when we all know that we have to do something about it. So what about a treatment that would give the skin some boosting effect and immediate effect and make the skin to remember how it regenerates itself as it is been in the 30s and in 20s. So we have, the skin is getting older, we are still having, the collagen is fading, the elastin is breaking, and the skin is dehydrating. So this new paradigm of skin treatment is for hydrating and boosting the skin, giving it immediate glow and immediate result, while working on the understructure of the skin. So making the skin remember how it used to generate or regenerate itself. So we all know that we need to have all our weapons to make the aging less effect on the skin. But the whole weapons are not enough. We need to add something else. When I was a resident 20 years ago, when we have the exam, when we study about the fillers and the Botox and the lasers, I remember that when we come to the section of the PLLA, we don't read it because they said it's not in the market anymore. Then suddenly, you never know. Now it is the talk of every company, and it's the infrastructure of regeneration of the skin. So here I present some of the new product that it has an immediate effect of boosting the skin with peptides, with vitamin C, with hyaluronic acid, which will give you an immediate effect while working on the collagen stimulation with poly-L lactic acid. This is really has been popular. The thing about this new product, it has, you mix it at the same time. It's not already mixed, because when you have the product already mixed, sometimes it precipitates and it would promote nodules. So having these products separate, you can have the both results at the same time. Then this woman will have the glow, she will have the hydration, she will have the lifting. Also, her skin will remember to regenerate itself and to build collagen on the long term. So it is it's not something to be underestimated. It is what we call that science can do magical stuff. So a lot of patients, when we do for them this treatment, they come out of the clinic happy, glowing, having this glow everyone is asking about, and at the same time excited to see more and more on the long term. So this is a game changer in the field of aesthetics and cosmetics, and it's really has a good potential, as it is medically proven from the USA. Also, it is a medical device. And in the last year, I was really invested, and everyone around me will know how much I'm invested in the medical device and the cosmetic, because it is a really big thing in our practice. Maybe when I get more mature and we have more patients, we are afraid to use any material that's not approved for injecting. So the first question anyone would ask me, medical device, cosmetic. When they tell me medical device, I would listen to the rest of the conversation. When it's not, I wouldn't be interested, because this is a gray area, and we don't want to be in that gray area, because if anything had been gone wrong, the first one to be in trouble is the physician and the patient. And no one would protect you from that. So as I told you, our product we are launching, I don't want to say the names, but it has hyaluronic acid, peptides, vitamin C, and also poly-L lactic acid, 170 milligram. So the protocol for injection, it's like the protocol of any poly-L lactic acid. You inject according to the patient's need, according to the patient features. Some patient will have this injection every month, then every 3 months, then every 6 months, and once a year. Or you can make it 2 vials, and the patient come every 6 months. I think the treatment should be tailored according to the patient need and the patient situation and the physician accommodation, because not all patients are the same. You would know, you would build a rapport with your patient according to their need, and you will reach a solution that will suit both of you, and it will be appropriate for all of you, all parties. But the thing that I called magic is making the patient going happy, having the glowing effect, having the filling or slightly lifting effect with the promise that it is working slowly to make the skin remember how to regenerate again. And this called medical treatment in scientific way. Here where science meet magic. The treatment protocol I will explain when I will do. It's different, as I said. Each patient is different than other. Even the same patient, I might inject first session differently than the second or the third session. The key is to explain to the patient how this works and what to expect and how this would give the patient the it factor that would make the patient feels that her face matches her spirit and she didn't get older, and finally she will be happy and satisfied, and this will make you also happy and satisfied that you met her expectation. So I will go very, very quickly because all of you, you know the scientific part of the PLLA. In adding to the PLA, we have the hyaluronic acid, we have the peptides and the vitamin C, which make it that patient will have this dual effect of the results. So here, comparison, and that was it.
Thank you so much, Dr. Al-Qawi. That was great. So we're moving to the third talk and the last talk of this session with Dr. Abir Abdushakur. She will give us a talk on her philosophy on botulinum toxin injections for the upper face. Dr. Abir is European and French board certified plastic surgeon. She is a triple fellowship trained.
Okay, I will try to carry both. Good afternoon, everyone. Thank you so much for having me in this conference. Lovely organization and really above expectation. Of course, we're very happy to be in Al Medina. I had the chance to go to Al Haram Al Nawawi yesterday, and the group here helped me so much achieve that, so thank you very much. So today, I'm going to be talking about my philosophy in injecting botulinum toxin. I'm a KOL of injection, and I first learned these techniques in working with a facial palsy surgeon. So we were working on facial palsy, very complicated cases, and learning Botox on those cases made me fall in love, and now I'm always coming up with techniques and studying new products. So I'd like to call my philosophy art, which includes anatomy, rhythm, and tone. Nowadays, we're into regenerative medicine, but Botox or botulinum toxin is a very important staple. So frozen looks are out, and natural expression is in. We have to use all the regenerative manners that we use, but botulinum toxin stays essential. So I'm gonna go not too much in depth, just to explain my triangle. First of all, anatomy. We examine the anatomy of each individual patient, trying to define the thickness and the distribution of the muscle. We're trying to find the points that we want to inject Botox on. And next, we look at the muscle groups to achieve rhythm. So whether we want to lift the eyebrows up or minimize the lines of the eyebrow, of the forehead, we have to compare the groups. We have to make the patient make movements. For example, here we have an example of corrugators and frontalis, depressors versus elevators. And this determines the dose and the number of points. Third thing, everybody has their tone. The facial expressions are an important staple in showing identity. So it's not just features that we don't have to change, but also movement. I think you all know this. I just had to mention it. The mechanism of action. We all use botulinum toxin type A mostly. Type B is not commonly used. The onset usually is 4 days to 1 week. Some products, I saw results in 2 days. And usually the peak effect, I think, is in 2 to 3 weeks. I don't do retouches usually, but if I do, it's at 3 weeks, not at 2, because you might correct too early and regret it the next 2 weeks. Consistency is very important. I think aesthetic treatments are an experience, not just results. I have a face chart for every patient. I mark it every time I inject them, not just the first time, not just the second time. I keep on adjusting what I do, and every time they come back, I don't take much of their time. I ask, did you like what I did last time? Is there something you want to change? And I adapt according to the marking. Of course, I use an automatic injector. It's called Juvapen. I have no conflict of interest. My dilution is 2 mLs per 100 units, so this injector makes me inject more concentrated doses. And per 0.04 mLs, I get a dosage of 2 units. Usually, I don't change the 2 units. I just increase the number of points while injecting. If I want to have a stronger effect, I try to keep it 2 units per injection. But for people who use the regular needle, they can use 2.5 mLs dilution per 100 units. That will give them the same 2 units per 0.05, and that's easier to control by needle injection. So this is the main takeaway, this is the main point of my lecture. Anatomy versus units. It's always anatomy over units. We've learned in medical school that, for example, the forehead, people use 16 to 20 units. I don't know, orbicularis, I don't use those units. I just examine the patient, look at the muscle, and adjust my injection point according to the strength of the muscle and the rhythm of the groups, while preserving tone. So today my lecture is focused on the upper face muscles. For the frontalis, I know people say forehead lines, but I'm going to address muscles. Again, we're not addressing the wrinkles, we're addressing the muscles themselves. So for the frontalis technique, the most important thing for me for the frontalis when you examine the patient is finding the divergence. There's a divergence line in the frontalis muscle that separates its 2 functions. The function of the lower 2/3 is to lift up the eyebrows, but the function of the upper third is to pull down the hairline. So injecting under the hairline will not give you any eyebrow ptosis. I divide my doses between the middle third of the forehead and the upper third. I never inject the lower third, and that's a common rule, but I like to explain it according to anatomy. So for the glabellar horizontal radix line, which is the per-series injection, very easy. You just examine the patient. Don't inject too high. Inject on the peak of the per-series muscle, the most prominent part. I inject 2 to 4 units. Males usually 4 units, females 2 to 4, depending on the patient. This is the fun part, corrugator. Corrugator has very interesting anatomy. Of course, it gives you classic angry 11s, but if we look at the muscle in depth, we will find things more interesting. We have an anatomical variation in the corrugator. We have 3 types, the narrow ribbon, which is the most common type. We have the rectangular type, and we also have the fan-shaped type. Now, every muscle shape will give us different wrinkles. Usually, the first kind is where I use only 1 injection spot, because the narrow ribbon will give you only the typical angry 11s, so 2 central vertical lines. The rectangular type might need more than 1 injection, 1 medial, 1 lateral. The rule for me in injecting the corrugator is that I inject subdermal in the lateral part, which is the middle part of the eyebrow. And for the fan shape, it's going to give us another shape of wrinkles. Of course, I had I screamed at AI so much to make these videos, but I succeeded. So as you've seen the muscle anatomy, for the narrow ribbon type, with movement, you will get 2 vertical lines, the classical angry 11s. But when it comes to the rectangular type, you will have a wide muscle giving you several parallel lines. These are the patients that present with the omega sign. I never treat the omega sign. I just examine and inject each muscle individually according to the shape of the anatomy. The third type and the least common is the fan-shaped type, which will give us, as you guessed, several lines, but they're oblique, not horizontal. For this, I will inject 2 points. If the second line is prominent, usually it's not. So only for the rectangular type, where you have to inject the second part of the corrugator muscle. Now, moving on to the crow's feet. This is a fun part, and I published a paper about this special muscle. So for the orbicularis oculi, it's a muscle of movement around the eye, of the eyelids. Usually it's the smiley muscle. People who are very smiley, they have a lot of lines in this area. And in females, I like to inject it a bit higher to get the cat eye effect. Usually I don't inject above the eyebrow unless there's a sharp angle, and this helps me achieve my special cat eye. In the study I did, we reviewed the neuromuscular junction placement by mapping of several muscles, and we found that the long muscles of the face, or the other muscles, the non-circular muscles of the face, have the nerve ending in clusters. So injecting around those clusters is more effective. But those muscles I'll talk about in the other talks of the middle face injection and the lower face. But the interesting thing is, in round muscles like the orbicularis oculi and the orbicularis oris, the motor end neurons are distributed evenly. So they're all over the muscle, which means, and which we tried in our study, to inject in a retrograde manner, so while pulling the needle. And this gave us a more prominent result with lesser doses of botulinum toxin and a longer lasting effect because you are touching more motor end neurons. Of course, this was the way I used it when we first published the paper. Now I start towards the eye and I move backwards, and I feel like that gives me a wider area that I can use from under the eyebrow all the way to 1 point under the lateral canthal line. And that gives you a much nicer cat eye effect. Of course, my workshop was, it was early this morning. I talked about the cat eye technique and how to inject it. We had 2 patient examples, one male, one female. And the wide eye enhancement tip, these might be scary for the wide eye. I will talk about them because they're a way of managing some complications. We'll mention them with the complication. So, what are the complications of upper face injection? The most common one, I think, is the brow ptosis. Unfortunately, this happens if you use too many units on the frontalis muscle. It will get relieved in a while. That's what I tell my patients, if it happens. It doesn't happen a lot. But one lifeboat that you can use is injecting the depressor supercilii. It's just under the eyebrow, and if you inject deep enough, you'll end up injecting it instead of the orbicularis oculi. It's fine if you inject either or, but it's a lifeboat for patients who are having really a lot of brow ptosis. You can also re-inject the depressors, the corrugators and the depressors. That might save you sometimes, but it's better to avoid it. And then, for the lid ptosis. This reminds me of a story. When I first started my residency, my head of department was nice enough to make me inject 1 patient. Of course, I was too fast. So on the second point of corrugator injection, I was very deep. And he said, merde. He said something very bad, and he said that the patient will have eyelid ptosis after the injection. And he was sure, he bet on it. But after, the patient came after 3 weeks, and she had nothing, which leads us to the percentage. What do you think the percentage is for eyelid ptosis after Botox injection to the corrugator muscle? Anyone? It's 1 to 2%. It's not very common. You have to really try to inject the levator to be able to have the lid ptosis. So, how would you make the diagnosis? If the patient came to you and said, Doctor, I have lid ptosis, first of all, it's more common to be unilateral, not bilateral. The exam is, you take the patient's forehead and you pull it up. If it's relieved, then you actually have lid eyebrow ptosis, but if you don't, and if it's unilateral, it's most probably lid ptosis. You have to ask the patient, if you don't have before photos, ask them to show you pictures of them before, old pictures before the injection. If the picture, sometimes you might be surprised and you might find the lid ptosis present even before the injection. But if you really were unlucky enough to be one of the 1 to 2%, then we have two kinds of treatment. So we have the apraclonidine, which is an alpha adrenergic agonist. A pro tip for everyone, this is not easily found in the pharmacies, but you can tell patients to mu'lan, buy it from Noon. You find a lot of lifesavers on noon.com, it's very easy. There's another type, it's called oxymetazoline HCl, or it's called Apnic, I think, the American name. These injections, they're also alpha adrenergic agonists, but they're selective to alpha 1 and not alpha 2. And those give you less redness, less vasoconstriction, and the patient will have no side effects. These were approved by the US FDA in 2020 as a treatment of acquired eyelid ptosis. Unfortunately, it's not available here yet. They exist in form of nasal decongestants, but I never used them on patients. The other way of solving this problem is orbicularis injection. I don't have a photo, but I'll try to explain to you. So this is called the wide eye technique. This technique is used to make the patient have a wider eye. It's used in Horner syndrome and all of the problems that come with diabetic complications around the eye. So when you have ptosis, the problem is that you're affecting the levator palpebris superioris, which is in the middle section of the eye. So in order to override this, the drops will give you a raise of 1 to 2 millimeters, but sometimes that's not enough. So you have to inject the orbicularis oculi in the pretarsal part. That means 1 to 2 millimeters above the eyelid, the eyelashes, and it has to be on the limbus, medial limbus, lateral limbus. There are points of 2 units, so 2 units medially and 2 points of 2 units laterally. Your guidelines are your iris, medial limbus, lateral limbus. Some people I've seen doctors use this to give a wide eye effect even without complication, and some people inject laterally to give more of a cat eye effect, but you really have to go and inject on the eyelid itself. So just some pearls for the residents. Take the time to examine your patient. Aesthetic surgery is an experience. It's not just results. The patient has to feel welcomed. Use أملة even if the patient tells you, دكتورة ما أتعور عادي متعود أحقن بدون أملة. You will use أملة and you will wait 35 minutes with on your face. It gives me time to see other patients and it will give you a better experience. I also use a vibrator and I let the nurse move the vibrator with me at each injection point because I mark them on the face. It's easier for the nurse to help me and it's a much more pleasant experience, especially for men, because men get really scared when you inject them. So all of these give me good results. I use the face charts are very important for every file. The patient feels special and gets better results. And at the end, it's very simple. Don't follow lines, follow anatomy. You will get the most sophisticated results. Thank you so much. These are my records.
Thank you so much. That was a great session. So with this, we conclude the session and we can move to the next session.
Hello. Good afternoon. Now we go to the third session of today, which is beyond the breakout, treating at Anki and its sequelae. So the first speaker will be Dr. Maliha Saad. Dr. Maliha Saad, she's a dermatologist at Blab Clinic, Jeddah, French Dermatology Board, Fellowship Trained in Interventional and Regeneration Dermatology at Postgrad Claude Bernard University, Paris. And the co-chair will be today, there will be Dr. Azam Al-Khalifa and Dr. Khadir Attas. So, Dr. Maliha, the mic is yours.
Good afternoon, everybody. جمعتكم مباركة يا رب. I'm glad to be here today at Adam Academy. My topic will be about acne, break the vicious cycle. Together, we will walk through science, triggers, innovation, and treatment in acne. So let's talk about some facts about acne. 4 out of 5 teenagers are affected by skin condition, mainly acne. Acne is one of the top 3 reasons why patients visit dermatology office, and 41% of women between age 25 and 40 have skin problem connected to acne. It will start in puberty, as we all know. In girls, it will start between the age of 12 and 14, and boys around 14 to 16 years of age. 15% of women have acne presents after the age of 25 years. What is the aggravating factors? So, let's talk about the exposome. What are exposomes? Exposomes are the term that describes all the exposure in which the individual are subjected to throughout his life. It's mainly divided to external, like light, noise, environment, pollution; internal, or individual, like diet, physical activity, social, sleep, and tobacco; biological, like hereditary, emotion, microbiome, hormones, and metabolism. So let's talk about the main pillar to understand the vicious cycle of acne, so we can go through and understand how to break this cycle. As we all know, it starts by the hyposeborrhea, hyperkeratinization, and that will lead to inflammation that gives us the acne. So the first stage, that caused by the innate predisposition, the high sensitivity of the hormone. And we are talking here mainly about the stress hormone, the catecholamines, the epinephrine, and the norepinephrine. That will lead to increased sensitivity, that transform the testosterone to the active form that will irritate the skin and the sebaceous gland, which will lead to acne. As we mentioned, stress triggers the release of the stress hormones, the catecholamine, that increase the production of the microbiofilm of a very important bacteria that presents in the skin, and that recently was found the main cause and the main contributing in the formation of acne, the C. acnes strain. And that will lead us to the microcyst, the comedone, the different form of acne. Let's talk about the C. acnes, that previously known as probionobacterium. It presents on the surface of the skin and inside the hair follicle. Increases at puberty in relation to the increase of rate of the sebaceous secretion. Several types, but here we are talking about the major subtypes that are recently discovered by researchers that is responsible for acne, the RT4 and the subtypes 5. The presence of the C. acnes on the skin that leads to activation of the innate immunity, the induction of microbiofilm around the bacteria. To sum it up, this is the cycle of acne: the hyperseborrhea, the clogged, the hypersupuration, inflammation, and the comedone formation, and that's all started by the stress. And the stress, it's a vicious cycle that will increase the hormones, the stress hormone, and give us the final reason that it's visible on the patient's acne, that's mainly complaining about the several types of acne that we mentioned here, the retentional, inflammatory, and the nodular type. So a short video to understand the cycle. Starting by the emotional stress that leads to the oxidation and the C. acnes or other type of bacteria proliferation on the skin surface. Stress leads to hormonal peak, catecholamines mainly. That leads to more stress on the skin, visible symptoms, acne show on the face that will trigger feelings of anxiety, more stress, and the cycle go on. So the hormonal fluctuation that will increase the sebum production. Sebum production, clogged pores, that will lead to inflammation. Inflammation, it will lead to worsened breakouts. Breakouts, stress, further hormonal activation, and the circle go on. So the management principle of hormonal acne. As we all know, the topical backbone are retinoids, like benzyl peroxide, AHA. We have hormonal option, combined oral contraceptive, spironolactone, first line, for many patients that have hormonal acne that links to hormonal disturbances. Systemic therapies reserved for severe types of acne, like isotretinoin. We're all familiar with the latest guideline of acne treatment that were released by JAD in 2024. I will not go through it for the sake of time. Mainly targeting the microbiome diversity instead of full suppression, anti-inflammatory peptides nowadays are replacing long antibiotic therapy, selective androgen receptors inhibitor. Exosome nowadays are playing a minor role in the treatment of acne, but still under study. Laser in acne. Laser recently plays a major role in treatment of acne. We have the 725 nanometer laser gained FDA approved recently. It's targeting the sebaceous gland by destruction and shrinking that will lead to less sebum secretion and improvement in acne. So let's talk about acids in the management of acne, either hormonal or other type of acne. The alpha hydroxy acids, like glycolic acid and lactic acid, that will help exfoliation via weakening the corneocytes. That will reduce the post-inflammatory hyperpigmentation, especially in darker skin tones. It will improve skin texture and superficial scarring, and it increases the penetration of active ingredients in treating acne. So the recommended concentration, 5 to 10% as a daily skincare routine. We have many products in the market without mentioning any name that contain this concentration, either in form of serum, creams, or facial wash. 20 to 40% in clinic peel as a treatment of acne. I came across this very interesting study, as one of my colleagues mentioned earlier, the role of energy device in treatment of acne. The study compared efficacy of alpha hydroxy acid combined with IPL treatment. So the overall results, always, as we all know in our practice, combined therapy is the best therapy, especially in treatment. So they found that combining AHA with IPL treatment only, without any systemic treatment, gives a higher results than using IPL treatment alone versus AHA alone. So here are some synergetic ideas on how to combine AHA in the treatment. AHA plus retinoids that will enhance cell turnover, that will give faster lesion clearance without any scarring. AHA plus azelaic acid is effective for post-inflammatory hyperpigmentation, especially in darker skin tones. Usually and always avoid combining AHA with benzyl peroxide in some cases, as we all know, for irritation risk. Start gradually, 2 to 3 times per week. Always when we start slowly and gradually, this will lead to more adherence to the treatment, and then in the follow-up, we can increase gradually. This is another very interesting study that I came across. It was published in November 2025. Sleep disturbances versus acne. It's a comprehensive review. 18 studies were included in this research. How many of you ask patients with acne about their sleep quality? None. There's one person only? Okay. So they found that there is a strong bidirectional relationship between sleep and acne. Acne increases stress. That leads us to the vicious cycle, the starting pillar of this problem. Stress will lead to increase the hormones. Hormones will act on the skin and leads to acne formation. Poor sleep worsens acne through hormonal, as we mentioned, and the circle go on. Very important tips in the treatment of acne. The skin care routine at home is very, very important. It will improve the barrier and reduce inflammation. And containing active ingredients in skin acne treatment will help prevent the scarring and enhance the tolerance of prescription therapies like retinoids. So, breaking the loop requires multi-targeted approach. Hormonal acne is multifactorial. That's requiring targeted therapy. The innovation focus in new treatment that we can include in our practice daily. The daily skin routine is very, very important. That will give good outcome without any scarring or any scar formation in acne. AHA plays a major role in texture improvement and the post-inflammatory hyperpigmentation. Acne and sleep. Now you have to ask all of your acne patients about their sleep quality. Addressing sleep disturbances may improve clinical outcome. Thank you so much.
Thank you, Dr. Maliha, for this insightful presentation. And we'll keep the questions at the end. It's my pleasure now to invite one of the dermatology leaders in Saudi Arabia, Professor Samir Zimmo. Prof. Zimmo is an American board-certified consultant of dermatology based in Jeddah with pediatric dermatology subspecialty done in McGill University. Prof. Samir, the mic is yours.
Assalamu alaikum. If we ask the question, what is the best topical treatment for acne over the last 50 years? Retinoids. All the publication is retinoids. This actually started by Dr. Kligman in 1969, where after his research on the vitamin A acid with Professor Blevik from Germany, both coined the research for retinoids, and it became the standard of treatment. In 1996, adapalene, the synthetic retinoids, came on as an alternative treatment as well. But William Pace, since the 60s, in 1960, have the FDA approval for benzoyl peroxide. And he was mixing it before the invention of retinoids with sulfur to control acne. So all the treatments, the best treatment we have has been old, 50 years plus, but still we did not invent better than this. So why topical retinoids are the mainstay of therapy of acne? Because very simple, it works as the comedolytic, because this is the heart of acne, and it has the anti-inflammatory effect. Surprisingly, 50% plus of dermatologists do not prescribe retinoids. Why? And non-dermatologists, 32% do not prescribe retinoids for acne. This is the problem of doctors. Now this is the problem of patients. I did a cross-sectional study, and we found among 600 subjects, they prefer to put honey and yogurt, and I think it does not control their acne, and they end up with scars. العروسة في يوم فرحها المفروض تكون رافعة راسها مو وشها في الأرض، تتصور مع العريس ومع المعازيم أحلى يوم في حياتها. depressed، أهم من النوم، وشها هذه صورها اللي نزلتها. حب الشباب والscars. We have to treat acne to prevent scars, for sure. Scars could occur even in mild cases. Up to 28% of patients with mild acne develop scars. And the more severe is the number of scars. Post-inflammatory hyperpigmentation occurs in more than 60%, particularly in our skin color. And we base our treatment on the severity of the disease. And you can see all the guidelines talk about mild, moderate, and severe. Yet, in acne, we don't have a standard measure to measure acne. We have PASI for psoriasis, we have EASY for eczema, we have a lot of invented tools, but we have not agreed on one single treatment. Very surprising. Now, this is one of the standard, they say mild, moderate, severe, and very severe. So there is a big variation, even with the numbers. This is the 2024, this is the guidelines where 16 من علماء حب الشباب في أمريكا اجتمعوا، راجعوا 300 بحث نشر على حب الشباب، وفي النهاية وصلنا لدي النتيجة اللي طلعوا بيها. For topical, they don't recommend that use monotherapy لأنه الإفكاسي أعلى لما يكون fixed combination. The best is to avoid prescribing clindamycin because of the antibiotic resistance is high nowadays. So the best treatment now is topical retinoids with benzoyl peroxide. Retinoids. Now, this is simple, very straightforward, easy to diagnose, yet mistreated, unfortunately. Topical combination benzoyl peroxide plus retinoids or with antibiotic, and in the States they have benzoyl peroxide, retinoids, and antibiotic. You don't need antibiotic. Benzoyl peroxide works good as antibacterial. For more severe cases, you had to add oral antibiotic like doxycycline or use isotretinoin or the hormone spironolactone in particular. Now, the same guidelines is from Britain. Again, they positioned the adapalene benzoyl peroxide for the any type of acne severity, and it gave good results, as I will show you soon. And also they recommend using it for maintenance. So the fixed dose is very easy for the patient to apply once at night. It has an early onset of action within 1 week. After 1 week, they start seeing إنه بدأت تطفي الحبة. Favorable safety profile over tretinoin, less irritant. So adapalene is the synthetic retinoid. It's a comedolytic anti-inflammatory, and it has a small size, so it penetrates to the pilosebaceous unit very nicely and have a good efficacy. It acts on the retinoid receptor in the dermis and epidermis, both. So it acts to prevent the comedone formation. Both adapalene and benzoyl peroxide works on the 3 of the 4 main pathogenic of acne, particularly the hyperkeratinization, the inflammation, and the bactericidal effect of benzoyl peroxide. We have two concentration, 0.1 and 0.3. We have the 0.3, which is stronger. Why? When you have severe case, you want a rapid action, you can use the 0.3. If you have a sensitive skin, mild cases, you want maintenance, you can use the 0.1. So both could be used, both are good. If we ask the question again, what is the best topical preparation for the treatment of mild to moderate cases? This group of researchers got together and they published this systemic review of all the articles and meta-analysis, and they found that, again, adapalene benzoyl peroxide combination was #1 compared to adapalene alone or benzoyl peroxide alone, or with tretinoin and clindamycin. Number of lesions, again, the number of lesions was less than 20 lesions, was the best with adapalene benzoyl peroxide. These are some of the photos of the trials before and after 3 months. You can see visibly very good, excellent results. This is a double-blind, randomized trial, 60 centers in the States, Canada, and Puerto Rico, comparing adapalene benzoyl peroxide and adapalene alone or benzoyl peroxide. It's very clear that 30% reach clear. Clear means no lesions could be seen. Not 100%, but 30%, which is high, clear. Another study, but this time they included Europe, and 1670 مريض, find that it is also 37% achieved clear skin within 3 months. When you looked at the inflammatory and non-inflammatory lesion, it works nicely. In the inflammatory lesion, it decreased by 62%, and non-inflammatory in 58%. So it works nicely. What if we compare 0.1 to 0.3? Both work, but the 0.3 is stronger, minus 55%. So you have the chance, you can use whatever you like. These are some of the nice pictures of you see before and after 3 months. Before and after 3 months, this was severe, and they have added doxycycline to the therapy. And here, the 0.3 treatment. Now, the problem of acne, that it relapses. We know we can control it, but it relapses. So you have to discuss this with the patient and tell them to use it. Who relapses? The young age, females with polycystic ovaries, those who have severe acne, and those who have acne on the back, and those who start with large number of comedones. These 5 groups are the ones particularly that comes back. So maintenance is for everybody, 100%. We have to maintain treatment after the, so always tell the patient that we have 2 phases. Phase 1 is to control it. Phase 2 is to maintain what we have achieved. We know acne lasts from 7 to 14 years, so treatment is for 14 years. Even when you give isotretinoin, there is 20% chance of recurrence even with isotretinoin. And you know, all of us have used it, and we see that it's not a cure, it's just we control. So maintenance is very important. We know now that acne itself as a disease and our treatment retinoids does dry the skin. So both work on the skin. So the result is dry skin. What is the solution? Very easy. Decrease the amount, decrease the frequency, use emollients. And we have a lot of excellent, good emollients. Does it work? The answer is yes by this study. This study, they found that the patient adherence was good if you use retinoids with a gentle cleanser and a moisturizer. They don't see that much of flakes, and they are happy with the treatment and its results. احنا بعض الأحيان بنعمل تقشير في العيادات، الريتينويد بيتقشر من وحدها أرخص وأحسن وأظرف وممتازة. أنا one of the points I always discuss with my patients that it works على حب الشباب وآثار حب الشباب بإذن الله تعالى. كل الستاديز كمان الآن بتورينا إنها بتقلل من السكارز، الريتينويدز الوحيدة اللي بتقلل من السكارز. Others do not. So I hope I have encouraged you to use the retinoids. You can use a gentle cleanser, sunblock, a moisturizer, and oil-free makeup, and you can make their lives nice. نرجع للعروسة. إيش حكاية العروسة هذه؟ هذه في برنامج في استراليا في شركة بتوفق كراسين بالحلال. العريس ما يشوف العروسة والعروسة ما تشوف العريس. بياخدوا مواصفاتها وبياخدوا مواصفاته وإيش هي تبغى وهو إيش يبغى we match them. بيشوفوا بعض لأول مرة في ليلة الفرح. فهي مضطربة جدا مش عارفة إيش هل حيرضى بها؟ طبعا له الحق إنه يقول لأ. فهي متعقدة. فهذا أحسن دليل على قديش إنه حب الشباب بيأثر في النفسية وبيحطمها. The good news that he accepted her and finally they are happy. Thank you.
Thank you, Professor Samir Zummo, for your comprehensive and informative presentation. Now we'll proceed to Dr. Dana Al-Isa. She's assistant professor in King Abdullah and King Saud University for health specialties, and also she's American board certified dermatologist. She's also head of scientific activities in Saudi Society for Dermatology and Surgical Dermatology and Adam Academy. Dr. Dana, thank you for presentation of your nice and interesting name, Management of Acne and its Aftermath, Topical Solutions that Work.
Okay, thank you for the kind introduction. It's actually very hard to follow Prof. Zemmo, and bear with me, there will be some repetition since we're all talking acne. So my topic is managing acne and its aftermath, topical solutions that work. So we'll basically discuss the key ingredients in topicals that can help in managing acne. So as we all know, acne is a very common condition. More than 90% of teenagers are affected. It's also a major contribution for the use of antibiotic in young population, and it can negatively affect the quality of life. It can lead to significant complications such as scarring, and the etiology is not exactly known, and it's multifactorial, but it has been linked to hyperandrogenism, certain medications, and the use of greasy products. So why it's important to study acne and acne treatment? Because it can negatively affect the quality of life. Studies have shown that acne can affect social, psychological, and emotional status and the overall quality of life. It can lead to depression and anxiety and suicidal ideation. One study showed that more than 50% of acne patients were withdrawn into themselves, compared to 20–30% in other skin conditions. It can also affect work employment, it can affect going out with family and friends, and the personal self-esteem. So as I mentioned, the pathogenesis is multifactorial, but the four main pathomechanisms is hyperkeratinization. So there is increase or hyperproliferation of the keratinocytes, which leads to follicular plugging. There is also loss of balance between the Cutibacterium acnes phenotypes, which can lead to colonization of the bacteria. There is also local inflammation and release of cytokines, which can lead to inflammation. And there is also increased sebum production. As we all know, the presentation is variable. It can be mild, so it can be only comedonal acne. It can present with the inflammation, and the degree of inflammation can also be variable. It can be papules, pustules. It can be more severe, such as nodules and cysts. What about acne complication? It can also be variable. Complications include scarring, post-inflammatory hyperpigmentation, post-inflammatory erythema, as well as keloids. So as we all know, it's cheap to treat acne, but it's very expensive to treat the complications of acne. So it's very important to tackle and treat acne early on to prevent the complications. So we'll talk next about management. We'll start by general measures. So the recommendation is to use a moisturizer to reduce the skin irritation and the skin dryness that can be caused by acne treatments. And it's important to note that the moisturizer should be non-oil based and non-comedogenic. It's also recommended to use an acne wash that can contain salicylic acid, benzoyl peroxide, or other ingredients that can decrease seborrhea and treat acne. For other skincare products such as makeups and sunscreen, it's important to use non-comedogenic products. It's also important to avoid picking because picking can increase inflammation and lead to scarring. And there is insufficient evidence to support that specific diets can treat acne. So management is usually based on the severity of acne. So for mild acne or acne that is mainly comedonal, the first line of treatment is a topical retinoid, either monotherapy or retinoid combination, such as retinoid benzoyl peroxide, or the use of other products that have some keratolytic effect, such as azelaic acid or salicylic acid. If it's moderate, then we use topicals in combination to oral treatment, such as oral antibiotics or oral hormonal therapy that can tackle hormonal acne. For severe acne, we recommend the use of isotretinoin in addition to topicals. Also, as Mo mentioned, always use maintenance therapy after completing the treatment regimen because maintenance is important to prevent disease relapse. Maintenance, what do we use maintenance? We use usually topical retinoid or retinoid benzoyl peroxide combination or a dermocosmetic. So what is the role of dermocosmetics in managing acne? So it's increasingly being used and it's recommended to include in the treatment regimen because they improve the overall compliance and the treatment outcomes. So they can either be used as monotherapy in management of mild acne cases or to prevent the appearance of new lesion. They also have an important role to modulate the skin microbiome, making it potential alternative in the treatment of acne without the use of antibacterial products that leads to antibacterial resistance. The most common use of dermocosmetics is as adjunct. We use it in combination with other products to minimize the side effects of acne medication and because it can provide a synergistic effect by targeting additional pathogenic factor causing acne or improve the compliance, such as the use of products that can decrease the skin irritation and the skin dryness. It's important for use as a maintenance therapy. I think I need another mic, if you have another mic. So dermocosmetic can also be used as maintenance therapy to maintain the result of treatment and prevent disease relapse. So what are the key ingredients that we have to look for in dermocosmetics when we manage acne? So there are products that are keratolytics, such as salicylic acid, alpha-hydroxy acid, retinols, and glycolic acid. There are anti-inflammatory products, such as niacinamide, zinc. There are sebum controlling agent, again, such as niacinamide, zinc, Bacchol, and there is antimicrobial agents, such as the Lactobacillus plantarum. There is also products that contain ingredients that has a skin barrier protective effect, such as glycerine, ceramide, and panthenol. We'll move next to one of the most common complications of acne, which is acne-induced hyperpigmentation. It's frequently observed in skin phenotypes 4 to 6. It's mainly seen to moderate to severe acne. However, it can also be seen in cases of mild acne. And the prevention has a key role. We need to prevent the hyperpigmentation before it happens. And the recommendation is by the use of emollients, that is non-comedogenic, as well as sunscreen and dermocosmetics that has an anti-pigment ingredients. What ingredients we need to look for in products that has an anti-pigment effect? These include niacinamide, vitamin E, vitamin C, kojic acid, alpha-hydroxy acid, as well as many other ingredients. What is the pathogenesis, or how does post-inflammatory hyperpigmentation happens in acne? So the pathogenesis, it's not completely understood, but it's basically because of the inflammation. So you have an acne pustule or a papule that causes a local inflammation. They act on melanocyte to stimulate melanogenesis, and they also act on melanophages, leading to the deposition of melanin, leading to post-inflammatory hyperpigmentation. So this is a grading system that was put together by a French group that can help you assess the severity of acne-induced hyperpigmentation. And it takes into account multiple factors. The skin phenotype, so the darker the phenotype, the more severe the score is. The duration of PIH, the longer the duration, the more severe it is. The intensity or the severity of pigmentation, the number and the size of the lesions. And the total score can range between 2 to 10. And the higher score, the more severe the PIH. How do we treat acne-induced hyperpigmentation? We have the pharmacological agents and we have the dermocosmetics. The pharmacological agents that we usually use include topical retinoids, and they interfere with the tyrosinase pathway, and they increase the epidermal turnover. We can also use azelaic acid and hydroquinone that inhibit tyrosinase activity. Oral tranexamic acid can also be used, and it inhibits UV plasmin-induced activity in keratinocyte. We also recommend the use of dermocosmetics with ingredients that has an anti-pigment effect, such as ascorbic acid, arbutin, licorice extract, as well as niacinamide. So now we'll look at certain ingredients that have role in pigmentation. We'll start by discussing niacinamide, which is a vitamin B3. It reduces inflammation and boosts the skin natural photoproduction in order to slow down the melanin production. It also reduces the melanosome transfer to keratinocyte. So in overall, it prevents and corrects the dark spots. And in a randomized controlled trial containing more than 200 patients, the use of 4% niacinamide with 2% N-acetylglucosamine, it reduced the pigmentation. What about Melasil? Melasil is a patented ingredient that works by decreasing the pigmentation. So this is a study that compared a Melasil containing serum to hydroquinone 4%. And after 3 months, you can see that the reduction in MASI score, which is the score that looks at the severity of melasma, there was a comparable reduction in MASI score in the Melasil product in comparison to the hydroquinone 4%. However, the tolerability to Melasil was much better in comparison to hydroquinone. So the tolerability for Melasil was 94%, compared to 78% for that to hydroquinone 4%. And this is another study that looked at the use of either Melasil alone or Melasil after 3 months of hydroquinone 4%. And both showed significant reduction in the MASI score with optimal tolerability. What about the use of Melasil in post-inflammatory hyperpigmentation? So this is a study that compared Melasil to a key competitor at 1 month, 2 months, and 3 months. And you can see that there was significant reduction in the post-inflammatory hyperpigmentation score in comparison to the competitor. That's it, and thank you so much.
Thank you, Dr. Elisa. So our last speaker for this session, كما يقولون ختامها مسك, will be Dr. Fahad Al-Mutawwa. Dr. Fahad Al-Mutawwa, he is assistant professor at Kuwait University, consultant dermatologist, and he's expert in laser, and he's double board certified, American board and Canadian board, and he's the fellowship training in medical and cosmetic laser. Dr. Fahad, the mic is yours.
Assalamu alaikum. Allah yatikum al-afiyah. So today I'll be talking about my protocol in treating rosacea. So the aim of this lecture is just to give you a practical tips that you can use as soon as possible to your patient, and hopefully it will give you better result and increase the satisfaction of your patient. So let's start. I'm gonna They're supposed to be before and after pictures. Anyway, if you can get me the updated one. Okay, let's continue. So basically, for every disease, I have a checklist, all the options that I can use to treat this condition. Today, we're going to talk about rosacea, and I divide them into topical medication, oral medication, lasers, which is usually my main specialty, and injectables. So this is back there. Still. Anyway, so let's continue. At the end, I'm going to show you before and after picture, so I'll convince you how my protocol is working. So again, this is the checklist for my rosacea patient. Of course, laser, pulse dye laser, broadband, IBL, and recently the 1726 nanometer laser, which is the Aviclear or Accure, that I've been using a lot in papulopustular rosacea and rhinophyma as well. Injectables, we have PRP, I'm going to talk about this, PRP, hyaluronic acid, and polynucleotide. Others, we have exosomes and botulinum toxin, and we have the normal treatment that everybody uses for their rosacea patient, which is the moisturizer, physical sunscreen, and oral medication. So let's go through this checklist. First of all, isotretinoin. I believe this is a very great add-on to all of my rosacea patients if there is no contraindication. If you look at there was a lot of studies, and this is a recent systematic review that combined more than 1,400 patients. It shows clearly that we have decrease in lesion count and also decrease in the erythema score. However, the relapse rate is quite around 1/3, so it's quite high in rosacea comparing to acne because, again, this is an add-on. We don't depend on it. We usually combine it with our laser treatment. So, about PRP. PRP, we know it has an anti-inflammatory effect. And this is a study done on 40 patients. And they found, they did 6 sessions over 3 months. And they found around 50% had excellent improvement. And another 50% had good improvement. But what's interesting that even when they did histology, they found decrease in the inflammatory cell. PRP has a role as an anti-inflammatory. And now I added I do at least one PRP treatment to my rosacea patient in between the laser session. It will help in decreasing the inflammation. What about low cross-linked hyaluronic acid? This is one of my favorite in treating rosacea patient because you know that most of rosacea patients have dry skin, so this will improve the hydration. It also has an anti-inflammatory effect, and it restores the barrier function. And if you look at this case report where this is a case report of a few patients where they combine the hyaluronic acid, low cross-linked, with their vascular laser, and they found a good result even with only one session. And if you look at some of the cases in the patient, from that study, you can see the difference in redness. And this is only by adding one session of low cross-linked. And this is, to be honest, one of my favorite option in adding to my rosacea patient. I always add at least one session of low cross-linked. And this is important. I tried the non-cross-linked. It gives more temporary effect. But if you use the low cross-linked hyaluronic acid, usually the effect is more long-lasting. What about exosome? Exosome, I'm a favor of exosome in hair treatment, but not in facial treatment. But however, this is an option you can add on if you have it. You can do it either with microneedling or apply it topically. For my patient, I apply it topically after the vascular laser, and it does help in decreasing the redness. And if you look at this case report, they found sustained result, not only a good result, but it was sustained over more than 21 months with only 2 treatments with microneedling and topical exosome. And this is the patient over the 21 months. So polynucleotide again, this is a good option to add, and you can combine it same day with the laser, or you can put it in between. And I tried polynucleotide alone and polynucleotide with non-cross-linked hyaluronic acid. I can tell you the one with non-cross-linked hyaluronic acid is better than polynucleotide again, alone, because not only the anti-inflammatory, it provides also hydration effect. Okay, what about botulinum toxin? I mean, if you look, there is lots of case report and some small studies looked at the hyper-diluted botulinum toxin in butter. But there is a recent case series, look at the normal dilution, the standard dilution, that's 100 unit in 2 ml. And they injected 1 unit per point, as you can see here in the pictures, around 10 units in each side. And they have good result regarding the erythema score. Around half of them almost clear, and 2 more have mild improvement. So again, this is also an option, but you can use it also with the standard dilution at this distribution, and it might also help with the management of rosacea. So let me summarize my protocol. What do I do to my patient? If I can use isotretinoin, definitely. I'm going to start with a low-dose isotretinoin. Then, nowadays, if I have papulopustular rosacea or rhinophyma or even periorificial dermatitis, I use my Aviclear laser, the 1726 nanometer laser. And even with 1 or 2 treatments, it can get rid of the papulopustular rosacea. I found it is more effective in papulopustular rosacea than in acne, because with even 1 or 2 treatments, you can have good result. Then I use my vascular laser. I always start with pulse dye laser, and I use a 3, 6, and 10 millisecond in order to target all sizes of blood vessels. And between the vascular laser, I do 1 PRP session to decrease the inflammation and 1 low cross-linked hyaluronic acid for the hydration and barrier function. I was hoping that they can provide the before and after pictures so that you can see within as low as 4 weeks, we can really improve the rosacea by having this combination treatment. Thank you very much.
Thank you, Dr. Fahad, for this informative presentation. Any questions for any of the speakers? Yes, please. If you have a mic.
Thank you all to have you in Medina. This is Dr. Hanifa Bukhari. I'm a obstetric consultant, fetal medicine, and aesthetic gynecology faculty member. First of all, is thank you, Dr. Al-Isa, to have here hosting one of the brilliant conference in dermatology and have a pioneer in the field. You talk about an acne, Dr. Maliha, thank you, to consider patient lifestyle and the stress is part of developing and physiology starting of the acne. Prof, you consider this bride to how to make her this night it's pretty and self-esteem is high and enjoy her night in her wedding. So as part of obstetric and fetal medicine, usually I receive a consultation, patient, she gets pregnant while she's in retinoid, especially for those with high dose. And patient with polycystic ovary, they have amenorrhea. They don't have ovulation sometime. And this patient, even she has an infertility for 4 years, she can get pregnant without notice she is pregnant while she is on high dose of retinoid. So just a message from obstetric colleague, make sure about your patient. She had a proper contraception. I usually told my patient, the one she's have no plan to get pregnant, اللي عندها حبوب تقرأ عليها كل يوم تاخذها if she doesn't want to get pregnant. All those patients who have high dose of retinoid, I prefer to have a double method of contraception because the risk of failed. And I'm happy, the room is empty, but I'm happy to have you here in Medina, and I hope to enjoy your trip. Thank you.
Thank you for the comment. Usually we put patients in isotretinoid, we make sure that they are in proper contraceptive method, but especially in oral contraceptives, usually the patients, they are not compliant to their treatments. So that's why we need to sign them informative consents, and we need to inform them about the risk and the benefit of using the contraception, the treatments. So yeah, this can happen, actually, yes. Usually, even when I was still resident in France, even the non-married patients, female and skin in the age-bearing period, we have to put them on contraceptive. But here in Saudi Arabia, the mother tells you or the patient that I'm not married and I'm متزوجة, I don't need to take any contraceptive. But yeah, we have some cases like this. Thank you for the comments. And usually I advise dermatologists to take informative consent to the patients, that she know the risks and she's willing to take the treatment and to be compliant with her oral contraception.
Thank you. Even some type of oral contraception with this brain on is also can be improved, the reduced androgen level. So it can help to achieve a result.
And some of the patients, some of the doctors or pharmacists, they provide the treatment without any doctor prescription.
Thank you.
Thank you, dear
everyone.
colleagues.
Sorry.
Just to close the session, because we have now a break. And next session will be in 20 minutes. Thanks to all the speakers.
متابعكم على الانستغرام.
الو الو تست ايه
Assalamu alaikum. Distinguished physicians, honored guests, respected colleagues, it is a privilege to be with you. My name is Mehmood Hossein. For over 30 years, my work has focused on building global data systems that protect life. I helped build the storage pipelines used in the Human Genome Project, the first HIPAA-compliant medical clouds in the United States, Europe, and Japan, and the digital infrastructure hospitals still rely on today. I may not be a doctor, but I have spent my entire life building the systems that doctors depend on to save lives. You may not know me personally, but if you have practiced medicine in the last 20 years, you have likely touched the technology I helped build. If you viewed an MRI from a PACS archive, if you ordered a genome test, if your hospital has stored patient data digitally, if you used HIPAA-compliant systems, if imaging moved across your hospital network, you are using part of the infrastructure my teams helped create. My work sits quietly behind the scenes in genomics, imaging, health records, and secure medical storage. I am not here to sell anything. I am here because I have seen from the inside what medicine will need next. Today, medicine has become the largest generator of data on Earth. One ICU patient produces more than a gigabyte of data every hour. A wearable device produces up to 2 gigabytes per day. An MRI is 1 to 2 gigabytes. A genome is 200 gigabytes. A single hospital produces 10 to 30 terabytes of data every day. And globally, medicine now generates more than 2.5 zettabytes of data every year, more than all video, banking, government, and social media combined.
السلام عليكم ورحمة الله وبركاته. Good afternoon, good Friday. I think any meeting with no sharm derm, it doesn't taste good. So I have no doubt, عاصم من القلب شكر لك والجروب اللي معاك، وأنا متأكد أن هذا السيشن is an excellent additive value لمؤتمرنا كالعادة. وصدقني كل واحد يسأل متى شرم ديرم سيشن، والسبب دائما متجدد وتأتي بالجديد، كلهم متطلعين إلى سماع الأبديت، وخاصة جاك انهبيتورز and vitiligo، لأني أنا أعتقد أنك the most expert in this field الآن في المنطقة from number wise، لأني أنا أشوف vitiligo كثير، فأكثر الناس ومن منكم إلا واردها، فما في أحد اللي يمر عليك طبعا. فأنا أشكرك على الجود مانجمنت اوف فيتيلايجو وادنج الجاك انهبيتورز. كلنا آذان صاغية لسماع ما تقوله أنت والجروب اللي من شرم دير. شكرا لك.
بسم الله الرحمن الرحيم. ضروري أشكر أخويا الدكتور أحمد العيسى. عمري ما أنزل المملكة إلا ما أشوفه ويشوفني وبتعلم منه. خدوا بالكم، بتعلم منه. ما بقتش أروح مؤتمرات كتير إلا مؤتمر أحمد العيسى. ليه؟ لأنه في علم وفي محبة، وده أكتر من أخويا. أنا هوريكم شوية حاجات بس هي همشي فيها بسرعة جدا جدا. الدنيا اتغيرت بنسبة 100%. مش عارف أنا بالجاك، من غير الجاك انهبيتور كنا هنعمل إيه؟ من غير الجاك انهبيتور كنا هنعمل إيه؟ أدوس دي. خدوا بالكم من اللي أنا هقوله تاني ده. دي أنا جمعت لكم حالات بتاعة شهر يعني الشهر اللي فات على كل الجاك انهبيتور. بعمل إيه وبإيه اللي فشل وإيه اللي نجح وإيه اللي نجح جدا واللي فشل ليه. أنا ديت يمكن الحاجة الوحيدة اللي هتستفيدوها مني. اللي فشل وعندي المفاجأة الكبيرة، تخيل بقى لما أجي هنا وقدام الدكتور أحمد وأقول له جاك انهبيتور في الفيتيليجو، ده يعني ضروري أبقى جريء جدا 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 عشان أوريله إن أنا أعرف أتكلم على الجاك في الفيتيليجو. حاجة من ورا العقل، حاجة أنا نفسي جسمي أشعر لما شفناهم. أنا عايز أقول لكم إن ده أهم جدول ممكن تسمعوا أو تشوفوا. ده أهم جدول. يعني إيه أهم جدول؟ خدوا بالكم منه شوية لأنه عايز شوية دقة. أنا غيرته 6 مرات، غيرته 6 مرات، إنما في حاجات زادت، حاجتين زادوا في دول. إنما هقول لكم لما زودتهم ليه. ادي ديت بقى. انا همشي بسرعه ليه؟ انا اسف، عشان نفسي اوريكم حالات كتيره جدا جدا جدا. دي اوعى تفقد الامل وانت بتعالج بالجاك الوبيشيا توتاليس اللي هي الشامله. اوعى تفقد الامل. اوعى تاخدش الكلام بتاع جيري وليديا تقول لك 6 أشهر ماكسيم. اوعى مفيش حاجه اسمها كده. انا جبت كلهم وبقت الحكايه اكتر من كده بكتير، اكتر، مليانه اسرار ما نعرفهاش. خدوا بالكم ديت في منها 6 شهور وابتدت تنبت وابتدت تطلع اكتر واكتر. انا اللي انا عايز اوريه لكم، وهل في ريكارنس يا دكتور عاصم؟ هجاوب في الاخر. هل في ريزيستنت يا دكتور عاصم؟ هجاوب في الاخر. لانها اجابتين مهمين الى اقصى درجه تتخيلهم. في ريزيستنت، في ريكارنس ولا ما فيش ريكارنس؟ هما الاثنين دول مهمين الى اقصى درجه. انا عايز اوريكم هنا ازاي يعني ديت قعدت في قد ايه لغايه ما استجابت. عارفين ده قعد كتير ليه؟ هو العيان السبب مش احنا. هو العيان اللي ما بيسمعش الكلام، هو العيان اللي ما بيسمعش الكلام. لما انا خدته بقى واقول لي بتعمل ايه الصبح وظهر وبالليل، طلع هو السبب. they are completely treatable completely. ما فيش حاجه اسمها resistant. ارجوكم ما فيش حاجه اسمها resistant. انا مش بألف يعني. ما فيش حاجه اسمها will never cure، مش ممكن. كلها بتستجيب. بصوا والنبي شوفوا الروعه دي. عيانين راحوا في حته تانية. دي من حته اسمها في ليبيا، يعني هم اصحابي قوي. انما ما شاء الله ما شاء الله ما شاء الله بقت استجابت من الخوم. دي حته اسمها الخمس، يعني ابتديت احفظ حاجات كتيره كده. انما ديت في 2/9 انا بقى جابولت للعيله كلها وفرحانين جدا. انا عايز اقول لكم دي تبرك برضه باستجابه جامده. نو ريزيستنت. وانا مالي ايدي قوي، مالي ايدي، انا مش مخي ضارب يعني. لا، دول نو ريزيستنت، نو ريكارنس. مفيش ريكارنس. هو انا عبيط؟ انا اعرف يعني ايه في ريكارنس ولا مفيش. نو ريزيستنت، نو ريكارنس والجاك انهبيتور. انا همشي بسرعه قوي قوي. دي بقى من بني غازي. وبقى هنا يعني مش هوريه بتوع هنا ما شاء الله، لانهم ببعتهم بعد كده للدكتور احمد العيسى من الرياض و انا همشي معاكم واحده واحده. بصوا بقى، ساعات تبتدي المده تقل. انا مش عارف ليه تبتدي مده الاستجابه تقل. زي دول اللي هي من 21/4 دي، يعني يا نهار اسود 6 اشهر لغايه ما بقت شعرها مليان خالص. ادي ديت بيفور اند افتر تريتمنت، حاجه روعه. انما في حالات بتحصل لها ريزيستنت. لا مش هقول لكم دلوقتي لان انا مش عارف. ادي ديت بيفور اند افتر، بيفور اند بعد كام ما فيش 6 شهور بيفور اند افتر. لكن دول مش بيبقوا عارفين لون شعرهم. دول مش عارفين لون شعرهم ايه. دول اول مره يشوفوا لون شعرهم، اول مره يعرف ان شعره ابيض. دول كلهم بيفور اند افتر. انا اسف همشي بسرعه لان انا جايب في الجاك حاجات كتيره جدا. ونشكر احمد زكي. انا متشكر يا احمد لانه هو اللي صلح لي المحاضره دي كلها. لقيتهم داخلين في بعض. ادي ديت. بصوا بقى بقيت اشوف كازاخستان وحاجات كده. لكن كازاخستان ده ما شاء الله عليه استجابه روعه اسرع. اقول بقى فيها حته تقوى ولا ايه انا ما اعرفش. ده ما كانش يقدر يمشي. انما اهو بتوع كازاخستان ابتدى يتقل الشعر ما شاء الله ما شاء الله. ده برضه بيفور اند افتر تريتمنت. دي من اسكندريه وكانت معقده وكانت حالفه مش هتنزل من البيت. ادي دي مش هنزل من البيت. لغايه دلوقتي شعرها ما شاء الله وصل لنص ظهرها. انما معلش مره واثنين وثلاثه انا همشي بسرعه علشان ما اتاخرش عليهم. ديت واحده ثانيه اهي ودول كلهم. في ريزيستنت لما العيان يبتدي ما يستجيبش للعلاج. العيان نفسه اللي بيفوت. خدوا بالكم ده في حتت ريزيستنت. دي لا اللي نفسي تقولوا لي السبب. حتتين ما بيش الحواجب والنيب اوف ذا نيك. مفيش حد عارف ليه. انا الاول فكرت في الحواجب دي عشان الهير سايكل صغير. انما برضه اهي دي خدوا بالكم بقى اهي، انا همشي بسرعه جدا جدا، انا اسف على كده، لكن ضروري اوريكم كل انواع التريتمنت بيها 1 2 3 4 5. معلش انا اسف اذا كنت همشي بسرعه. بصوا ده اهي، حلو ده قوي. ايه هو؟ ادي الحاجب، كل شعره طلع ما عدا الحاجب. الريزيستنت للاي براو صعب جدا جدا، ولا انا عارف له حاله. انما الجاك انهبيتور اللي جاي معجزه، معجزه طبعا في اللي جايه دي اهي، ديت كلها اهي. انا اسف فعلا. ايوه. تاني حاجه في العلاج ده اتغير برضه، الاتوبيك ديرماتايتس. تاني حاجه في الجاك بالترتيب اتوبيك ديرماتايتس. اتوبيك ديرماتايتس ات از ماست ان انت تكمل العلاج. ايهما اقوى؟ هما بقى الرينفوك ولا السبينكو؟ احسنهم السبينكو اتشال من مصر، احسنهم بمراحل السبينكو اللي هو بتاع فايزر اتشال من مصر، وانا ما اعرفش اتشال لانه غالي جدا، يعني فيه ب80,000 وحاجات كده. لكن هو ده الاتوبيك ديرماتايتس، it is FDA approved ومحترم جدا جدا جدا. ادي الرينفوك وادي البارسيميانت جينيريك والباريتافا اهم، دول كلهم. خدوا بالكم نزل رينفوك رخيص، انا ضروري اقول لكم عليه، رخيص قوي كمان. فهنبتدي نقول ده الاتوبيك ديرماتايتس ويوقف الايتشنج لغايه ما ابتديت انا اقول ما هو اللي بيوقف الايتشنج بتاع الاتوبيك ديرماتايتس يقدر يوقف الايتشنج بتاع حاجات كتيره. وده اللي احنا عملناه دلوقتي، pruritus of unknown etiology. pruritus of unknown etiology اهو، more in atopics اهي ديت يا جماعه. هنمشي ما انا اسف برضو اهو، مش عايز اضيع لكم الوقت لأحسن اللي جاي ده عندي اهم حاجه. الكونتاكت ديرماتايتس والايتشنج في الكونتاكت ديرماتايتس بيتعالج بسرعه رهيبه بالجاك انهبيتور، بس هتختار انهي واحده؟ برورايجو نوديولاريس ده ما ياخدش 3 ايام. برورايجو نوديولاريس ادي دي اهي 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 اهي، وادي دي اتوبيك ديرماتايتس. اتزمست ان انت تريتمنت، يمكن دي اهم واحده هجيبها لكم النهارده. انا الفتها كده بس، وسالت شادي وسالتهم دي هتنفع؟ نفعت ونفعت كويس جدا. تريتمنت اوف برورايتس اوف انون اتيولوجي مع جاك انهبيتور، انهي واحده فيهم؟ بارسيميان برورايتس اوف، حاجه مرعبه. ما عدا السكيبز والفانجس انفكشن لا يمكن لما يبقى فيه كده ما نفعتش. انما دي الصراحه عملناها البيبر دي، انما نفعت قوي 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 كمان. نمشي بقى ادي ادي كمان دي كرونيك برورايتس characterized by persistent itching، ديت challenging، ديت كنت فاقد الامل. انما الصراحه الدنيا اتحسنت جدا جدا، هي مع البرورايجو نوديولاريس ودي بقت الدنيا بقت تمام. المهم بقى التشالنجينج دي ادي تريتمنت اوف كرونيك برورايتس، وجاءت المعجزه. وانا كلمت احمد العيسى ما حدش يعرف يشتغل في الفيتيليجو الا ما يكلمه. انا كلمته قلت له هقول لك حاجه ما تتريقش عليا، انا العيانين كلهم بيجوا من المملكه وبيجوا من كويت وبيجوا من هنا ومن هنا ومن هنا. الصراحه حصل استجابه مرعبه، خصوصا الرينفوك ده يعني لسه ما فهمناهوش. والرينفوك بقى الجديد اللي اوباسيتينيب ده الجينيريك بتاعه نزل امبارح بالظبط، ونزل رخيص، يعني امبارح نزل ب 4000 وده 32000 وكده. انما تريتمنت باي اورال جاك انهبيتور حاجه رهيبه خالص. الاوبا ديسين ده البروميسنج. بصوا يا جماعه البيفور اند افتر، العيان نفسه انا ولا العيان مصدقين. ادي المنظر ده، وابتدينا نعمل الاكرال تايب. اكرال تايب عمره ما خف في حياتنا. الاكرال تايب ده في مده وياخد 4 شهور بس، 4 شهور بس. ادي ده بيفور وافتر. الجاك انهبيتور، جاك انهبيتور يعني ما شاء الله ما شاء الله. بس الاربع حاجات اللي احنا بنعملها في الجاك اللي هي هنقولهم رينفوك روكسيتوب، وده 4 حاجات. انما انا ما تخيلتش في يوم من الايام ان الاستجابه هتبقى كده بيفور اند. بنعمل حاجه عندنا في العياده بالوودز لايت، نصور بالوودز لايت اهي. وطبعا شادي والدكتوره رحاب وامين وكلهم موعديني بالبيبر دي، بس طول النهار يعملوا لي كده. لا والله طول النهار يعملوا لي، يا ابني فين البيبر؟ يعملوا لي كده.
بتاخد وقت يا دكتور عاصم، هي بتستوي دلوقتي.
خلصت؟
بنسويها كويس عشان بس.
والله العظيم ده انا هتشل اهي. بصوا بقى لغايه ما جينا للاكرل. الاكرل اللي بيخف، اكرل طايب عشنا وشوفنا اهي. ده يعني حاجه انا بقول لكم بقت عندي دلوقتي بالظبط 180 حاله. انما الاكرل بصوا انا هحكي لكم حكايه في البنت دي. البنت دي انا عالجتها وجايه لقيتها هي وابوها وفرحانين جدا. او قلت للعيال اللي عندي ها ادوني بقى بيفور. قالوا ايه؟ صدقوا ما صبرهاش بيفور. والله العظيم 3 ان بقى صوتي ده واصل لركسي من الزعيق، وجريت وراهم. ولا انت بتتكلموا جد؟ قالوا لي بس معلش ومش عارفه ايه. والله اصل احنا عمرنا ما كان عندنا الامل انها تخف. طب وده منيل اهي. طبعا بعد كده دلوقتي بيصوروا نفسهم قبل ما ديت. انما بقى بيصوروا اي حاجه ماشيه يقول لك هيزعق لنا. ادي بيفور اند افتر. الصوره بيفور دي من عند العيانه، هي هم كانوا بيصوروا عشان كده السجاده اللي بتاعتهم اهي. بس بعد كده بقى ما شاء الله. انا اللي عايز اقوله لكم ده حتى يا ربي الجنرالايزد احسن من اي حاجه تانية اهي. ديت بيفور اند افتر كتير بقى. بيفور اند افتر خالص خالص خالص. امتى ما تستجبش؟ امتى ما تبتديش فيها؟ امتى هيحصل ريكارنس؟ امتى مش هيحصل استجابه؟ مش عارف. انا بكلمكم الصراحه انا مش عارف. لكن الراجل ده من السعوديه من هنا، وهو ده برضو سبحان الله ده ابنه. انما الدنيا كلها بصوا دي بنعملها ازاي بفور اند افتر اهي. المهم وانس ديلي ده بلاسيبو ويز اكستنسيف نون سيجمنتال فيتيليجو ما شاء الله. انا يعني لو عملنا كده على راي احمد، لو عملنا دي بس وبطلنا شغل كفايه علينا. عشنا وشوفنا انا الفيتيلجو اكرل يخف ليه يعني. ادي يا جماعه بارسيميان بروجريسيف فيتيلجو ما شاء الله عليه اهو. وديت اوعوا تنسوها، اوعوا تنسوا الجدول ده. الجدول ده اتغير سنه، بس طبعا انا لسه معترف بالاف دي ايه والنوت ابروفد دي. انما دي معترف انا بيها. انا اسف اذا كنت طولت عليكم، لكن احنا دي بقى الناس بتوع السورايسز ما بحبهمش يشوفوها خالص، منها رحاب. وانا عمري ما ليه يا حيوان انت بتالف؟ اتش سورايسز دي يا سلام عليها في الجاك انهبيتور. ديت بتستجيب اول ما العيان يستجيب فيها، وبلاقينا بس السيفنتيف سورايسيس والجاك انهبيتور ديت ما شاء الله ما شاء الله عليها، او هي ديت الثلاثه 4 5 وديت التوفه والتوفه ديت. وانا في الاخر خالص خالص اشكركم واشكر دكتور احمد العيسى واشكركم على تواجدكم.
ممكن سؤال واحد بس يا دكتور عاصم؟ سؤال، اتفضلي دكتور.
ايوه ثانيه ثواني، خليك اتفضلي، خليك يا استاذ.
طيب يا دكتور عاصم، يعني انت نورت طبعا المدينه، ويعني هي المدينه منوره، بس حضرتك نورت كمان هنا المكان. كنت عايزه اسال حضرتك لحد امتى دلوقتي الشعر طلع والدنيا زي الفل، لحد امتى هيتن الطفل ياخد جاك انهبيتور؟ كمان حاجه، هل ان احنا بنقلل الدوز ولا لا؟ دي حاجات، دي اسئله احنا كل يوم بنتسالها في العياده. لحد امتى؟
قالت سؤال ما حدش جاوب عليه في العالم. لحد امتى؟ لحد امتى؟ انا الجاك ما بوقفوش، بقدر اوقف الاستيرويد وانا مرتاح، انما الجاك انهبيتور خصوصا بقى بارسيميانت وكده ما اعرفش، والله ما اعرفش يا دكتور.
طب
لما اقول لك ما اعرفش،
هل نقلل الجرعه؟ يعني مثلا
لا
واخدين 4 ننزل
لا
2؟
انا وانت هنألف؟ لا ما فيهاش تأليف، يعني انا وانت ما نألفهاش، يعني نقلل جرعه وما نقللش جرعه. ما العيان عملها الصراحه البتاعه باظت. يعني ايه باظت؟ البتاع باظ، بس في سايد افكت للدو بس كويس ان انا افتكرت. في سايد افكت جامده جدا، الكوليسترول بيعلى، الترايجليسرايد بيعلى، على فكره من تاني اسبوع تالت اسبوع ارجوكوا بيعلى قوي قوي قوي، بيشوط. فده ضروري، انما هنرجع تاني ونقول هل بالراحه كده، بالراحه فيه يعني هل اقدر اسحبه؟ ما هوش استيرويد، ما يتسحبش زي الاستيرويد خالص. انما
هو انا معايا حاله واحده بس، يعني نزلنا الاثنين والدنيا لحد دلوقتي تمام بقالنا سنه، فانا مش طبعا ما فيش يعني ما فيش جايد لاينز ولا اي حاجه، ف هو سبحان الله يعني يمكن بكره يجي حاجه وفوق كل ذي علم عليم، بس بكره يمكن يبقى فيني حاجات نيو، بس كنت بحسب ان حضرتك عندك حاجه في النقطه دي.
انا نفسي مش بحب يعني استعجل. يعني ايه استعجل؟ ده ألوفات فرحانه، فما اقدرش. بس معلش يا دكتور، لما اجي كمان مره 100% هيبقى عندي اجابه
ان شاء الله
100%. ان شاء الله ربنا يخليكي لنا.
فيك يا دكتور، شكرا.
يشرفني. اتفضل يا دكتور.
السلام عليكم، شكرا يا دكتور عاصم على المحاضرة الحلوة دي. سؤال، أنا شفت تعطي من البيدياتريك ايج جروب، من سن كم تبدأ بالجاك انهبيتورز بالنسبة للأطفال اللي عندهم ألوبيشيا أرياتا؟ من سن كم؟
ما أنا قلقان إن هتلاقوا الأسئلة نصها مش متجاوب، بس أنا حاطط لنفسي كده من 16 سنة، يعني بديهم من 16 سنة. والاستجابة أنا أصل أنتوا ضروري كلكم تشوفوا الاستجابة. يا نهار اسود 3 شهور يبقى.
بس الصور شفنا أصغر من 16 سنة.
لا ما تخافش، انت هتراجع ورايا. انا بقول لك 16 بس 16 في اكتر من كده، يعني في اقل من كده، وعملتها في واحد كان 12 سنه وفي واحد من 10 سنين. هو ده انا سائل فيها الهدايه كلها اوف ليبل، يعني كلها اوف ليبل، يعني فهي يا دكتور معلش اديني فرصه بس لغايه السنه الجايه. 100% هيبقى عندي بروتوكول جاهز. مش انا بس، انا ده انا متاكد ان في بلاد بتستجيب اكتر من بلاد يا فندم. 100%. يعني انا دايما اقول لاخواننا هنا يمكن في بركه ولا حاجه بيستجيبوا بسرعه. في حتت الاستجابه فيها سريعه، بس لسه انا اللي وريته ناس كانوا ريزيستنت فور تريتمنت واستجابوا بقى بعد 4 شهور 5 شهور بس. حاجه تساوي ان احنا نفكر صح ولا غلط.
عفوا استاذ
عشان بس نبتدي. اتفضل.
European guideline نزلوا للسنتين بالاتوبيك dermatitis regarding the OPA. regarding the OPA system.
الجايد لاينز للأوبا.
دي موجوده اتوبيك ديرماتايتس. دي بروف. اتوبيك ديرماتايتس برورايجو نيديولاريس كل دول الصراحه بروفد، يعني ما هياش حاجه.
For that reason
والاتش
اس
الاتش اس كمان الاتش اس ابتديته متاخر. اللي هي الاتش اس ما شاء الله الاتش هيدرادينايتس سيبريتيفا يعني.
اوكي. نشكر دكتور عاصم على المحاضره الجميله الابديتس جاك، ويشرفني ان اقدم اخويا علم من اعلام الليزر دكتور شادي محمود هيتكلم عن painting away red vascular specific laser in dermatology.
شكرا دكتور امين، شكرا دكتور عاصم على السيشن شرم ديرما. My topic today about painting away red vascular specific laser. يمكن النهارده يعني هنفوكس شويه على الفاسكولار specific laser especially في الفاسكولار lesions. Sometimes we have non-vascular lesions برضو. At first we have to select الويف لينس اللي تشتغل على الفاسكولار ب using selective photothermolysis. دي حاجه كلنا عارفينها، وعشان to achieve selective photothermolysis لازم نختار suitable wavelengths, pulse duration to confine heat to vascular lesion, effective fluence to chromophore which is vascular or hemoglobin, cooling to protect the epidermis. والبيولوجيكال افكت اللي احنا بننتظره هو heating diffusion to blood vessel wall عشان يعمل coagulation followed by necrosis and perivascular collagen damage. ده الاوتكم اللي احنا دايما بنحاول نوصل له. طيب which wavelengths او which specific laser بنتكلم عليها regarding this coefficient curve. As you see here we have 3 peaks of hemoglobin absorption. هنلاقي ال 532 واخده بيك اللي هي الكي تي بي followed by pulsed dye laser 595 نانومتر followed by 1064 نانومتر. هتلاقوا ده اضعافهم بس اطولهم، يعني ده can penetrate deeper up to sometimes 6 to 7 millimeter into skin. كل الديفايسز الموجوده في الماركت could be KTB, pulsed dye laser. Diode can generate some wavelengths like pulsed dye اللي هو ال 577 وال 585. Nd:YAG ال IPL we can use in vascular. even الميكسد تكنولوجي something like pulsed dye and Nd:YAG وده available في الماركت في المملكه العربيه السعوديه. الديفرنشال بينهم ازاي؟ الكي تي بي هتلاحظوا في افينيتي الميلانين عالي جدا ففي ليميتيشن مع السكين تايب الغامق. البلس الداي في افينيتي اعلى في الفاسكولار كومبيرد تو ميلانين. الدايود هيبقى لايك بلس الداي. ال 1064 اضعف في الميلانين واضعف في الهيموجلوبين ميك ات سيف في الداركر سكين تايب وكان بنتريت ديبر. والاي بي ال زي ما انتم شايفين حسب الفاسكولار فلتر اللي بنستخدمه. سريعا عشان نعرف الفرق الكونز والبروز بتاعت كل واحده. الكي تي بي هاي ابسوربشن تو هيموجلوبين بيرفكت بس عندنا ليميتيشن اتريشن وليميتيشن في الميلان. بالتالي مش هعرف استخدمه غير في سوبرفيشال فاسكولار ليجنز ان فير سكين تايب. حاجه سوبرفيشال وفير سكين تايب هو ده الاوبتيمم بتاعه. طيب اللي بعديه البلس داي ليزر الافينيتي الهيموجلوبين موجوده. البنتريشن ديبس بقت اكتر 1.4 ملم اكتر من الكي تي بي. ستيل شويه عندي ليميتيشن في الميلانين فسكين تايب اكتر من 4 ما بقدرش اشتغل قوي لكن عندي بنتريشن كويس وعندي افينيتي للهيموجلوبين كويس جدا فبالتالي ميك ات بيرفكت او المين ستيت تريتمنت في الفاسكولار ليجنز هو البلس داي ليزر. الدايود اللي هو كان جنريت ويف لينث لايك بلس داي هنقول ان ذا سيم ايديا بس في ليميتيشن ان الباور بتاعت الدايود دايما ضعيفه فهيشتغل بسبوت سايز صغيره فهيميك ات سوبرفيشال ان بنتريشن. هي دي مشكله الدايود. الاجهزه اللي ممكن تشتغل لايك بلس داي هو اميز انه ما فيش كونسامشن ما عنديش اي كونسيومبل فيه فبيريح دماغي، مفيش اي مشاكل او هيدك وراه، لكن ستيل هيبقى فيه لو باور، فبالتالي البنتريشن هتبقى صغيره او ليميتد علشان بيشتغل بسبوت سايز صغير. نروح ل 1064. 1064 لونج بنتريشن، دي ميزه مهمه جدا. لو ابسوربشن تو ميلانين ميك ات سيف، لكن ستيل لو ابسوربشن تو هيموجلوبين. طب هو عشان ضعيف you have to increase fluence to compensate this failure, this deficit. هي دي الايديا. make it risky، هتخليه ريسكي لان انا مضطر ان انا ابوش في الفلونس قوي عشان اجيب ريزلتس. هي دي مشكله ال 1064 دايما لما بنستخدمه، فعشان كده محتاج someone professional enough to use it. How to optimize؟ عرفنا which laser can achieve outcomes superficial or deep or fair skin type or darker skin type regarding the wavelengths. Regarding the fluence, we adjust the fluence according to amount of chromophore. When you deal with less hemoglobin, you have to increase fluence. When you deal with more hemoglobin, you have to decrease fluence. هي دي الايديا حسب كم الكروموفور اللي بنشتغل عليه. دي القاعده بتاعتنا دايما احنا شغالين. وطبعا بنتظر wanted end point، لازم اعود عيني على end point. دي جمال الفاسكولار ان في end point بشوفها بعتمد عليها كفلونس اوب. something like that therapeutic endpoint في البورت واينستين بيربر، عندي في التلانجيكتيزيا بلانشنج، عندي في الليج فينز ممكن الاقي كالر تشينج او بلوج ديسكلريشن. دي endpoint لازم ادور عليها، معناها كده الفلونس بتاعي بيرفكت. regarding الديوريشن، القاعده هنا حسب الثيرمال ريلاكسيشن تايم، فهنا match duration according to blood vessel size. When you deal with small size, reduce duration. When you deal with larger blood vessels, increase duration. هي دي الفكرة عشان نعمل diffusion of heat to reach up to blood vessel wall to induce coagulation. ودي الاوتكم اللي احنا بندور عليه. عندي different sizes especially when you deal with port wine stain, something like port wine stain, we have very small capillaries، فبنشتغل هنا بأقل duration اللي هي ممكن تبقى 0.45 ملي سكند. لما بنشتغل مع ليك فينز حوالي 2 to 0.53 ملم diameter، فالحالة دي لازم ازود الديوريشن up to 15 20 25 ملي سكند. دي الايديا of how to control الديوريشن according to blood vessel size. لما نتعامل مع darker skin type for safety, the darker skin type the lower the fluence the longer pulse duration. هي دي الأأمن. لما خلاص معايا dark skin type 4 or 5 أنا مضطر أقلل الفلونس وأزود الديوريشن to make it safe for the patient. Regarding spot sizes دايما في الفاسكولار كلها الصغيرة 5 ملم 7 ملم up to 12 ملم is the maximum، لكن أنا بميل أكتر لل 5 و 7 ملم أميس. الحاجات الديب لاين فيزل something like venous malformation yes we can use 10 ملم especially ال 1064. دي even في ال 1064 هتلاقوا في فرق حتى في الفلونس رينج، لأن ال 1064 shows weak to be absorbed by hemoglobin. You have to increase fluence range. عشان كده أرقام ال 1064 أعلى كتير من أرقام البلس دايليزر. الكولينج طبعا طول الوقت on to protect الابيديرمس. sometimes when you induce damage انت intended انت تعمل damage في الليجن like ward، في الحاله دي انا بقفل الكولينج، انا مش محتاج كولينج لما بعمل damage لليجن زي الورد like that. هنا عملت حاجه اسمها stacking overlapping اكتر من pulse عشان اعمل grayish discoloration meaning that I intended to induce damage for this lesion. So laser response in vascular lesions, few factors regarding the laser type, blood vessel level, superficial ولا deep, size of blood vessels, fine telangiectasia or larger leg veins, blood flow. طبعا blood flow الأسرع بيحتاج مننا دايما فلونس أعلى. السكين تايب طبعا decrease fluence و increase duration مع السكين تايب الغامق، وطبعا عمر العيان طول ما بنشتغل هو أصغر especially في الوحمات الدموية هيبقى طبعا النتائج أفضل كتير. ناخد أمثلة سريعة كفاسكولار ليجنز. هيمانجيوما، البروتوكول بتاعي في الهيمانجيوما لازم كومباين تريتمنت، ما ينفعش بلس الداي لوحده. هنا بلس الداي هو المينستي تريتمنت هير، بس اهم حاجه يكون كومبايند مع البروبرانول، توبيكال اندرال، توبيكال ديميلول. الحاجات دي كلها مهمه جدا، وساعات بنحتاج سيستميك في الرابيد بروجريسيف هيمانجيوما، فده از ذا بيست تريتمنت دلوقتي بنعتمد عليه. ايفن ممكن كمان نعالج الريزيدوال تلانجيكتيزيا افضل انفوليوشنال فيز اوف هيمانجيوما، برضه دي بنحلها بالبلس الداي ليزر. Regarding البورت واينستين حاجه مهمه جدا، بليز do dermoscopic evaluation at first to evaluate superficial blood vessels or deep blood vessels or mix it sometimes، لأن الدوتس دي meaning that we have superficial blood vessels، الحالة دي هتبقى الريسبونس بتاعها كويس. when you have linear vessels معناها deep، دي هتاخد وقت طويل شوية وهتبقى شوية complicated في الشغل بتاعنا. وطبعا لازم اعتمد على ان بوينت زي ما انتم شايفين بيربيريك اكشن في البلس داي ليزر. طب ممكن استخدم 1064 في منتهى الخطوره فيري ريسكي. عشان استخدم 1064 في البورت ستين اي دونت ريكومند الموضوع ده، بس في حاله واحده بس لما يكون عندي هايبرتروفيك او نودولار بورت ستين انا ممكن استخدم 1064 ايفن بتستنج، بعمل تيست ات فيرست تو افويد اني كومبليكيشن، لانه انا مضطر ازود الفلوينس رينج هنا، ومن هنا بيجي الريسك بتاع البيرن وبتاع الكراستيشن والسكارينج فورميشن. الريسبونس بتاع البورت ستين طبعا عمر العين اصغر افضل، لوكاليزيشن اوف ليجن في الفيس افضل من الاكستريميتيز، المساحات الصغيره اللي هي اقل من 20 سنتيمتر سكوير شوز ريسبونس كويس. الديبس طبعا سوبرفيشال افضل من الديبر، والفير سكين تايب افضل من الداركر سكين تايب. Some cases as you see here after 4 or 5 sessions for pulse dilatation ان دي افضل حاله، دي الاريسيماتس معناها ان هنا سوبرفيشال بورت ستين، دي برضو الريسبونس بتاعها كان كويس. دي شويه الريسبونس هنا في السكين كويس، في الميوكس ممبرين للاسف متاخر لان هنا ليها ديب لاينج فيزلز. كل دي ريسبونس كويس يوزنج بالس داي ليزر. فيشال تلانجكتيزيا عندنا ديفايسز كتير ممكن تشتغل بشكل كويس جدا. الكي تي بي مش متاح قوي، 1064 ممكن، البلس داي ممكن. ف 1064 انا من الناس اللي بدو بريفير في الفيشال تلانجكتيزيا، بيجيب ريزلتس كويسه جدا زي ما انتم شايفين. ادي 1064 وادي بلس داي. ايه الفرق بين الاثنين؟ الفلوينس رينج. ذا سيم سبوت سايز، بس هنا 80 جول سنتيمتر سكوير، هنا 12 جول سنتيمتر سكوير. الفرق ده جه منين؟ عشان ال 1064 very weak. You have to compensate this deficit by increasing fluence range. Again, facial telangiectasia 1064 perinatal infra او بنسميها الانفرا اوربيتال فين، دي مهمه جدا، فيها شويه بروفيشنال ليفل، لازم استريتش السكين تحت، الهاند بيس بتاعتي تبقى دايركتد داونورد تو بي سيف ان انت تعمل اي مشكله. سبيشال احنا بنستخدم ال 1064 هو لونجست وان ان بنتريشن. ستريتش دايركت هاند بيس اواي فروم اي اند ذا ايس باكس افتر ايتش بالس، كده احنا نبقى في الامان. ودي الريزلتس بعد 3 او 4 سيشنز. دي الاند بوينت بتاعت الليج فينز بوريها لكم. يعني انا بحتاج كلر تشينج، جاست كلر تشينج بلانشنج، هو ده الاند بوينت بتاعتي. غير كده لقيت بقى شرينكج افكت، لقيت صوت طرقعه بوبينج ساوند، انا كده ريسكي وكده ممكن اعمل كراست فورميشن اور sometimes pigmentation. ودي البروتوكول بتاعي when you deal with leg veins in different sizes starting from fine venectasia, spider veins, even deep reticular vein. ايه deep reticular veins؟ انا increase هنا الديوريشن 35 to 40 ملي سكند عشان تناسب حجم الريتيكولار فينز، لان دي اكبر واحده فيهم. لو انا استخدمت الشورتست وان في الكبيره هتعمل الصوت ده وتعمل ممكن كراست فورميشن. many cases after 3 or 4 sessions دي الافريج بتاع النتائج بتاعتنا خلال 3 4 جلسات. بيرجينيك جرانيلوما وي كان يوز 1064 اور بالس داي ليزر تو induce coagulation، ودي برضو after 3 to 4 sessions. الانجيوكيراتوما وي كان يوز 1064. البيبر دي كنت بعمل بالس داي و 1064 بعمل كومباريزون، والاثنين جابوا نتائج ذا سيم ريزلت، بس 1064 كان so painful compared to pulse dye laser. Venous malformation, in such a case, we have deep lying vessels. Pulsed dye can penetrate, can reach up to maximum 1.4. In such a case, you shift it to 1064 to reach deeper up to 5 to 6 millimeter عشان أقدر أجيب كل الديب لاينج فيزز الموجود. هنا 1064 ما ينفعش pulsed dye. في ناس ليك the same deep lying malformation. We have some non-vascular lesion، مش شرط التارجت بتاعي الفاسكولار، لا ممكن يكون vascular element inside disease ممكن اشتغل عليه عشان احسن زي الورد. We have congested blood vessels inside ward، بنعمل نشيل هايبركيراتوزس، بنعمل ستاكينج، نقفل الكولينج ونضرب 1 2 3 لحد ما يحصل جريج ديسكلريشن، يبقى انا كده نجحت اعمل شرينك نيكروزس would be sloughed من السكن بعد كده. دي امن ما فيهاش فيومز، فيها امان عالي جدا بدل ما نعمل كوترايزيشن او نعمل ابليشن بالسي 2. دي ريزلت برضو من الببليكيشن بتاعتنا، كانت كومباريزون بين بالس داي اند 1064 والاثنين شوز جود ريسبونس، بس الريكارنس كان اقل مع 1064. even في الانال وورد جينيتال وورد the same idea. inflammatory acne I do prefer to use pulse dye laser. البلس داي ليزر بيشتغل على البورفرين انسايد البي اكني، فيقدر يعمل فوتو اوكسيديشن ويقلل او يعمل كيلينج للبكتيريا اللي موجوده عن طريق حاجه اسمها فوتو كيميكال رياكشن as you see here. لو فلوينس لونج بالس ديوريشن. البرزيستنت بوست اكني اريسيما برضو من الكيسز اللي احيانا بتطول معانا قوي سبيشالي بيرسيستنت. هنا في الحاله دي البلس داي ليزر ممكن يبقى حل لطيف ما كانش البلس دايليزر، ممكن نفكر في الانتنس بالس لايت. عندنا حلول ثانيه ودي كانت برضه بيبر يوزنج اللونج بالس اندياك ايفن، بس بياخد سيشنز اكتر من البلس داي عشان يحسن انفلاماتوري اكني. استخدمنا هنا 10 ملم 30 ملي سكند، طولنا الديوريشن شويه عشان ناثر على السبيشس جلاند اللي موجوده في الفيس. روزيشيا بالس داي طبعا ده مين ستيج تريتمنت، ما كانش عندي البلس داي ممكن افكر في الاي بي ال. اجين روزيشيا ايفن في النيل سورايسز وي كان يوز بالس دايليزر بس بتاخد سيشنز كتير. الليشمانيا ايفن اشتغلنا بالبلس دايليزر، كل دي نون فاسكولار ليجنز بس I can use it to induce coagulation and decrease الفيدنج فيزلز اللي تحت الجلد عشان اعمل نيكروزس للتيشو. الهايبرتروفيك سكار والكيلويد ذا سيم ايديا to induce ischemia for scarring tissue or for hypertrophic scar and after that will be shrinked. Fresh scar قولا واحدا after suture removal 1 week we can use pulsed dilaser improve الفريش scar and prevent الاوتكم بتاع الهايبرتروفيك او الكيلويدال تندنسي اللي ممكن تبقى موجوده. To target vascular lesions effectively using safe roadway, pulsed dye is the mainstay treatment for vascular lesions. هو في رقم واحد. Longer wavelengths just for deep lying vessels زي venous malformation. Adjust the fluence according to chromophore and endpoint دي مهمة جدا. Match the duration according to blood vessel size. Avoid purpuric effect of pulsed dye في الداركر skin type بنحاول نكستند الديوريشن شوية. Low fluence و long pulse duration be safer in darker skin type and cooling to protect the epidermis ما عدا الحاجات اللي أنا قاصد أعمل لها دامج زي الورد. Thank you.
احنا عاجزين عن الشكر يا دكتور شادي. فعلا شادي هيز اكسبرت في الليزر بتعمق كتير، وهو انا محظوظ انه بيشتغل معانا او احنا بنشتغل معاه في العياده، فهيز ان اكسبرت. دلوقتي الاستاذه الدكتوره رحاب، انا اعشق في الجلديه الاوف ليبل، خدوا بالكم، يعني انا احب قوي الاوف ليبل. يعني كل الادويه اللي انتم بتستخدموها انا احب الاوف ليبل بتاعها. ليه؟ لان حاجه كده اسمها بنفكر. يعني ايه بنفكر؟ اكتر حاجه جربناها في الاوف ليبل طبعا الايزوتريتينوين. يعني الايزوتريتينوين ده اتخلق عشان الاوف ليبل، والبروتوبيك اتخلق عشان الاوف ليبل. في 8-10 حاجات اتخلقت في الاوف ليبل، لكن مين بقى اللي يكلمنا في المواضيع اللي هي شويه فيها ممكن نشط؟ العبقرينو بتاعنا الاستاذه الدكتوره رحاب حجازي، وانت نورتينا يا دكتور.
ربنا يخلي حضرتك يا دكتور عاصم، ومحيه فخوره قوي ان انا موجوده النهارده في الفيرست انيوال كونفرنس لادم، والف مبروك لدكتور احمد ودكتور رؤى الحرثي ودكتور دانا وكل القائمين على المؤتمر العظيم ده. زي ما دكتور عاصم قال، انا بحس ان احنا في الجلديه بنتعامل جزء ليبل والكتير جدا اوف ليبل الحقيقه يوزز. والحقيقه احنا وات داز الاوف ليبل مين؟ في البيبر دي في 2019 هي خلتنا نحط definition للأوف ليبل، هو إن إحنا نستخدم drugs that have not been approved for this kind of indication، أو هي approved with this kind of indication بس إحنا استخدمناها في doses مختلفة أو بفورمز مختلفة، أو اديناها لحد beyond the age أو السكس اللي هو يعني متوافق عليه، سواء من ال FDA أو من اليوروبيان أو even من اللوكال authorities اللي من حقها تدي الابروفل على استخدام الدراجز. والحقيقة فيها ethical controversies كتيرة، من حقنا أو لأ نستخدمها، وبالتالي حتة الأوف ليبل دايما شائكة، ولازم يكون ليها scientific proof تخلي الدكتور من حقه يكتبه، ويكون في safety rules تقدر تخلينا نبقى عندنا اتساع في كتابة هذه الدراجز. والحقيقة البوتوكس، البيولوجيكس، السبايرونولاكتون، زي ما دكتور عاصم كان لسه بيقول التوبيكال كالسينيورين انهبيتور، حاجات كتيرة جدا جدا ليها اوف ليبل، لدرجة ان هم في البيبرز دي تقريبا قالوا عندنا من 5 to 15% of the drugs are off label في حاجات الديرماتولوجي. اكتر من 30 دواء بيستخدم كأوف ليبل في مئات من الانديكيشنز. الحقيقة النهاردة هشير مع حضراتكم 3 حالات فيها الأوف ليبل نفع كتير جدا للحالات بتاعتنا، وأكيد لو طلبت منكم هلاقي أكتر وأكتر، بس قلت أتكلم معاكم في هذه الحالات. My first case الحقيقة واحدة اسمها عالية، هي عندها ألوبيشيا يونيفرساليس، وزي ما الدكتور كان لسه بيقول سن قد إيه نقدر ندي فيه الجاك inhibitors. So she is 7 years old. She was resistant للكورتيكوستيرويدز topical وintralesional وسيستميك، والحقيقة هي رفضت حتى انها تاخد الجاك inhibitors رغم ان احنا عارفين ان البارسيتينب واخد موافقة سنتين من اول سن سنتين للاتوبيك dermatitis، لكن اهلها رفضوا انها تاخد الجاك inhibitors وشي had severe deterioration of the quality of life. يعني زي ما انتم شايفين كانت مامتها كل شوية تبعت لي صور just waiting for a single hair انها تطلع، حاسة بفرق ولا لا، and this is from المother بتاعت البيشنت. الحقيقة في مارش 2023 كنت حاضرة الأمريكان أكاديمي، وبعدين وأنا قاعدة في المحاضرة لقيت دكتور بيتكلم على dupilumab use in children with alopecia areata and concomitant atopic dermatitis. فبعت لها قلت لها أنا في مؤتمر في أمريكا I think there will be something I can help her with. والحقيقة الدوبيليماب من الأدوية الرائعة اللي احنا كلنا بنستخدمها، and at that time في 2023 كانت ال FDA approval بتاعته كانت الاتوبيك dermatitis من أول سن 6 شهور، so it's a very very safe option. والبرورايجو nodularis later on في very recently كان واخد الابروفل بتاعت الكرونيك spontaneous urticaria والبولس بينفيجويد. في 2025 this wonderful paper اللي هي منشورة في البيدياتريك ديرماتولوجي كانت بتتكلم على السيستميك ثيرابيز للبيدياتريك ألوبيشيا أرياتا، وكانت بتتكلم إن patients هيستفيدوا من الدوبيليماب عندهم ألوبيشيا أرياتا بس مع concomitant atopic dermatitis. وهذه البيبر كانت قبل ما ادي البنوته، وكانت برضو بتتكلم على الدوبيليماب انها تقدر انها تحسن جدا الالوبيشيا ارياتا، وكانوا قايلين ان البيز لاين IgE ليفل هيقدر يفرق جدا مين هيستفيد من الدوبيكسنت او لا، وكل ما IgE عالي كل ما النتيجه بتاعت الدوبيليماب في الالوبيشيا ارياتا في الاطفال بتتحسن. والحقيقه this is very very important point of ان احنا نقدر نحسبها معانا. لما رجعت طلبت منها انها تعمل الاي جي اي ليفل وطلع 1501. So she had a very high IgE level رغم انها ما كانتش عندها signs of atopic dermatitis، وده يخلينا نفكر مع بعض why not لما يجي لي حالة pediatric اعمل لها IgE level. So this is what I wrote at that time ان هي عندها 8 years alopecia areata totalis لمدة أكتر من سنة، وإنها ال IgE level بتاعها عالي، وبالتالي I think إن أنا أقدر أدي دوبيليماب. والحقيقة كتبته لها إن دوز ملائمة لسنها دوبيكسان 300، وبعدين بعد أسبوعين أخذت حقنة تانية and then every month كانت بتاخد الدوبيكسان 300 و no labs لا في الستارت ولا في الفولو أب. 2 months later ابتدت إنها يبقى في hair regrowth, and this is 9 months after the 2 months، يعني 11 months later she had nearly full growth of her hair. والحقيقة ما حبيتش أجيب وشها، بس she had full regrowth of the eyebrows and her eyelashes and her quality of life. يعني عندي معها صور تجنن. She is on top of the world. والحقيقة من ساعتها ما فيش pediatric case ما بقيسلهاش ال IgE عشان أعرف إيه الأخبار بتاعتها. She is still on dupilumab 2 years later and she's even better عن الصورة دي، بس ما لقيتش صورة أقدر أقطعها أكتر من كده. طب اللونج تيرم يوز، عشان كان في حد بيسأل هنا على اللونج تيرم يوز of the JAK inhibitors. لونج تيرم يوز بقى بتاع الدوبيليماب is well proven, and this boy كان منشور له البيبر دي كانت بتتكلم على long term efficacy of dupilumab in alopecia areata. He has been 3 years on Dupixent with no side effects, and therefore this is a very nice option احنا نفكر فيه. بيشتغل ازاي في حالات الالوبيشيا areata؟ احنا كلنا عارفين الالوبيشيا areata is basically T helper 1 and T helper 17، ولكن this is an oversimplification of the case. There is an override من T helper 2، وبالتالي لما بنقلل T helper 2 there is some skewing ان احنا نقلل T helper 1 and 17. اكيد ممكن الاقي بعض الناس اللي هتطلع تقول لي بس احنا عارفين ان الدوبيكسنت ممكن يعمل الوبيشيا ارياتا وبالتالي كانت البيبر اكيور اور كوز، لكن لو انا اديته اصلا ان كيس اوف الوبيشيا ارياتا so this is a sure thing انه مش هيسببه وان هو هيصلح الاميونولوجي بتاعت هذا الطفل بالذات في وجود a high IgE level او a very high T helper 2. So this is my first take home message ان احنا نفتكر دوبليماب as an off-label use في الالوبيشيا cases in children اللي معاها atopic dermatitis. We can really change patients' lives safely in such cases. My second thing is this case. She's another patient of mine. كانت جاية female pattern androgenetic alopecia. She's 52 years old. عندها history of breast cancer. ففينسترايد is not on the table. intolerant topical minoxidil. حاولت معاها بكل الطرق تحط معاه topical steroid، تحطه فوم، تحطه أي حاجة. She couldn't tolerate it at all. Moderate improvement على different mesotherapy sessions, non-minoxidil topical treatment، وطبعا she was not a candidate for hair transplantation. فكرت في البوتولينم توكسين. احنا عارفين ان هو متوافق عليه عندنا في الاستاتيكس mainly for wrinkles and hyperhidrosis, but it has so many off-label uses including the hair. هتلاقوا في in this wonderful systematic review في حوالي 40 paper محطوطين معمولين على قرب 700 حالة في البوتولينم توكسين في حالات المختلفة من الهير loss, seborrheic dermatitis, craniofacial hyperhidrosis, الفوليكولايتس دي كالفانز، الترايكوداين والسكليروديرما. ولما نيجي تبصوا اكتر على الهير لوس هتلاقوا ان في AGA محطوط كتير قوي عليه بيبرز، والتالجين افلوفيوم، ترايكوتيلومانيا، الوبيشيا ارياتا بس ما كانش ليها اي ريسبونس، سيفالجيا الوبيشيا عارفينها اللي هي بيبقى فيه سيفير بين في منطقه وبعدين فجاه الشعر يقع، ده كمان كان جايب فيها نتائج رائعه، والراديشن انديوست الوبيشيا. And in this systematic review هتلاقوا البوتولينم توكسين من ضمن الحاجات اللي محطوطة، وزي ما انتم شايفين it had a very good efficacy في حالات الالوبيشيا أو الاندروجينيتك الوبيشيا. الحقيقة ملهوش بروتوكول ثابت، هتلاقوا في دوزز مختلفة محطوطة، depths مختلفة محطوطة، frequencies مختلفة محطوطة، بس this is the one I use. إن أنا بستخدم 30 international unit in 30 points once every month for 6 months، ولغايه دلوقتي ما لقيتش اي ريزيستنس او يحصل ريزيستنس للبوتولينم توكسين. طيب يبقى this is my روشيتا، عملت لها بوتولينم توكسين، اديتها بقى كملت على السيستميك سبلمنتس واديتها topical non-minoxidil and the results were really nice and I find it very impressive and the patient was really happy. How does it work? Botulinum toxin هيقلل الكونتراكتشر بتاعت المسلز وبالتالي هيقدر يزود الفاسكولار سبلاي والاكسجينيشن. كمان لقوه ان هو بيقلل الانفلتريشن بتاعت السي دي 4 والماست سيلز والانفلاماتوري سيلز اللي ليها دور كبير في الالوبيشيا ارياتا لكن ستيل موجوده في البيوبسيس بتاعت الاندروجينيتك الوبيشيا. بيقلل الترانسفورمينج جروث فاكتور بيتا عن طريق ان هو يقلل الفايبروبلاست برودكشن بتاعها، والترانسفورمينج جروث فاكتور بيتا من ضمن الكي ميدياتورز في حالات الاندروجينيتك الوبيشيا. وكمان هو بيقلل الريليس بتاعه الاس بي والكالسيتونين جي ار بي، ودول من الحاجات اللي بتعمل البيرنينج سensation. عشان كده بينفع في السيفالجيا اللي احنا كنا لسه قايلينها، بينفع في الترايكوداينا جدا جدا جدا، وكمان ممكن يقلل الهير لوس اللي مع الستريس وبالتالي هيحسن قوي الهير لوس والاندروجينيتك الوبيشيا ان جنرال. So my second take home message is إن إحنا ممكن نفتكر البوتولينم توكسين في ال AGA cases especially لما يبقوا resistant أو where other therapeutic modalities are contraindicated. My final one is this case اللي احنا كلنا لما بنشوفها بننهار، frontal fibrosing alopecia with or without facial papules. الست دي كان عندها 48 سنة and she has been progressive for the past year. Usually في الحالات دي I never miss to give oral isotretinoin. Oral isotretinoin يعني هي دي الروشتة اللي أنا بديها، بس my off-label thing is oral isotretinoin in such cases. Oral isotretinoin remains FDA approved mainly في حالات السيفير recalcitrant nodular acne، بس so many off-label uses. والحقيقة in this paper اللي اتعملت 2017 بليديا رودينسكا and راكوسكا كانت بتقول قارنت ما بين الأورال ايزوتريتينوين والأسيتراتين والأورال فينسترايد في حالات الفرونتال فايبروز فايبروزنج الوبيشيا، ولقت ان الديزيز ستابيلايزيشن في 80% من الحالات بيحصل مع الايزوتريتينوين. Even when she stopped the treatment 1 year later الناس دي معظمها فضل stable. بيشتغل ازاي؟ عن طريق الانتي انفلاماتوري اند immunomodulatory effect بتاعت الاورال ايزوتريتينوين. In this wonderful paper in 2025 قارنوا ما بين different systemic therapies في حالات اللايكن بلانوبايلاريس والفرونتال فايبروزنج الوبيشيا، ولقوا ان الاورال ايزوتريتينوين is the most important treatment في حالات الفرونتال فايبروزنج الوبيشيا، بالذات لو عملنا له combination مع topical tacrolimus. Again, this is an off-label use للtopical calcineurin inhibitor، ولكن الكومباينيشن ما بينهم again بالجروب بتاع الهير experts قالوا this is where you get the best results in frontal fibrosing alopecia. طبعا احنا ما وصلناش للنهايه في الفرونتال fibrosing alopecia، و still more off-label drugs هتستخدم، بالذات الجاك inhibitors داخله بقوه في حالات الفرونتال fibrosing alopecia، وطبعا early diagnosis still remains an important target في الحالات دي. الحقيقه لما بنديها من الاورال ايزوتريتينوين مع التوبيكال تاكرونيمس I found very good results طبعا من ناحيه الفيشيال بابيولز، وحتى في البروجريشن اللي كان موجود في الفرونتال فايبروزنج الوبيشيا with some regrowth of the hairs الدنيا ثبتت والدنيا احسن بكتير. So my third take home message is oral retinoids in frontal fibrosing alopecia, especially مع topical tacrolimus, is a perfect off-label indication. In conclusion, we need to go off the label sometimes to change our patients' lives, but still respecting scientific evidence and our experience, inshallah. Thank you very much.
لو حد عنده أي أسئلة للدكتورة رحاب اتفضل.
اتفضل حضرتك كده.
يعطيك العافيه يا دكتوره. بالنسبه للايزوتريتينوين بالفرونتال فايبروزنج alopecia, dose 10 mg or 20 or according to the body weight dosing. شكرا.
دكتور شكرا على السؤال. هو البيبر كانت معمولة على 20 ملغ per day اللي هي البحث اللي اتعمل، بس usually I go according to the body weight، لكن البيبر نفسها معمولة على 20 ملغ per day، بس I do it according to body weight.
بكرة بالمناسبة أنا عندي محاضرة يعني جزء منها على الاف اف اي. أول مرة اتكلمت في الاف اف اي كان هنا، كانت في سعودي ديرم، كان كلام غريب. بس بكرة عندي كلمتين جداد في الاف اف اي بالذات، اللي هي الفرونتال فايبروزنج الوبيشيا. الدنيا اتغيرت شويتين كده، بس كلام مهم جدا جدا جدا. اتفضلي يا رحاب.
بالنسبه لاستخدام البوتوكس في حالات السبوريك ديرماتيتس والروبيش اريات وكده، التركيز هيبقى لا في السبوريك ديرماتيتس. طيب التركيز حضرتك قلت 30 يونت، احنا بنعمل ساعات بنعمل ميزو بوتوكس في الفيس، فاحيانا بنعمل دايلوشن البوتوكس بصلاين وبعد كده بنرجع نزود مثلا هيالورونيك اسيد ميزو. هل اقدر اعمل الحكايه دي في الشعر بحيث ان انا اشتغل يعني اخد البوتوكس بعد ما خففته بعد كده ازود ميزو سيرابي مثلا ميزو هير؟
طبعا يا دكتور من حق حضرتك جدا، هي في الاخر انك وصلتي 1 يونت بير سايت في اي دايلوشن حضرتك عايزين، ان هنا انت مش خايفه على الديفيوجن بتاع البوتولينم توكسين، فاي دايلوشن حضرتك هتحبيه استخدميه، في الاخر حضرتك هتوصلي 1 انترناشونال يونت لكل زقه يعني لكل سايد.
يعني اقدر احط اكسيزوم ميزو سيرابي
طبعا يو كان كومبايند اكوردنج طبعا للبيشنتس كاباسيتي بقى في الدفع بقى.
اوكي ثانك يو.
ثانك يو فيري ماتش.
احب اقدم اخويا واخويا والدكتور هاني ابو الوفا، وهيتكلم عن الكرنت تريتمنت وانفستيجيشن في الهربس زوستر فاكسين.
هاني من الناس اللي اتسرقوا مننا وجوم هنا في السعوديه، ده انا اتقهرت يوم ما عرفت، انما اوعى تسيبنا كتير.
التسجيل عندي على فكره. شكرا حضرتك دكتور عاصم على التقديم، شكرا دكتور امين على التقديم، شكرا دكتور احمد العيسى، الدكتوره رؤى والدكتوره داني. النهارده ان شاء الله توداي ان شاء الله هناخد بعض الكلينيكال تيبس والابديتس ريجاردينج ذا هيربس زوستر. My talk today have 4 topics or points. Number 1, pediatric herpes zoster. Number 2, vascular herpes zoster. Number 3, antiviral therapy, evidence-based highlights and updates. Systemic steroids in herpes zoster and guidelines for management of post-herpetic neurology. في last few months بدأنا نشوف حالات herpes zoster in children. This is a 9-year-old boy presented by asymptomatic herpes zoster وكان جاي العياده بيلعب ما عندوش اي مشكله خالص وبنفحص الطفل اللي عنده classical herpes zoster. في اي complaint? There is no any complaint with the child. Actually الليتريتشر ما فيش حالات كتيره regarding او كلام كتير regarding الchildhood او البيدياتريك herpes zoster. الانسيدنس very rare or 0.45 per 1000 among children below 14 years. About 3% of cases of pediatric herpes zoster may be associated with internal malignancy. The primary infection, as we know, there is no herpes zoster without primary infection or primary varicella. So that the primary infection of varicella is thought to be due to a neutral exposure infection during infancy. Sometimes the Varivax vaccine or varicella vaccine may induce chickenpox or varicella even subclinical and later on reactivation عشان يعمل لي pediatric herpes zoster. Pediatric herpes zoster should be differentiated from the zostriform or dermatomal herpes simplex. Zostriform or dermatomal herpes simplex differs from the pediatric herpes zoster is that it is less painful, recurrent because it is a herpes simplex. Vesicles are superficial, fragile with incomplete dermatomal distribution, has a younger age onset, has a shorter course. To differentiate between pediatric herpes zoster and zoster-form herpes simplex, PCR is able to differentiate between the herpes zoster and zoster-form herpes simplex. How to manage a case of pediatric herpes zoster? At first, you have to rule out the underlying immunosuppression by assessing the lymphocyte counts, CD4, CD8 ratio, and the serum immunoglobulin. Sometimes the immune suppression unpredictable. The treatment of pediatric herpes zoster in a healthy child with mild rash or eruption, just reassurance, symptomatic treatment, no need at all for systemic antiviral such as الكيس اللي انا وريتها دلوقتي اللي هو 9-year-old child كان جاي asymptomatic ما عندوش لا systemic manifestation ولا بين خالص مكان الإيرابشن وبالتالي just reassurance there is no need for systemic antiviral. What is the vascular herpes zoster? Herpes zoster is not only a neuropathic virus but also a vasculopathic virus. الهربس زوستر احنا عارفين ان هو الاولد كونسبت that it is a neuropathic virus لكن بدا يظهر له vascular complication in the form of myocardial infarction and cerebral stroke. There are many multiple reviews, systematic reviews and meta-analyses linked the herpes zoster attack by myocardial infarction and cerebral stroke. Herpes zoster increased the incidence of stroke and myocardial infarction of 0.3 to 4-fold. The onset of cerebral stroke or myocardial infarction usually start from the first month of infection to the first year, sometimes up to 2.5 years. Herpes zoster ophthalmicus is the most common type of herpes zoster, sometimes followed by vascular complications. The age or the incidence of stroke, the absolute incidence is higher in elderly, while the relative risk is higher in patients below the 40 years. So even in younger patients below 40 years, sometimes there is a vascular complications. So there are some measures to minimize the vascular risk, which include prevention of herpes zoster. The best treatment of herpes zoster is prevention of herpes zoster, and the only way to prevent herpes zoster is vaccination. Early treatment of the herpes zoster in the first 3 days by initiation of antiviral is very important to abort the infection, to minimize the infection, and to minimize the subsequent vascular risk. Control of other risk factors. And when the patient came with other risk factors like metabolic syndrome, smoking, it is important to control these risk factors in order to avoid adding more risk factors induced by the infection. Education of the patient, it is very important to educate the patient and his relatives in recognizing the early signs of stroke and myocardial infarction اللي هي ممكن تحصل في أول سنة وخصوصا في أول سنة بعد الاتاك بتاع الهربس زوستر. Regarding the antiviral therapy, evidence-based highlights and updates, there is no need for topical acyclovir in immunocompetent patients. Immunocompetent patients جايب herpes zoster, there is no need at all for the topical antiviral acyclovir. No need for systemic antiviral immunocompetent patients younger than or less than 50 years old with mild truncal disease. So the patient with herpes zoster لو كانت الاميونيتي بتاعته good immunity الايدج بتاعه اقل من 50 years الراش بتاعه mild راش موجود في الترنك مش في الفيس there is no need for systemic antiviral. It is just symptomatic treatment. The ideal time to initiate antiviral therapy in herpes zoster regarding the immune-competent patient, the ideal duration or period to initiate the antiviral therapy should be in the first 72 hours. However, if there is still new lesions erupting, if there is a severe or complicated zoster such as zoster affecting the ocular or facial nerves, you can give the systemic antiviral up to 7 days from the rash onset. However, in immune-compromised, the situation differs. In any time immune-compromised patient came to the clinic with herpes zoster, you have to initiate the acyclovir antiviral. دي يمكن بوم ودي يمكن انوفيشن جديد جدا في حالات الهربس زوستر ان احنا بنعالج الهربس زوستر بدل ما بندي 800 مللي جرام اسايكلوفير 5 times daily or 1 جرام فالاسايكلوفير 3 times daily 6 قراص في اليوم اللي هو الفالاسايكلوفير. This is a new antiviral Providine is a novel single dose drug therapy في الهربس زوستر despite ان هو still لسه مش EMA ولا FDA approved, but it is widely distributed and used in many European countries such as Germany, Spain, France, Italy, and the other European countries. Single daily dose 100 and 125 milligram for 7 days. It is more effective than acyclovir. Comparable efficacy to famciclovir, effective and safe and may decrease the risk of post-herpetic neuralgia compared to other antivirals. Side effects of Brividine include GIT upset, serious side effects if the patient is taking chemotherapeutic drugs such as 5-fluorouracil or fluoropyrimidines. So it is innovative antiviral used as a single daily dose for treatment of herpes zoster. وبالمناسبة there is no dose adjustment in patient with renal impairment وده أحد المميزات بتاعة البروفيدين. Dose adjustment of acyclovir in patient with hepatic impairment, there is no need for dose adjustment. This is because acyclovir not metabolized by the liver. However, dose adjustment in renal condition or renal impaired is indicated in any patient on intravenous acyclovir, in a patient elderly above 65 years old, any patient has renal impairment, in a patient use a nephrotoxic drug, you have to adjust the dose of acyclovir according to create clearance, not to serum creatinine. How to obtain a create clearance from a serum creatinine? There is a simple equation called Cockcroft formula. Within few minutes, you can do a lab analysis for serum creatinine, and you then go to Google search online to search for the Cockcroft formula. This Cockcroft formula is present online. You just put these items: gender of the patient, the weight, the height, the age, serum creatinine, then click calculate. The creatinine clearance within few seconds will be calculated, and then you go to Google search again for adjustment of the dose of the acyclovir according to creatinine clearance, not to serum creatinine. What is the role of systemic corticosteroids in herpes zoster? Systemic corticosteroid in herpes zoster is one of the most effective treatment in relieving the acute zoster pain, but has no effect on the post-herpetic neuralgia, provided that the case of the herpes zoster should be moderate to severe cases. There is no rule of the systemic steroid in mild case of herpes zoster. It should be taken in the first week, should be an immune-competent patient to avoid more immunosuppression and exacerbation of flare of herpes zoster. If there is a significant neurological symptoms such as herpes zoster ophthalmicus or CNS, systemic and steroid should be given under cover of systemic antiviral. The dose is prednisolone 40 to 60 milligram daily for 1 week, then tabar by 10 milligram every 2 days over the next week. This is the indication of systemic corticosteroid, and this is the most effective treatment of acute zoster pain. Last point is the treatment of post-herpetic neuralgia. Number 1, patient education. Number 2, prophylactic treatment. Number 3, active therapy. At first, patient education in risk patient, especially patient above the 50-year old and the patient immune compromised or having severe rash or pain, this is patient will develop post-herpetic neuralgia, and this is unavoidable side effect. Prevention of herpes zoster is the best line because post-herpetic neuralgia, once established, it will be refractory to the treatment. Steady improvement occurs with time. Cognitive and behavior therapy and physiotherapy sometimes helpful in post-herpetic neuralgia. Prophylaxis against post-herpetic neuralgia is by vaccination, whatever in children or adults, early initiation of antiviral, especially in the first 72 hours, is very important to minimize the chance or severity of post-herpetic neuralgia. Early initiation of neuropathic painkillers is very important. Sometimes early initiation of amitriptyline or triptazole or early initiation of gabapentin or pregabalin sometimes may be associated with decreased risk of post-herpetic neuralgia in risky patients. The last point is active treatment of post-herpetic neuralgia, and this is a flow chart supported by many guidelines. The first line for post-herpetic neuralgia is the neuropathic pain killers, whatever oral, such as tricyclic antidepressants, amitriptyline, nortriptyline, desmipramine, and the gabapentinoids, such as gabapentin and pregabalin. Number 2, in the first line, topical or patches, topical neuropathic painkillers such as lidocaine and the capsaicin. If there is a failure of the first line, we can go to the opioids such as tramadol, oxycodone, and lastly, the third line refer to pain clinic or interventional options. Take care about the anticholinergic side effects of tricyclic antidepressants and the dependence and sometimes suicidal ideation that may be associated with gabapentin or pregabalin. Dose titration starting with low dose and increasing gradually. This is the last FDA-approved topical treatment for herpes zoster by Bondilido lidocaine patch, approved in September 2025. And this is evidence-based guidelines regarding the interventional therapies or pain clinics. It takes low to moderate evidence. And lastly, thank you so much.
شكرا دكتور هاني فعلا. بيدينا دايما هنت حاجات فيها إبداع، فاحنا دايما نشكره وفي أسئلة يا دكتور هاني. اتفضل يا فندم. اتفضل.
شكرا دكتور هاني. بالنسبة للبيشنت اللي على renal dialysis,
yes,
will you do any adjustment for the dose? This is number 1. Second question is, if a patient already he's above 60, he had the herpes zoster, would you recommend vaccination?
Regarding the first point, if the patient on the hemodialysis, at first I should correlate with the nephrologist. But according to my experience from the literature, after dialysis, the dose should be repeated again because it is removed by the process of dialysis. But this is point I should correlate with nephrologist. Regarding the herpes zoster, any patient get infected by herpes zoster, whatever the 60 years, any patient above 50 years should be vaccinated, whatever he get infection in the past or not.
But we as dermatologists, we have seen, we all are very seniors, and we've seen once a patient has herpes zoster,
yes,
it's extremely rare
yes,
that he gets another herpes zoster.
Yes.
I have never seen in my life a patient unless he is immunocompromised.
Yes, I have one patient 2 weeks ago. She was vaccinated about 3 to 5 years ago, and she developed a herpes zoster after vaccination. And this is reported because the Shingrix vaccine prevents the reinfection in about 80 to 90% of the cases. But the patient, despite it is a 67 years old elderly patient, she complaining of nothing regarding the herpes zoster. It is asymptomatic, very mild asymptomatic herpes zoster. According to the guidelines, whatever the patient infected before or not infected should receive the herpes zoster vaccination from the age of 50, 2 doses, 6 months apart, 12 months apart.
شكرا شكرا يا هاني خالد. بالمناسبة عندنا 2 epidemics في المنطقة، بس epidemic رهيب، ويعني ما ينفعش اسمها ايه نخبي راسنا ولا بتاع، وضروري نجد العلاج، نجد العلاج له. واحد HPV، لأن ال HPV ماشي زي الصاروخ. تاني والتاني أهم، الريزيستنت ديرماتوفايتوزز. ريزيستنت ديرماتوفايتوزز مش وباء ومش ابيديميك، لكن ما مش عارفين زي ما بيقولوا كده ندخل له منين. انا كنت فاكر لوقت قريب قوي، عشان كده سالت اخويا الدكتور احمد، ان الفي فنت هايلي كيوريتيف، وكنت فاهم لوقت قريب قوي ان احنا لما ندي في فند واترا كونازول و بينتهي الوباء ده، انما الوباء ما زال متفشي ومش عارفين نوقفه. فاحنا قلنا ان مين اللي يقول لنا الحل ان شاء الله؟ الاستاذنا الدكتور ايه كده بيتكلم مين؟ بيكلم مين اهو؟ طب تعال. استاذنا وليد البلاط هيتكلم على الريزيستنت ديرماتوفايتوزز. يا جماعه عايزين نخلي بالنا شويه من طرق العلاج. يعني انا العلاج حاجه، بس ازاي العيله دي بيضرب فيها كده ازاي؟ انا متاكد من حاجات، بس بعد ما نسمعها من الاستاذ الدكتور وليد البلاط. اتفضل يا فندم.
شكرا لبيع التقدمه الجميله، وطبعا ببارك دكتور احمد العيسى ودكتوره ربا على نجاح المؤتمر وعلى الدعوه الكريمه. يمكن كان زي دكتور عاصم بما بيقول، احنا عندنا مشكله الفنجاي دي او ريزيستنت فانجل انفكشن، بقت مشكله كبيره جدا. يمكن في مصر دي اتصدرت لنا بقى من الخليج، معلش بقى جت لنا من السعوديه في الاول. طيب هل هي بقت بريفيلنت وورلد وايد؟ هي بقت بريفيلنت وورلد وايد. يمكن هي بدات في الاول في الهند، حتى الريزيستنت سترين اللي طلعت سموها اندوتيني، يعني تينيا اندوتيني جاء من انديا. اول حالات بدات تو بي ريكوردد كانت في 2021. حتى ايفن الدبليو اتش او بقت عملت لسته كده لاكتر 10 حاجات لازم هتبتدي تشتغل عليها. اولها الانتو مايكروبي ريزيستنت، كانت انكلودنج الفنجاي والانتي فانجل ريزيستنت. بقينا نلاقي ان خلاص بقينا الدرماتوفايتس سبيشال الحتت بتاعت التربنافين ريزيستنت درماتوفايتس وصلت لفين؟ وصلت لحد بولند، فيتنام، استراليا، يعني راحت لحتت بعيد قوي، وكلها كانت بيزد اون ستادي. يمكن شايفين الخريطه دي، كل الريد اريا دي حصل فيها ستاديز للريزيستنت فانجل انفكشن. شايفين يمكن تقريبا المملكه كلها متغطيه، كلها ريد اريا. الغريب بقى ان احنا عندنا في مصر ما عملناش ولا ستادي على الموضوع ده. very blue، مع ان هي في الحقيقه is very red. طيب هو ايه اللي بيحصل؟ عايزين نعرف الميكانيزم بتاعت الانتي فانجل ريزيستنس بتحصل ازاي، الدايجنوزس وهنتصرف معاها ازاي، والجديد الستيوارد شيب اللي حصلت كمان الانتي فانجل. الميكانيزم بتاعت الريزيستنس عندنا قسمناها حاجتين، كلينيكال ريزيستنس وميكروبيال ريزيستنس. طب الاول نعرف شويه الانتي فانجل بيشتغلوا ازاي. زي ما احنا كنا عارفين زمان الجريزوفالفين بيعمل انهبيشن للميوزس، الحته بتاعت اللانوستيرول سينثيسيس اللي هم التربنافين والنفتافين البيوتافين، وبعد كده الازول جروب اللي هي شغاله على الارجوستيرول سينثيسيس، والايكونوكاندينز اللي هم شغالين على السيل وول سينثيسيس، والنيوكليك اسيد سينثيسيس اللي هو ال5 فلوتوسايتوزين ده اللي هو احنا ما بنستخدموش بس ملي بيستخدم في العنايه، والبولنز بقى اللي هي بتيجي على الممبرين بتاع السيل بتاع الفنجل وتبتدي تزود فيها البور فورميشن فتعمل برضو وول ديستراكشن. اشهرهم اللي هو الانفوتريسين بي، واحنا بنستخدم النستاتين توبيكالي. ده برضو بقى من اول السكوالين لحد الارجوستيرول، دي هاو ذا سيل وول بتاعت الفنجل بتبتدي تشتغل، والجينز معظم الجينز دي الارجوستيرول جين 1 لحد 4 و6 و11 هم دول اللي بيحصل فيهم الميوتيشنز اللي بتخلي الدراجز ما تشتغلش. كمان معاهم السكوالين ايبوكسيديز واللانوستيرول سينستيز واللانوستيرول سي 14، كل الحاجات دي بدأ يحصل فيها ميوتيشن على مستوى المولكولار بيولوجي بتاعت السيل بتاعت الفنجل اتسلف، كل دول بقى حصل فيهم جينيتك ميوتيشن. ده المهم. الانتي فانجل ريزيستنس بتحصل ازاي؟ حاجات ريليتد للاورجانيزم اتسلف وحاجات ريليتد للهوست، بس هم قسموها مايكروبيال ريزيستنت وكلينيكال ريزيستنت. مايكروبيال برايمري وسكندري. البرايمري هو في جينيتك ميوتيشن حصلت زي ما قلنا، التربنافين ريزيستنت ترايكوفايتون سبيشيز، والفلوكونازول ريزيستنت ايزر كانديدا او الاسبرجيلس. الناحيه الثانيه لا، ده كمان مش الميوتيشن بقت برايمري اللي طلعت لوحدها، لا بقى في اكوايرد ميوتيشن، الحته بتاعت سكوالين ابوكسيديز والاوفر اكسبريشن بتاعت الدراج اتسيلف واكوايرد انفيرومنتال ريزيستنس وبايو فيلمز، يمكن الحاجات دي قابلناها كتير. طب الهوست ده ريليتد للعيان نفسه، الايدج بتاع العيان، الاميون ستاتس بتاعته مع اذر ديزيزز، دايابيتس، سورايسيس، هيباتيك ديسفانكشن، يعني الجنرال ستاتس بتاعت العيان. الديزيز فاكتور بقى، هل الديزيز السيفيريتي بتاعته قد ايه، الانتشار بتاعه قد ايه، الديوريشن، وكمان نون التريتمنت فاكتور بقى. طيب انا اديت العيان العلاج صح من الاول ولا لا، اديته له فتره كافيه ولا لا، كمان الفارماكو داينامكس بتاعه التريتمنت، هل البنتريشن بتاعه قوي للمنطقه المصابه ولا لا. وممكن برضو يبقى انا في الاخر انا عمل لي incorrect diagnosis. وحته البولي فارماسي دي، طب العيان ده بياخد ادويه تانية ولا لا، بياخد ادويه كتير ولا لا. في بعض الناس ممكن ابقى انا مشخص صح ومدي الدوز صح، بس العيان زهقان، العيان عنده اذر دراج، وغالبا الدكاتره التانيين والعيان نفسه بيقول لك لا انا هركن دواء الجلديه شويه فيزود الحاله. دي صوره برضو بتبين هم كانوا شغالين ازاي الدراجز، والفنجل وول بتعمل فيهم ايه. يعني الام دي ار 2 و4 و5 دي بورز كده، هو الفنجس بدا يزودها، فالدراج بدا يخرج اسرع بره الخليه بتاعته، بدا يغير شكل. يعني حته بتاعت اللانوستيرول 14 الفا دي ميثايليز، ده اللي الدواء بيشتغل عليه، بدا يغير شكل الانزيمز. يعني احنا بنحارب مخلوق سبحان الله ذكي جدا، يعني هو فنجل بس هو ذكي جدا، ده غير شكل الانزيمز، غير شكل التارجتس بتاعت اللي الدواء هيروح يمسك فيها، الدواء مش هيمسك فيها لان شكلها استراكشر يتغير، وكمان بقى يخلي الدواء يحصل له افلاكس من جوه السيل بسرعه جدا، يبقى مش هيأثر. ده البايو فيلم زي ما احنا عارفين، والجلوكاكان. احنا زمان كنا بنقول البايو فيلم بيحصل في الكانديدا بس، لا ده لقوا ان معظم الريزيستنت ديرماتوفايتس هي كمان بقى ليها القدره انها تعمل بايو فيلم. يبقى مش بس بتريزيست، لا دي كمان بتعمل بايو فيلم تخلي الدراج ما يعرفش يوصل لها. environmental resistance، البلاد الكتيره اللي بتستخدم البيستسايد، وطبعا يمكن اكتر دوله في العالم بتستخدمها كانت الهند، وده برضو جزء مهم من الريزيستنس. لما عملوا مقارنه لقوا ان اوروبا بتستخدم 10 مرات اضعاف اليو اس اي في حته البيستسايد. وكمان لقوا المشكله مش بس في البيستسايد، لا الازول بيزد بيستسايد، يعني الانتي فانجل اللي بيستخدموها في الاجريكلتشر وازول بيزد، دي بتاثر على الانفكشن سواء اللي بتيجي للهيومن او بتيجي للانيمال، فعملت لي جزء من الانتي فانجل ريزيستنت. طب هل الدايجنوزس هنعتمد بس على الكالتشر؟ لا، كمان بدانا ندخل في الحته بتاعت البي سي ار، بقى مهم جدا. وبقينا كمان زي ما كنا بنستخدم الحته بتاعت الكالتشر والسنسيتيفيتي في الانتي بايوتيك، لا ده انا كمان بقى مهم قوي الانتي فانجل سسبتابيليتي تيستنج. وبقى عندي 2 كوميتيز، واحده يوروبيان اللي هي كلينيكال لابوراتوري ستاندرد انستيتيوتس، واليوروبيان كوميتي اون انتي مايكروبيال سسبتابيليتي تيستنج. يمكن الاكثر فعاليه هي كلينيكال لابوراتوري ستاندردز دي، عشان دي بتقيس فيري ريستريكتلي وما بتديش ان العيان او الفنجل سنسيتيف للدراج ده غير لما يبقى السنسيتيفيتي فوق ال 90%. يمكن الحته بتاعه اليوروبيان لا دول 50 60% ويقول لك ده سنسيتيف، فدي برضو مهم. طيب الاستراتيجي بقى، هل المانجمنت هيبقى بس معتمد ان احنا نستخدم النيو دراج يعني الفوريوكونازول، يمكن هو ده الموست افيلبل دراج موجود سواء في مصر او السعوديه؟ لا، لو انا هو الدواء غالي، دكتور عاصم دايما بيقول في المحاضرات العلبه في مصر ب 7000 جنيه او 8000 جنيه. ده سوق سودا بيبقى 9000 القرص ب 1500، يبقى كده العلبه عدت ال 12000 جنيه. طيب واعتقد هي اصلا كمان هنا في المملكه غاليه شويه. طب يبقى انا لازم هستخدم الحاجات او الاسلحه اللي في ايدي. الاسلحه اللي في ايدي زي ما احنا عارفين التربنافين، الاتراكونازول. طيب هديها بالنورمال دوز؟ لا، ده احنا وصلنا ان احنا ندي ال 250 مللي جرام بتوع التربنافين هنديها توايس ديلي فور اب تو 3 مانثس، وفي بيبرز بتديها فور 6 مانثس، وفي بيبرز بتديها فور 1 يير. ما العمل ما بتحسنش. وهنعمل كومباينيشن كمان مع الاتراكونازول. هدي الاتراكونازول 400 مللي جرام بير داي فور 1 مانث 2 مانث 3 مانث، واعمل كومباينيشن كمان مع التربنافين، ونزود بقى البالسز براحتنا. الفلوكونازول في الحته بتاعت الريزيستنت ديرماتوفايتس هاز نو رول، تقريبا ما بيجيبش نتيجه خالص. طيب دي بقى النيو دراجز كلها لسه ما خدتش اف دي ابروفل، يمكن بس الفوريوكونازول، وفي البوسكانازول والاوستيوكونازول. كل الحاجات دي بس يمكن مش افيلبل في الميدل ايست غير الفوريوكونازول. وده الكومباينيشن ثيرابي اللي لسه كنا بنقول عليه. مش هنستخدم الوان انتي فانجل، لا ممكن اعمل كومباينيشن لميني انتي فانجل دراجز. حتى ايفي في ناس بتقول لما يحصل الكلينيكال كيور ريت، لا ده انا ما اوقفش، اكمل شويه عشان يحصل لي الميكولوجيكال كيور ريت. الميكولوجيكال كيور ريت ده ممكن الاقيه بعد 2 3 من الكلينيكال كيور ريت. حتى بعد ما العيان يخف ممكن اضطر ان انا اعمل فانجل كلتشر. ده كان كلينيكال ريبلاتوري دايجنوز. زي ما بقول لكم لا نكمل شويه بعد ما الكلينيكال ريسبونس يحصل. ودي الالترناتيف تريتمنت. لو حصل لي فيلير ابتدي اغير بحاجه تانية. طب هل الانتي فانجل بس؟ لا، يمكن المشهور قوي ان انا بعمل كومباينيشن من الانتي فانجل مع اذر دراج. اكتر حاجه مشهوره عندنا الايزوتريتينوين، ويمكن الايزوتريتينوين لا طلعت نتائجه مش احسن حاجه لما حتى بعمل كومباينيشن، ما بيأثرش قوي على الاوتكم. الغريب بقى ان احنا ممكن نلاقي انها في كومباينيشن مع السايكلوسبورين، كومباينيشن مع الستاتينز بتحسن جدا. الكيميكال بيلينج اللي هو السلسليك اسيد يمكن عليه ستاديز كتيره والسيفتي مارجن بتاعته عاليه، يعني دايما ما بنسمعش مشاكل من البيلينج مع السلسليك اسيد. الفراكشنال ليزر either as a way for drug delivery او ان هو بيعمل بيلينج والهيت بيأثر على الفنجل. الانتي فانجل ستيوارد شيب دول ان احنا نعمل اداره للانتي فانجل، هم الايت ستيبس دول، وملي الاترا والفوريوكونازول. تيك هوم مسج ان انا دايما جود دايجنوزس از ا ماست، ولازم اعمل كومباينيشن، ودايما اخد بالي ان احنا هناخد وقت اطول بكتير. دي الستاديز اللي عايز اصورها، هم about 6 studies. Thank you.
دكتور وليد، يعني مش عارفين نشكر حضرتك ازاي. it was an amazing lecture. بس ممكن حضرتك تقول لنا تاني الجرعه بتاعت الفوريكونازول؟
الفوريوكونازول هو بيتاخد منلي 200 مللي جرام twice a day. اهم حاجه انها تبقى بيفور ميل، وزي ما قلنا هو في الاول for 1 month، لكن انا ممكن امشي عليه 2 months or 3 months according للكلينيكال ريسبونس اللي انا شايفه. ولو عايز اعمل كومباينيشن ممكن اعمل كومباينيشن بتوبيكال انتي فانجل دراج. ونقطه مهمه قوي ان احنا ما نستخدمش التوبيكال انتي فانجل اللي فيها كومباينيشن مع الاستيرويد. يمكن دي في الانتي فانجل ستيوارد شيب دي بقت بروهيبيتد خالص ان انا استخدم انتي فانجل ميكسد ويز ستيرويد.
ثانك يو سو ماتش يا دكتور وليد. في سؤال؟
شكرا دكتور على الريفيو. بالنسبه للمونيتورنج you're giving very high doses now, double the doses which are recommended. How frequent you do liver function tests?
هو معظم الحاجات اللي موجوده يعني ما لهاش افكت قوي على الليفر فانكشن تيست. يمكن بس كان الكوتكونازول، بس حضرتك ممكن تعملها every month لو انت عايز تطمن.
الاتراكونازول you're giving double the dose, huh?
Every 4 weeks.
And you're combining itraconazole with other antifungals.
ما انا بقول حضرتك كل 4 اسابيع.
Okay. What about the NDIAG? You've mentioned only fractional lasers. What about the NDIAG role?
الاندياج mainly كان الاستخدام بتاعه في الاونيكومايكوزس. يعني معظم استخدامات الاندياج كانت في الاونيكومايكوزس حتى لوحده without systemic antifungal.
What about the
I have a paper on this issue يمكن 2019.
Okay. What about the pediatric age group?
البيدياتريك ايدج جروب دي مشكله كبيره، بس ممكن نستخدم الباي بادي ويت. انت عارف ان هو اصلا الموست اكسبتابل كان دراج، خصوصا ان الاكتر حاجه بتيجي في البيدياتريك كانت التينيا كابيتس، كان الجريزوفالفين والدوز بتاعته. فاحنا ممكن ندي دوز اكوردنج بادي ويت. وهل هنطول الفتره بتاعتها؟ هنطول، بس الحمد لله لحد دلوقتي معظم حالات الريزيستنت درماتوفايتوزس دي ادلت، ما شفتهاش في بيدياتريكس، وما فيش حتى ريبورتس كتير عليها في بيدياتريكس.
شكرا دكتور.
نعم.
يشرفني ان اقدم
هنا بقى
ممكن
شكرا.
يشرفني ان اقدم زميلتي واختي دكتوره نيفين درغام. هنتكلم بقى، انت تتكلم على الاستاتكس، هتتكلم على brow shaping using botulinum toxin, which is يعني the highest skill of using the botulinum toxin, how to do the brow shaping.
شكرا جدا، ميرسي يا دكتور امين، وميرسي لكم كلكم التواجد. عارفه ان احنا اتاخرنا سنه، بس ان شاء الله تبقى محاضره انترستنج وظريفه خفيفه. الاول بس حد عايزني اتكلم انجلش؟ عادي؟ اوكي. طيب احنا يا جماعه لما بنتكلم على البراو شيبينج فاحنا لازم نعرف ان الفيس عباره عن بالانس between all the muscles of the face. ولما نعرف كل ماسل بتشتغل ازاي وايه الاجونست وايه الانتاجونست بتاعها نقدر نعمل شيبينج زي ما احنا عايزين بالظبط للبراو او لاي حاجه في وشنا. البراو بالذات فيه ديبريسور واحده اللي هي الكبيره اللي هي كوريجيتور، ديبريسور تانية بتاخد كل البراو وتنزل اللي هي الاوربيكولاريس زي ما احنا شايفين. الكوريجيتور بتدبريس داونوردز وميديالي، والاوربيكولاريس بتدبريس داونورد ولاترالي، وفي one elevator اللي هي الفرونتاليس. لما نيجي على البراو شيبينج نتكلم على اندز، على شكل احنا عايزين نحدده ونرسمه بالتوكسين رسم. الميديال اند بوزيشن بيعتمد على بالانس بين ذا كوريجيتور سوبرسيلياي، البروسيرس والديبريسور سوبرسيلياي. دول الثلاثه اللي هيعملوا ديبريشن للميديال اند اوف ذا ايبراو. طيب ايه اللي ممكن يرفعه؟ again my only elevator الفرونتاليس. يبقى انا لما هشتغل على ايه؟ على الديبريسور. اول حاجه لازم اوقفهم. بعد ما اوقف الديبريسور وانا بوقف الديبريسور لازم اخد بالي كويس قوي ان انا ما اضربش الاليفيتور بتاعتي. ازاي؟ وانا بشتغل على البروسيرس اخد بالي ان في بروسيرس فرونتاليس كونكشن، فلازم انجكت البروسيرس بتاعتي below the level of the connection. يبقى ما ينفعش ان انا انجكت البروسيرس في الحته اللي ما بين التو اي براوز. الحكايه دي غلط. حتى لو انا عندي الفولد موجود هنا فمش ده الفولد اللي انا هحقن فيه. انا لازم انزل below level of the connection عشان احقن. شايفين الكونكشن موجوده فين؟ يبقى انا لازم انزل تحتها. يبقى دي اول تيب. تاني تيب، الكوريجيتور نفسها اللي هي المين ديبريسور في كمان بينها وبين الفرونتاليس كونكشن لانهم كلهم intermingle together. يبقى انا دلوقتي لما انجكت الكوريجيتور لازم انجكت الهيد very deep لان الفرونتاليس سوبرفيشال، فلما انجكت ديب انا هافويد الكونكشن دي. وان انجكت في الماسل بالك لازم اخد بالي بالذات في الناس اللي راسمه حواجبها او اللي مغيره شكل حواجبها ان انا ليا دخل بالماسل بالك وليس شكل الحاجب نفسه. يبقى الانجكشن بتاعي يا افويد انه يعمل دامج. تاني حاجه عملتها ان انا بقى الاكتيف ديبريسور سوبرسيلياي لو موجوده عند البيشنت لازم ادرس الاكتيف ديبريسور سوبرسيلياي. مش موجوده عند كل الناس، لكن لو كده هحط فيها 2 to 3 يونتس ديب انجكشن ويبقى دايركتد ميديالي وابوردز. دي الحته بتاعتها اللي هي الديبريسور سوبرسيلياي. بقى دايركت النيدل بتاعتي ابوردز وميديالي عشان ما يبقاش في اي نوع من انواع الانترفيرنس. الاوميجا ساين لما اشوفها عند one of the patients اخد بالي. على فكره دي اللي في ناس بتقول عليها ان الكوريجيتور، واظن احنا سمعنا دي، الكوريجيتور اذا اليفيتور. سمعتوها قبل كده دي؟ الكوريجيتور معروف من زمان ان هي ليها كونكشن مع الفرونتاليس. مش كونكشن بس، ده في انترمينجلد فايبرز كتير جدا. في بعض البيشنت الكونكشن ده بيبقى سو سترونج لدرجه ان البيشنت لما تحاول تفراون بالكوريجيتور تشغل الميدل فايبرز اوف ذا فرونتاليس فيري سترونجلي زي كده وتديني الاوميجا ساين وترفع الميديال اند اوف ذا اي براو. هل معنى كده ان الكوريجيتور قلبت عندي اليفيتور وان انا لو حقنتها هينزل؟ لا بالعكس خالص. ده انا هنا هضطر لو عايزه اشتغل لازم احقن كمان الفرونتاليس الميدل فايبرز بس. طيب يبقى كده الميديال سايد قلنا هنشتغل عليه ازاي. اللاترال اند بوزيشن is a battle، وانا دايما بحب احط في دماغي انها battle between the orbicularis oculi والفرونتاليس. اول حاجه هعملها في البيشنت اني احدد شكل الفرونتاليس عنده ايه. الفرونتاليس مش عندنا كلنا زي بعض، مش في كل البيشنتس زي بعض. حسب الفايبرز بتاعتها هحدد اذا كان البيشنت دي ينفع يترفع لها اللاترال اند ولا ما ينفعش. ممكن جدا جدا في بيشنت بالذات زي الثالث دي، البيشنت دي لو حقنت الميدل فايبرز بس اللاترال فايبرز مش قويه انف انها ترفع اللاترال اند. On the other hand البيشنتس اللي عندهم اللاترال فايبرز قويه جدا الوضع هيبقى مختلف. لو حقنت الميدل بس هتعمل لي مافيستو ساين. يبقى انا لازم اخد بالي من اللاترال فايبرز. ما دام بتكلم على الشيب اوف ذا لاترال اي براو، اول حاجه بص عليها اللاترال فايبرز اوف ذا فرونتاليس قويه تقدر ترفع اقول لها ايوه حضرتك ينفع نغير شكل التيل اوف ذا براو. طيب هي مش قويه مش هتقدر ترفع، يبقى ساعتها هلجأ للستيب اللي بعدها. هنا الفرونتاليس عندي قويه فانا حقنت الميدل فايبرز وسبت اللاترال فايبرز تكمبنسيت، فابتدى يترفع في ارشد شيب اسمها elevation في اللاترال براو ارش شيب. طب لو انا لقيت ان الفرونتاليس اللاترال فايبرز ضعيفه او شغاله بس مش قادره ترفع اللاترال اند اوف ذا براو في دروبينج جامد، هلجأ لايه؟ ما انا خلاص الاليفيتور اللي عندي مش لاقيه لاترال فايبرز. هبدا الجأ لتكنيك عكسي، ان انا اشوف الديبريسور واوقفها. يبقى هعمل ايه؟ هدخل على الاوربيكولاريس اوكيولاي الديبريسور بتاعتي واوقف الشغل بتاعها بناء على الشيب اللي انا عايزاه. لو انا عايزه الشيب بتاعي يبقى ارشد هحقن between the medial 2/3 ولاترال ثيرد، وكده وقفت mainly الفايبرز اللي عامله الارش واخده داون، فهتاخد ارش. ليه هتاخد ارش؟ هتاخد ارش عشان بقيه الفايبرز اللاترالي شغاله فبتنزل اللاترال اند والارش بس هو اللي بيترفع. طب لو عايزه ارسمها ان هي كلها تترفع اللي هو التيل كله يبقى elevated، لو التيل كله elevated هحقن عند الجنكشن وهحقن عند اللاترال اند، لازم احقن عند اللاترال اند عشان كل التيل يترفع. يبقى انا كده هحدد انا عايزه ارش ولا عايزه تيل elevation بس. الفرونتاليس كمان مش سايباني في حالي في الحته دي، هي حتى الاوربيكولاريس اوكيولاي عامله جنكشن معاه. يعني انا ممكن اكون اساسا عايزه اضرب الاوربيكولاريس اوكيولاي، عايزه اقلل الفانكشن بتاعتها، عايزه ارفع اضرب غصب عني الفرونتاليس. طب هعمل ايه في القصه دي؟ عارفين ان الكونكشن مكانها اخر مكان للكونكشن دي هو الليفل اوف ذا اي براو. يبقى عشان ابقى سيف الحقن بتاعي ما يبقاش في الاي براو، يبقى تحت الاي براو. تحت الاي براو النقط بتاعتي كلها مرسومه تحت الاي براو. بيشنت زي كده احنا شايفين حقنا لها الميدل فايبرز في ناحيه من الاي براو عاليه مش عايزاها تعلى، فبحقن اللاترال على الناحيه دي. الناحيه الثانيه بالعكس دي عايزه تعلى وما فيهاش لاترال فايبرز شغاله، واضح طبعا لان مفيش كسرات. وهنا هحقن الاوربيكولاريس على ناحيه والديبريسور حتى شغال على ناحيه اكتر. وهنا بعد الحقن اصبحت سيمتريكال، الناحيه اللي كانت واطيه اترفعت. نفس الكلام لو انا عندي ويك فرونتاليس قلنا وسترونج اوربيكولاريس في اللاترال بورت هحقنه زي البيشنت دي. مفيش عندي فرونتاليس قويه لكن انا هعتمد على اني اوقف الديبريسور. اتريست لازم اللاترال براو اليفيشن يتعمل. طيب البيشنت دي ظريفه جدا لها قصه، دي بروفيسور والبروفيسور دي مش عايزه ان شكلها يتغير لكن عايزه شكلها يبقى افضل شويه، عندها سيفير asymmetry وفي نفس الوقت الاي براوز شكلها فيري ساد. اتريست اللاترال اند اليفيشن والميديال اند اليفيشن لازم يحصلوا على ناحيه اكتر من ناحيه. طيب هل الميفيستوساين اللي موجوده دي مشكله؟ مشكله بس مقصوده، انا سايباها قصده عشان اصلحها بعد كده، يعني مش هسيبها لها بس لازم in the first visit لازم اقول للبيشنت انا هرفع بكل الطرق. وحضرتك ما تقلقيش لو لقيتي شكل الحاجه بتغير او اترفع او بقى شكله بايخ شويه، لما تجيلي في الريتاتش انا هظبط لك الحاجه اللي مضايقاكي، لكن سيبيني استخدم كل الاليفيتنج سكيلز بتاعتي وبعدين نحدد مع بعض هننزل ايه ونرفع ايه بعد كده، وبعدين نظبطها في المرات اللي جايه. بيبقى عندي فايل نشوف البيشنت حصل لها ايه، فبعد ما ظبطنا الميفيستوساين بقت هي elevated ولكن ايه اللي حصل؟ ما بقاش عندها ميفيستوساين. طب عملت ايه؟ حقنت في اللاترال بس ما حقنتش بقى فول دوز، حقنت هاف دوز وحقنتها انتراديرمال. البيشنت اللي شفناها الاول بتاعت الاوميجا ساين شايفينها بترفع، شايفينها وهي بتحاول تكشر الكونكشن عامل ازاي، وده الاليفيشن. بعدها حاولنا نرفع السايد اللي فيري داونوردز عشان يبقى زي الناحيه الثانيه. Thank you so much.
نيفين ما شاء الله it's so interesting، يعني رهيبة رهيبة. thank you قوي قوي قوي. ممكن نتنقل على طول لأخويا وصديقي وأشطر واحد في الدنيا دكتور أمين شروبيم، هيتكلم على safe injection strategies avoiding and handling adverse effects.
أنا هتكلم النهارده عن الكومبليكيشن، مش عشان أخدكم، بالعكس علشان نعرف إن كل الحالات اللي هنوريها it's treatable واتعالجت. بس I will ask you not to take pictures بس علشان دي sore patients. So we always receive a WhatsApp that's saying that doctor I was injected yesterday, I have a discoloration. So we always ask, is this a vascular occlusion or this is not a vascular occlusion, it's a single bruise. طبعا علشان نعرف ده لا ولا لا، احنا عارفين ان البروزنج can happen to 80% of the patient علشان this is the blood supply of the patient of the face. Usually اللي بيخلينا نفرق when we ask them these questions, is it a vascular occlusion, it's a bruising, is it immediate and severe والبروزنج في disproportionately severe pain, change in skin color, blanching, livido، ده كله بيخليني اشك يبقى لازم اقول العيان يجي علشان اشوف عنده sluggish or absent capillary refill. الكيموزز في شويه حاجات بنعملها بنقلل الاكيموزز زي ما احنا عارفين، كولد كومبريسز، الارنيكا، الاي بي ال، بي دي ال لو استمر، ولو بريزيستنت بنعمل بالس دايليزر. بس let's go to understand what's the blood supply of the face عشان نعرف ازاي هنعالج لو حصل vascular occlusion لا قدر الله من الفيلر، واحنا كلنا بنحقن فيلرز كتير فلازم نبقى عارفين ازاي هنعالج الفاسكولار اوكلوجن. So we know that زي ما احنا شايفين الفيس عبارة عن معمول عن حاجة اسمها انجيوزوم. So each part of the skin it is supplied by a unit called angiosome. These units اللي اسمها angiosome communicate between each other، بتتكلم مع each other بحاجة اسمها chalk artery. So if there is a problem here with the hyaluronic acid filler, so the chalk artery اللي communicate between two unit of angiosome will close. ليه will close? To prevent the propagation of the embolism أو to prevent إن الامبوليزم تمشي. وده اللي احنا بنشوفه بعد كده. So I inject in a blood vessel. When I inject in a blood vessel, الchalk artery ده الانستموزس بيحصل له vasoconstriction فبيقفل. فلما الفازوكونستريكشن بيقفل ما بيحصلش خالص ان البلاد فلو بيبقى موجود، فنلاقي ان احنا حققنا فاسكولار اوكلوجن في الليب بس هو مسمع لغايه النوز او مسمع لغايه الجلابيلا. So this is what happened. So I have injection of HA here and then the chalk anastomosis علشان sensed an embolus will stop all the way the blood supply فيحصل skin necrosis in all this area. So this is what we called the vascular occlusion اللي بيجي من الهيالورونيك acid filler can go propagate pathway على طول. They always have pain, pallor, livido face, slow capillary fill, blue grays, blue face. ده احنا شايفين أهم حاجة في دول pain and slow capillary fill and livido pattern. دي أهم حاجة اللي احنا بنشوفها عند العيانين دول. So they start to have blanching, then there is a livido. This livido ده جزء ان البلاد سبلاي الارتير بلاد سبلاي وقف، الفينس بلاد سبلاي فتح، عندي بكتيريال انفكشن، عندي كواجوليشن، عندي اسكر فورميشن لو اتساب. اقدر ان انا اصلح الكلام ده كله قبل بلاك كاش ديسكولوريشن؟ في حاله عندي بلانشنج وليفيدو باتر يعني within the first 24 hours I can correct this. So the safety measure, I want to put my needle or my cannula just perpendicular to the site of the blood vessel. And the most important to look at this diagram. Look, this is the 30 gauge cannula. It can penetrate the blood vessel. This is the blood vessel بتاع facial artery. It can penetrate it. Look at the 23 gauge. It's difficult to penetrate the artery. So 30 gauge cannula, don't use it. 27, don't use it. It is as a needle. The 20 gauge cannula, it's almost impossible in هي cannulate or penetrate the artery. What's the treatment? كله يصور دي. This is a very important. This is the new treatment. It is to use firm massage, apply heat, aspirin, antibiotic. The most important thing is to use the high pulse dose, هايرونيديز. يعني ايه هاي بالس دوز هايرونيديز؟ جاست ان انت هتجيب الهايرونيديز ال 1500 ملي international unit and you will dilute it on 1 to 2 millisaline not 5 ml زي ما احنا بنعمل. And then you infiltrated the whole ampoule deep and superficial, and I will show you why deep and superficial, in the all the area of the blood supply علشان نفتح الشوك vessels لو الامبولس بتاعت الهيالورونيك اسيد مشيت. And then you repeat this every hour up to 5 ampoule. Keep repeating it this every hour till you see capillary refill and it is resolved, and inshallah it will be resolved. It's very difficult that it's not resolved if you do this high pulse dulse hyalinase واللي احنا نعرفه how to use الهيالينase. So we flood the entire area of the vascular compromise at all depths. Why at all depths? Because hyalinase, it penetrates through the blood vessel wall and then it do dissociation لل hyaluronic acid cross linking. الكروس لينكينج يوجولي بيبقى ما بين الان استايل دو جلوكوزامين والجلوكرونيك اسيد. هم دول بيبقى اللي ما بينهم الكروس لينكينج. الهايرونيديز بيقفل الكروس لينكينج ده او بيكسر الكروس لينكينج ده، فبالتالي بيحصل ان الهايلورونيك اسيد اللي كان قافل البلاد فيسل بيبقى ديسسبيت او بيتكسر. So this is اللي احنا بنقول عليه degradation of HA filler material into small fragments، صح؟ علشان كده it can penetrate the blood wall. مش لازم تحط الهيالورونيك اسيد او الهيالورونيديز جوه البلاد وول. This is a very important، ودي حاجات جديده لسه نازله، البيبرز دي نزلت من 3-4 شهور بس. What to expect؟ خلي بالك monophasic filler are more aggressive, needs more aggressive approach and higher concentration. So we have biphasic fillers and monophasic fillers. على عكس المتوقع monophasic filler is much more difficult to be dissociated and it's much more difficult to be treated with hyaluronidase. So لو انت عندك monophasic filler, most our fillers اللي موجوده في السوق are monophasic. جوفيديرم، تيوكسان، ميرز، كلهم monophasic. It needs more. في حاجات biphasic it needs less. على عكس المتوقع hyaluronidase is more effective when you're using high G prime. When you're using low G prime, you need a lot more hyaluronidase. When you're using high G prime, you need less hyaluronidase. So you have to know these things علشان تعرف what you're gonna use. لو monophasic يبقى أنت هتدي hyaluronidase كتير قوي. لو monophasic وهاي G prime، وده أغلبية الحاجات اللي احنا بنستخدمها، you have to give the maximum of الهايلورونيديز بتاعك. So don't forget قبل ما نتكلم على الهايلورونيديز، قبل ما نتكلم that hyaluronidase على سيرة الأوف ليبل اللي قالتها الدكتورة رحاب، hyaluronidase can be used in other application. It has a lot of off-label use other than fillers. And this paper was published last month في November was published، وبتقول mainly على السكليروديرما وجرافت فيرست هوست ديزيز والسكليروميكسيديما، بس mainly على السكليروديرما. دي انجكت السكليروديرما للحالات المايكرو اوستيا مش قادره تفتح بقها and I found that they can open their mouth. فالهايلورونيديز بنستخدمه في حاجات تانية كتير. So the high vascular dose، انا قربت اخلص الفاسكولار دوز اللي قلنا بنستخدمها، we'll use زي ما قلنا up to 1 ml or 2 ml of the whole 1500 unit. يعني قصدي الأمبولة كلها زي ما احنا بنقول. و don't inject the glabella because the glabella, from injecting the glabella from the supraorbital or supraorbital artery you have a vascular occlusion على طول central retinal artery which is very difficult to be treated، وده اللي بيجيب blindness على طول. زي ما احنا شايفين this is retinal ischemia and this will occur blindness. عندنا this وانتوا بتحقنوا البالبيبومالار جروف وانتوا بتحقنوا التير تراف، خلي lateral part of the tear trough، خلي بالكم الزيجوماتيكو اوربيتال ارتري ده لازم يوز كانولا. if you injected this with a needle العيان بيجيله سكوينت تحول ان this is the artery اللي بيسبلاي all the recti muscle، فالعيانين بيجي لهم ساعات حول. I saw 2 cases of this. Blindness is there is a hope, yes there is a hope for blindness. Say there is a lot of units that can do catheterization، بتعمل قسطرة من الفيمورال artery all the way ophthalmic artery وتفك الاوكلوجن. And this is there is a lot of units in Far East that can do this. and this is زي ما احنا بنقول وانا بعمل لازم اقعد ادي اهم حاجه ادي الهيونديز زي ما احنا قلنا بالطريقه دي. This table summarize كل السايد افكت وسمرايز برضو من السايد افكت الفاسكولار اوكلوجن. اهم حاجه في الفاسكولار اوكلوجن زي ما قلنا هيونيديز، اسبرين، هايبر سكين مساج، ورم كومبريسز، انتي بايوتيك، مش مهم ان توبيكال نيتروجليسين. So these are some cases that were treated. This were احنا هنشوفها. So this was one case that was injected with filler ل ده الديستريبيوشن بتاع الانفيريور ليبيال ارتري. So حصل اكيموزس، حصل الاكيموزس. شايفين ايه اللي يخلي في الصوره دي نقول ان احنا عندنا فاسكولار اوكلوجن؟ الاكيموزس او البروزس are very well demarcated. When you find that the ecchymosis and the bruises are very well demarcated like this, and it is the bruises مكمل beyond the border of the lip, يبقى this means that this is vascular occlusion و there is pain. البيشنت دي مثلا ما قالتش ان هي عندها pain. ليه ما قالتش ان هي عندها pain؟ because كانت أول مرة تحقن في حياتها، ف she thought that the pain is normal. So don't get dissociated or don't get fooled by the pain. Look at the الشكل، الليفيدو، الكابيلاري ريفيل. سالت العينه تعمل، جيت شفت لها كابيلاري ريفيل، ما عملتش كابيلاري ريفيل. خدت هيونديز بالطريقه اللي احنا قلنا عليها، وان ذا سيم سيشن فور ذا سيم داي كان باين ان هو اتحسنت. وبعد كده this is the patient after 5 days. So another case, this patient برضه was injected in her lip. شايفين كل الانجكشن اللي في الليب اللي بيعمل vascular occlusion بيبقى فين؟ the lateral part of the lip. Because the lateral part of the lip, this is the most difficult, it's the most difficult part, or the most dangerous part of the lip. This is where the inferior and superior labial artery, they come deep, and then they come deep, then they come superficial, then they get deep. So it's very important that this where it changes its course. العينة دي زي ما احنا شايفين vascular occlusion, ecchymosis, very well demarcated, just beyond the order of the lip. لما نشوف حصل الشوك اللي انا كنت قلت عليه، افكشن وصل للنوز، افكشن وصل على افكت الكولومينال ارتري على اللاترال نيزل ارتري. the patient وصل للاوكلوجن، واصل للسوبير ليبيال، وصل كمان للانجولار ارتري، and then she was treated with the same routine, and then she was completely resolved without any scar except of some pigmentation. So don't forget, you have this case, you can have this case if you give her a good treatment. This is another case that was treated with injection of the pyriform fossa. So usually when you inject the pyriform fossa, you inject deep on the bone, but sometimes the artery، هو المفروض الارتري في الحتة دي ماشي midway or superficial. But even in some anatomical variety, كام في المية in 5% it can be deep. So you can inject it as well. And aspiration was done negative. So this patient برضو, she has a bruise very well demarcated beyond the level or beyond the area of injection. This is a vascular occlusion. Vascular occlusion, the worst vascular occlusion in the face you can have were two areas that are not forgiving. The glabella and the nasolabial. So the nasolabial, because it has a very bad perfusion, ده واحد. اتنين وده الأهم, there is no collaterals. So skin necrosis occurs quickly. But if you keep treating your patient with the hyaluronidase, like I said, not even 1 day but 2 days, every day 5 to 6 even ampoules, like you can see, this is the occlusion, vascular occlusion. عملت شوية اسكرز, and then she was treated completely with no thing except of some pigmentation. Don't forget that there is ultrasound guided vascular treatment with hyaluronidase. You can say, in this case, you can see that the blood supply with the Doppler is less. So you deliver under the ultrasound the hyaluronidase. This is cannot be done in dangerous area, or when you have your patient at your clinic and you just see vascular occlusion. You flood all the area with hyaluronidase, and then you have capillary fill, then use your ultrasound. But you cannot use your ultrasound تفضل قاعد بتدور بالالترا ساوند and takes for you مثلا 30 minutes 45 minutes till you find the Doppler and you find the artery. No, just flood everything with hyaluronidase, then use your ultrasound to be sure that there is the continuous of blood supply. Don't forget that the more than 100 of cases have been reported with history of facial injection can حصل لهم blindness. Blindness can even occur with fat, can even occur with intralesional steroids. So don't ever treat with cautious and with experience the most common area of blindness, which is the glabella and the nose. Nose, glabella, and the forehead, hemodal is the highest risk. When injection then less than 0.5 ml, even 0.3 or 0.2 can cause blindness. So if you are going to inject this area, just place small aliquots 0.1, 0.2 every now and then, or while you are injecting. Don't use boluses in this area at all. Thank you.
دكتور امين شكرا جدا جدا. يعني زي ما انت قلت انت مش قصدك تخوفنا بس احنا خفنا طبعا. بس لا it's really amazing and hopefully اي حد يحقن يبقى حافظ الكلام ده عشان يقدر يحقن very very safely ان شاء الله. Now يعني to our last and most distinguished speaker ever, Dr. Mu'taz Nusir, refining the jawline combined approach techniques. It's a pleasure, Mu'taz, always to listen to your wonderful lectures. Thank you so much.
بسم الله الرحمن الرحيم. ميرسي طبعا دكتور رحاب على الانترودكشن الخطيرة دي، وأحب أشكر كل الأورجنايزنج كوميتي لآدم. مبروك، وإن شاء الله كل الإيفنتس تبقى مكسرة الدنيا. I'm proud و honored إن أنا أبقى موجود مع اساتذتي في البانل دي. هنتكلم سريعا على الجو لاين، على اللور فيس، ايه التولز اللي ممكن نعملها علشان نحسن الاوتكم تو اور بيشنتس، ايه المانوفرز اللي نقدر نعمل لها كومبينيشن مع بعض. وهنعمل ده through الكلينيكال براكتس. دول 3 patients came to our clinic complaining من نفس الكومبلينت اللي هو we need a lower face enhancement. هنشوف ازاي how to deal with every patient differently. بداية قبل أي طبعا aesthetic procedure الأسسمنت is key. مهم قوي قوي نعمل assessment proper وassessment يبقى individualized ل every patient. الأسئلة المهمة قوي البيشنت candidate للسيرجيكال procedures ولا لا، لأن في أوقات patients مش هيستفيدوا قوي من النون سيرجيكال procedures، فلازم ده نبقى عارفينه من الأول. هل الميد فيس when it will be injected هل هيحسن وهيimprove اللور فيس appearance ولا لا؟ هل كمان هل البون حصل فيه resorption محتاج ان احنا نعمل restoration؟ وهل في الفوليوم او الفات compartments هل في redundancy في اللور فيس؟ هل في level مش هنقدر ان احنا to deal with it؟ واخر حاجه مهمه قوي how to deal with the skin to improve the overall appearance. طبعا اللور فيس عارفين ان هو integral part من البيوتيفul فيس. aging بيحصل through الفوليوم لوس، البون ريزوربشن.
بس الفيديو
زي ما عارفين الايجنج بيحصل على كل الليفلز، البون، الفات كومبارتمنتس، ماسلز، ليجامنتس وسكن. مهم قوي برضو نبقى فارقين الجندر how to approach ده بطريقه ولا ان احنا نعمل masculinization للفيميل فيسز ولا ان احنا نخلي الماسكولين فيسز تبقى feminine. ومهم كمان الريس، دي حاجه من الحاجات المهمه how to set the treatment protocol convenient each individual. لو اتكلمنا على الاناتومي البون طبعا في اللور فيس ماندبل للانفيريور بورشن والمانديبلر ريمس. حته لاند مارك مهمه قوي المانديبلر ليجامنت لانه posterior للانتيريور ليجامنت هيبقى فيه توزيع بطريقه معينه وانتيريور هيبقى مختلف. posterior بنتكلم ان في سكن، السوبرفيشال فات، بلاتيزمال دي فات والماسيتر والبريوستيوم، والانتيريور للسالكس سكين والسبكتينيوس فات والماسلز زي الدي او والبلاتيزما والديبريسر ليبياي انفيريورس، بعد كده الدي فات والبريوستيوم. الفات كومبارتمنتس السوبيريور والانفيريور مانديبلر فات بادز، السب مانديبلر فات كومبارتمنت، وكمان الفات كومبارتمنت الكفرنج الباروتيد ماستريك فاشيا. خلي بالنا ان اللاترال للسالكس السكن بيبقى لوس اكتر، كل ما نخش ميديالي هنلاقي ان الستراكشرز بتبقى سن ادهيزيف اكتر. الفاسكوليتشر مهم قوي، دكتور امين طبعا شرح كل الكومبليكيشنز اللي ممكن تحصل. مهم قبل اي انجكشن نبقى عارفين هاو تو ديل مع الكومبليكيشنز قبل ما تحصل. فيشل ارتري هو طبعا الاهم ارتري، بيخش في الفيشل زون ديب انتيريور للمسيتر، وبعد كده بياخد الكورس بتاعه. مهم كمان في التشن ما ننساش انه الفاسكوليتشر اوف ذا تشين is supplied بالمنتال ارتري، الانفيريور labial artery واللابيومنتال ارتري، السبمنتال ارتري، وكمان الاسcending mental artery. Patient number 1 mainly she's a young patient وكانت عايزه بس to improve the appearance of the lower face، عشان كده اشتغلنا على طول بالديرمال هايرونيك اسيد فيلرز. عارفين ان هي بتقدر تريشيب الجو لاين، تمبروف الفيشل كونتور. هنختار الريولوجي اوف ذا فيلرز السوبر امبورتنت، لازم نبقى عارفين الكاركترستيك بتاعت الهيرونيك اسيد، هعرف ابليس ات ديب، هعرف ابليس ات سوبرفيشالي. هنقدر نعمل ايه بالهيرونيك اسيد؟ نقدر ان احنا تريت المانديبولار انجل، ايذر ان احنا بن بريسايز او بنديتكت الجونيان انجل، بنخلي البيشنت تو تلت هير هيد باكوردز، نقدر ان احنا نحدد الانجل، نقدر ان احنا ننجكت ديب على البريوسيوم، او اوقات بنقدر نحقن سبكوتينيوسلي، بس لازم التشويس اوف الالاستيستي او الجي برايم اوف ذا فيلر يبقى كونفينينت للاريا دي. البري جاو ريجن كمان من الحتت اللي ممكن تبقى انجكتد علشان اكمل الديفينيشن اوف ذا لور فيس. التشن من الحتت طبعا المهمه زي ما اتفقنا ما بين الومن والمان، الويدث بتاعها الومن من الانتر كانثل ديستانس، والمان بنقدر ان احنا الويدث من الاورال كوميشر. كمان نقدر ان احنا نحسن الميليو لابيال جروف، لان ده بيدي يونيفورم شيب. اوقات كتير بنزود البروجكشن بتاعت التشن وبنلاقي الليبيو منتال جروف بيبقى اكسنتويتد اكتر. كمان الماريونات لاين من الحتت اللي ممكن ان احنا تو ادرست علشان نحسن الاوفر اول ابييرنس. هننجكت سلو، هنختار البروبر بلين، هنختار البروبر برودكت، وهنخلي بالنا من الساينز اوف اسكيميا او الساينز اوف اوكلوجن زي ما كان دكتور امين لسه بيتكلم. وهنا هنلاقي البيشنت she appreciated the definition in a soft manner، ما حصلش masculinization، و even حتى من الفرونت فيو. patient number 2 ابتدى برضو loss of definition خفيف، وكمان حصل زي بداية ساجنج خفيفة من غير ما يبقى فيه فات فوليوم كبير. وعشان كده هنبتدي نفكر في النيورو موديليترز زي ما كان دكتور رحاب تتكلم على الاوف ليبل يوز بتاعتها. هو ستيل النيورو موديليترز اوف ليبل في اللور فيس، فمحتاج ان احنا نبقى عارفين اناتومي بروبر وعارفين الدوزج بروبر، نقدر نستخدمه للبيري اورال لاينز، الباركود لاينز، دوزز صغيره فيري سوبرفيشال. الكورنر اوف ذا ماوس برضو من الحاجات اللي نقدر نحسنها باي انجكتنج الهايبرتونيا في الديبريسور انجلاي اورس، نقدر ان احنا نحسن بيها الكورنرز اوف ذا ماوث. هنخلي بالنا من الدبث اوف انجكشن والدايليوشن اوف ذا توكسين. هنافويد الهايبر دايليوشن علشان ما يحصلش ديفيوجن لمسل تانية. هنافويد التو هاي انجكشن علشان ما يحصلش انترفيرنس مع الاوربيكولاريس اورس، وكمان نافويد التو ميديال انجكشن علشان الديبريسور ليبياي انفيريورس. التشن برضو الديمبلينج اوف ذا تشن نقدر ان احنا نحسنها بالنيوروتوكسينز. وطبعا المسيتر من الحاجات الاسينشال نعرف نادرس بروبرلي، نخلي البيشنت تجرايند او تجز على اسنانها، ونقدر ان احنا نرسم اللاين من الاير لوب لحد كورنر اوف ذا ماوث. ما ننساش ان احنا نتاكل السوبرفيشال والديب اوف ذا مسيتر. والبلاتيزما هاو كان انجكت البلاتيزما بهانز، والبلاتيزما الموجوده عند الرماي نقدر ان احنا نتاكل الديبريسور بارت اوف ذا بلاتيزما. وده اللي احنا عملناه مع البيشنت، ان احنا حققنا البوتولينيوم نيوروموديليترز مع هيرونيك اسيد فيلرز، ساعدنا ان احنا نقلل الاماونت بتاعت الهيرونيك اسيد فيلرز، ونقدر ان احنا ناخد شيب بروبر اجان من غير ماسكولينايزيشن. بيشنت نمبر 3 في فوليوم او فات ريبوزيشننج اجريسيف اكتر شويه. انا كان بالنسبه لي بيشنت better to be referred surgery، بس البيشنت she's not willing to go under the knife ومش هتعمل اي حاجه ليها علاقه بالجراحه. عشان كده فكرنا ان احنا نشتغل باللايبوليسيس. طبعا ممكن تعمل through surgical liposuction او injecting لللايبوليتيك materials. في البيبر دي كانت very interesting علشان كانت معموله على نمبر كبير حوالي 1200 patient using deoxycholate acid و showed great improvement. ممكن كمان نستخدم الفوسفو برضو من الحاجات اللي تقدر تحسن. مهم قوي ان احنا نستخدم amount proper، نجراب the fat cells properly علشان نقدر نوصل ل results proper. ودي كان بعد 3 sessions of lipolysis plus النيوروموديليترز plus في الآخر using the hyaluronic acid fillers. Patient had a great improvement without again changing the features أو masculinizing of the face. مهم قوي كمان as dermatologist نحن نخلي بالنا من السكن by using topicals, laser treatments, energy based devices. كل الحاجات دي for improving the skin quality. microneedling radio frequency. كل الحاجات دي تقدر ان هي تشتغل على production of collagen. نخلي بالنا من السكين تايب الهاي سكين تايب اوف فيتسباتريك، لازم يبقى فيه برايمنج بروبر. الكيميكال بيلز برضو من الحاجات اللي ممكن تحسن السكين كواليتي، بس اجان سكين تايب الفيتسباتريك الهاي لازم يبقى فيه برايمنج بروبر ويوزنج اوف بروبر بيل ديبث. واخيرا الباي ستيميليترز زي الكالسيوم هيدروكسي ابيتايت والبوليلاكتيك نقدر ان احنا نحسن بيها الكواليتي اوف ذا سكين. conclusion طبعا مهم قوي assessment for any aesthetic procedure is crucial. knowing the anatomy, knowing the proper products used، واخيرا لازم نبقى عارفين الcomplications علشان نقدر نassess it و to deal with it once it happened. And thank you so much.
دكتور معتز رائع رائع يعني وانا دايما بحس ان it's one of the most difficult areas in neck والlower face يعني بالذات النك يعني فيعني ان حضرتك يعني اديتنا بريف على dermal fillers البوتولينم توكسين اللايبوليسيس البايوستيميليترز think يعني ربنا يخليك it was amazing. Thank you so much and by that we end the day وان شاء الله نكمل بكره مع بعض باذن الله. مع الف سلامه.